and research. The theme of today's conference is Controversies and Consensus, and this reflects the dynamic and evolving nature of neurosurgery. Progress in our field is often driven not just by established knowledge, but by thoughtful debate, critical appraisal, and the willingness to challenge existing paradigms. We are privileged to have with us today over 30 distinguished faculty and speakers who will lead discussions across a broad spectrum of neurosurgical topics, including neurotrauma, craniovertebral junction and spinal disorders, neuro-oncology, cerebrovascular neurosurgery, skull-based functional and pediatric neurosurgery. We hope that today's deliberations will foster a meaningful exchange of ideas and collaboration. We will start the day's proceedings with a prayer, followed by lighting of the lamp.
Shri Gurubhyo Namaha Harihi Om Gananantva Ganapati Gumhavamahi Kavim Kavinamupamashavastavam Jeshtarajam Brahmanam Brahmanaspata Shunvannoti Bisida Sadhanam Prano Devi Saraswati Vajebhirvajinivati Dhinama Vitrayavatu Ganeshaya Namaha Saraswatai Namaha Shri Gurubhyo Namaha Harihi Om Om Shanti Shanti Shanti.
We shall now have lighting of the lamp by our director, Dr. Sundaresh, our chief guest, Dr. Anil Nanda, and Dr. Sarita Aryan, senior consultant and head of our department.
Jyotirgamaya Mrityorma Amritam Gamaya Shanti Shanti Shanti.
I now request Dr. Sundaresh and Dr. Nanda to take a seat on the stage while Dr. Sarita delivers the welcome address for this conference today.
Sairam, distinguished guests on the dais, respected faculty, dear colleagues and students, good morning to all. With profound gratitude and joy, I welcome you all today as we celebrate two momentous milestones, the centenary celebrations of our revered founder, Bhagwan Sri Satya Sai Baba, and the silver jubilee of the hospital and the Department of Neurosurgery. 100 years ago, the advent of Sri Satya Sai Baba marked the beginning of a transformative movement rooted in love, unity, and selfless service. His teachings resonate through all of us that education must build character, healthcare must be offered with compassion, and most importantly, service to man is service to God. This hospital, as one of the institutions he inspired, stands today as a shining beacon of these ideals. 25 years ago, guided by that same spirit of dedication and excellence, our Department of Neurosurgery was founded. It has since then evolved into a center of advanced clinical care and academic rigor. Over the decades, the department has not only treated complex neurological disorders, but has also trained generations of neurosurgeons, who can carry forward the principles on which this education was founded upon and blend skill with empathy in treating patients. This conference is not only a celebration of past achievements, but also a reaffirmation of our commitment to the future, to ethical practice, excellence in work, passing on knowledge, and above everything else, patient-centered care. I hope that Swami's centenary inspires all of us to renew our dedication to values-driven service, and that the occasion of the 25th year of the Department of Neurosurgery energizes us in our commitment to helping patients and guiding doctors towards excellence. May this conference foster meaningful dialogue and collaboration and be a compass guiding us to the next quarter century of achievement. It is my great pleasure to warmly welcome our honored speakers and all the delegates, alumni, and the students who have gathered here. Your participation adds meaning to this gathering and strengthens our collective purpose. Thank you all for coming.
Om Shri Sai Ram. Surrendering myself at the divine lotus feet of Bhagavan Baba. It's an honor to be here amongst all the luminaries that have joined to share their knowledge in the field of neurosurgery. 25 years ago, this institution was started, and the neurosurgery department was led by Dr. A.S. Hegde, a renowned neurosurgeon, and he has taken it to heights which are difficult to match going forward. These healthcare institutions of this is Sri Satya Sai Central Trust, which is the founding body of these organizations, was started 70 years ago. The small hospital at Puttaparthi to render primary care to the village of Puttaparthi, which is about 3 hours from here now, but then it used to take almost 8 hours. Was essentially meant to be a maternal and child health care where no medical facility was available within 100 kilometers of the place. That also was a completely free hospital. A few years later, in 1990, Bhagavan Baba declared that he's going to start a super specialty hospital at Puttaparthi, a village which people are fond of referring to as a stone's throw away from Stone Age. That's how remote it was, with no connectivity whatsoever, and a hospital with facilities for cardiac surgery was being planned there. A lot of people thought it is not a good idea and that it may or may not survive for long. In 1991, that hospital at Puttaparthi was inaugurated, and the building, which is about 3 lakh square feet and built like a palace, was constructed in 5 months' time. On the 22nd of November, a day before Bhagavan Baba's birthday, the first cardiac surgery took place there. And even that was a completely free hospital. A lot of people questioned the idea of a free hospital and made bold to suggest to the divine that you should take money at least from those who can afford it. Of course, in his own divine vision, he had other plans and knew that this is going to survive. In 2001, exactly 10 years later, this hospital was inaugurated by the Honorable then Prime Minister Sri Vajpayee. Again, 100% free hospital. When it started, it essentially catered to neurosciences, is neurology and neurosurgery and cardiology and cardiac surgery. All these institutions have stood the test of time and survived and thrived, not only survived and thrived, for over 70 years now. And in this centenary year of the birth of the Divine Advent and the 25th anniversary of this hospital and the Department of Neurosurgery, we pay our respects and gratitude to the Divine Founder. The difference is not just about the money. It's always conceived that anything given free is always of a lower quality than when you pay for it. Time has proven that this is not true in any of these institutions. The people who have worked here are testimony to the fact that we have the best equipment acquired at great cost to facilitate the most appropriate and best treatment to the patients who seek relief from this hospital. Not just the equipment, it's also the people behind the equipment. We have the highly distinguished faculty in all the departments here who have dedicated their lives to this institution and the patient care here. A word about Dr. Hegde, which is appropriate that we remember him today. He is unable to be here physically, but a great man. I was aware that he was a very efficient and a proficient surgeon for aneurysms of the brain, in the brain. This department has grown with the help of Dr. Hegde. In my own time as an orthopedic surgeon, I used to do a bit of spine surgery in the Ramaya Medical College where I trained, where I worked. At that time, we used to envy this hospital because this is the first institution in the city to have a neuro navigation unit. Even, I don't think even Nimhans had it. And we had the most advanced MRI at that time and the CT scan as well. And the thing that was remarkable here was that the neurosurgeons here were blessed to use all Medtronic implants, which were extremely expensive, and there was no other option for us. We used to use I have done some spine fixations myself also, but we used to use some local implants. And that is the kind of care that is being given here even today. There is no compromise in the quality of care. And the people who support this are the professionals. And I congratulate all the professionals and the staff in the neurosurgery department for giving their lives to the care of patients in this hospital. I can see a tremendous effort which has gone on behind the scenes in organizing this meeting. And I'm glad to see a lot of very eminent faculty here who have come to share their knowledge with all the delegates and the guests. I'm sure it will be a learning experience for each one of us. I wish the conference the very best and hope you enjoy your stay here. Jai Sai Ram.
Thank you, sir. Dr. Sarita will now retake the stage to deliver a few words of appreciation for our founding chairman, Dr. A.S. Hegde, whose vision and perseverance built this department brick by brick, transforming it into what it proudly stands as today.
Thank you all for this opportunity. I would just like to briefly mention what Dr. Hegde means to us. Dr. A.S. Hegde, or Chief, as we fondly refer to him here. He was born in 1952 and completed his MCH from NIMHANS in 1981 and was conferred the best outgoing student. Was awarded a doctorate in medical sciences in 1988. He worked in NIMHANS as faculty for a decade and did a microneurosurgery fellowship under the legendary Professor Sugita in Japan, and also completed his PhD during this period. These are some of the photos of Dr. Hegde during his stay in Japan, with his wife also, Dr. Sridevi Hegde, with him. A brilliant illustrator, some of the drawings of his intraoperative aneurysm surgery findings were incorporated in Professor Sugita's books. I remember in some of the many conversations we had, he would tell me, you have to study the angio and visualize the aneurysm and its surroundings in your mind before you start the case. He learned it from Professor Sugita and passed it on to so many of us. After leaving NIMHANS, he founded the neurosurgery department at Manipal Hospital, HL Road, Bangalore, and joined the MS Ramaya Institute in 2012 as Director of Neurosciences, from where he superannuated in 2022. In 2001, Swami called him and instructed him to set up a world-class neurosciences department in this hospital. Chief was chairman and HOD neurosciences here from 2001 to 2012, and the director of the institute from 2006 to 2012, and emeritus chairman from 2012 till date. It was on his watch that 4 fully fledged operating theaters were set up here, with the latest operating microscopes, fluoroscopy, ultrasound, and an angio suite. The department was the first in the whole of Asia to get a neuronavigation system, which has now become a standard of care in neurosurgical procedures. 2 years after the department was set up, Chief organized the Skull-Based Society's International Conference here. Here he is seen with some of the dignitaries from the conference, including R.N. Varma, sir. And this is Chief at the conference with a much younger version of our other patron, Dr. Anil Nanda. These are the doctors at the department with Swami. And Chief with the senior nursing staff here when he was director of the institute. Cerebrovascular surgery was one of Chief's favorites, something he carried forward from Professor Sugita. He had many pioneering surgeries to his credit, including being the first neurosurgeon to operate on giant aneurysms under hypothermia and circulatory arrest. He operated on more than 1,400 aneurysms and has the largest series on giant intracranial aneurysms. He has a huge number of publications in his name, and in 2003 was bestowed the Karnataka Rajyotsava Award. This is Chief with his family. His wife, Dr. Sridevi Hegde, has been his pillar of strength through all his highs and lows. His Dr. Nidhi is the executive director of the American Economic Liberties Project, a nonprofit organization based in the US. His son, Nishit Hegde, decided to carry on the legacy and is now a consultant neurosurgeon at Manipal Hospital, Bangalore. Today, it is both a privilege and a deeply emotional moment when we honor the founding head of our Department of Neurosurgery. Sir, you have built not just a department, but a culture of excellence, compassion, and integrity. As a surgeon, teacher, and mentor, you have touched countless lives, patients and students alike. On behalf of all of us, I thank you for your guidance, inspiration, and dedication. We are proud to be your students and honored to carry your legacy forward. Dr. Hegde is unwell and cannot join us today. Dr. Nishit Hegde will receive a token of our heartfelt gratitude and appreciation on Chief's behalf. I request our director, Dr. Sundaresh, to present Dr. Nishit with the memento of appreciation. Thank you all. Sorry.
Thank you. It is now my privilege to invite Dr. Anil Nanda to deliver the keynote address as we kick off today's scientific program. Dr. Nanda, of course, really needs no introduction in any neurosurgical forum. At present, Dr. Nanda holds the prestigious role of chairman at the Department of Neurosurgery at Rutgers in New Jersey. To call his contributions to academic neurosurgery anything short of immense would still be an understatement, and the corpus of his academic work in the domains of skull-based neurosurgery, cerebrovascular surgery, and neurosurgical oncology have influenced and will continue to influence generations of surgeons to come. However, Dr. Nanda is known perhaps more fondly in this corner of the world as a longtime patron of this institution since its earliest days. As a guide, mentor, and friend of our Department of Neurosurgery, he has provided unwavering support at every step of the journey that has taken our department to where it is today. Dr. Nanda, the stage is yours, sir.
My humble pranams to the lotus feet of Bhagwan Baba. I would start with a very personal note. I was, I think, 21 years old. My brother was getting married, and Bhagwan Baba was in the interview room. And I was kind of deciding between cardiac surgery and surgery. And he came to me and said, "Neuro karo, time lagta." And, you know, I didn't deserve such grace. I was not worthy of it, but it was a life-changing thing. And I'll always, always be eternally grateful to him. So nothing that I can do in terms of service, academia, can match his overwhelming grace for me personally. So I'm truly overwhelmed to be here. I'm very grateful to be here. And I think this is an amazing opportunity. I think I was here for a skull-based meeting a while back. Great to be in Bangalore. To me, of course, the highlight of Bangalore is the Sri Sathya Sai Institution. And I think, you know, I would be remiss in not paying tribute to Dr. Hegde. He was an amazing teacher, a very good technician, a kind soul, and I'd known him over several decades. And I want his son to know that our prayers are always with your father. He was an amazing giant, and, you know, his role will be unsurpassed by anybody. And we were privileged to know him, and I think Bhagwan did picked the right person for the job, and he knew it would be a phenomenal thing. So I would be remiss again in not recognizing the leadership here. I think Sumit and Sarita are like the Kundalini of the neurosciences here. They've done a great job. You know, Sarita was loved at NIMHANS, and I can tell you Sumit's chair, Dr. Vedantam, whenever I meet him, says, "Oh, Sumit's a great guy," and we all agree. So Sumit, thank you again for doing everything. I think, you know, the one thing about our Indian culture is that there's always a sense of deep and profound gratitude. And the Upanishads told us this thousands of years ago, Matru Devo Bhava, Pitru Devo Bhava, Acharya Devo Bhava. I went to Jipmer, and my sort of, you know, I would do Sashtang Namaskar to Dr. Chandrasekhar, who was an amazing neurologist who inspired me. And of course, the legendary Ramamurthy, I got to see him when I think I was 18, and my father took me to meet him. My only regret was that I didn't do a Sashtang Namaskar. He was an amazing teacher. These are obviously my parents and my teacher at St. Columbus High School, and obviously Bhagwan Baba. So I picked a topic about meningiomas, and I wanted to talk about the diabolical versus divine. I have enough gray hair that I can recount the disasters I've been through and the triumphs, and I think I can talk about it perhaps with some sense of profound humility. The story of Icarus is very well known for hubris. Icarus thought he could fly, and he flew too close to the sun, and the wax melted his wings, and he fell. That was a diabolical event. But the divine, as exemplified by Bhagwan Baba or St. Francis of Assisi, is that even when you think you've not done a great job, the outcome is fantastic. And I'll show you some cases. And that's where I feel there's the chasm. We're good, we're not that good. And things can go wrong. And so I think that profound sense of humility to approach our craft with almost a devotional worship, to say, we who are blessed to operate on the brain have done Jam Janmantar Punya to deserve it. Every time I see the brain, I still think of Bhagwan Baba and the opportunity I was given. Because I tell the residents, interns, I said, every time I split the fissure, like, my God, can you believe they pay us to do this? It's an amazing gift. And I think that awe, that sense of awe of what we do should never be lost, because then we become cynics. And cynics have no heroes, okay? So I think we need to have that sense. And I always start my talks with Krishna. We had a wonderful prayer to Ganesh, Lord Ganesha, and I always say I'm a Shiva Bhakt, so I'm going to Kashi Vishwanathan and Puttaparthi. But the wonderful thing is he was probably the first neurosurgeon, because he does a head transplant on Ganesh. So I always say he's the patron saint. Whether you're a Vaishnavite or a Shaivite, you have to acknowledge that, yeah. So a little bit about meningiomas. Meningiomas are the most common CNS tumor in the United States. 40% of all tumors are meningiomas, and we know they're more common in women. It's about 2 or 3 times more common, and it has something to do with hormones. So when you look at epidemiology, as we get older, you see more meningiomas, and incidence increases. Women, as you know, are 2 or 3 times more likely to have it. And if you look historically, the first known meningioma is almost 300,000 years old, not a millennium. But you can see this skull. This was discovered near Steinheim in Germany. It's called the Steinheim skull. You can see that you have this growth there that was resected. We published a paper on Felix Platter. Just for the residents, it's always good to write historical papers. And I would urge you guys to write a paper about Professor Hegde's legendary complications. I think that would get published. And if you want, I'll help you with that, because he truly deserves that, yeah. And then this is first Zanobi Piccioli, who first described it. This is an AI picture that was taking it out. And then there were many names for meningioma: fibroblastoma, duroblastoma, meningeal fungus thing. It was the great patron, as Bhagwan Baba, the patron saint of us here for his centenary, which we are so grateful for. Harvey Cushing was our patron saint of neurosurgery. And he comes up with the name of meningioma. So all other names go away, and meningioma comes in, and that's sort of a great start, yeah. Now, when you look at the grades of meningiomas, you can see grade 1 is still the commonest, then you have grade 2, you have grade 3, and it's a very good survival, 5-year survival, 92%, malignant obviously less. But if you look at the risk factors for this, there's a lot of risk factors you wouldn't realize. I think hormonal take, and then radiation. If you look at what happened at Hiroshima and Nagasaki, if you were within a kilometer of Hiroshima or Nagasaki, your incidence of meningiomas went up significantly. So the moral of the story is, don't live in a nuclear explosion zone. Just a little proviso. And if you've been to Hiroshima, you will see this powerful watch there when the bomb goes off, frozen time at 8:15. And it reminds all of us the dangers. I don't know if you saw the Dynamite movie about nuclear attacks. I think we still need to be vigilant socially about all the risks, yeah. So here we can see, this is a study that we're doing right now on Depo-Provera. So Depo-Provera is a form of injectable birth control. And it's given to largely in America to poorer women who are homeless. So they get this Depo-Provera once a month. Well, lo and behold, the French came and said, you take Depo-Provera, your incidence of meningiomas, especially in the skull base, goes up 5-fold. So this has become sort of a burning issue. This was a study that Alan Weil did from France, and they found that 5 to 6 times, the odds ratio is 5.6, if you had taken Depo-Provera. This also was duplicated by the Swedes. Thies Matheson did this paper. And we are actually doing a meta-analysis on this. And the sad thing is, again, it's a social relevance because the women that got this were largely homeless minority women in the ghettos of America that were getting this, and their rate of tumors is significantly higher. So we're doing this study. My own career, I've been great. You know, I've done almost 20,000 surgeries now. With the grace of God, I still operate. And I thought I'll just tell you a little bit about meningiomas. You know, the way we report them now, I think the molecular diagnosis has become important, and the gene penetration is important. So, you know, if you asked Cushing, and I'll sort of end with that when I tell you that this was the apotheosis of our art. Taking a meningioma out is one of the greatest thrills of neurosurgery. For the residents, I will tell you, you will enjoy this for the rest of your life. There is nothing that comes close to the triumph of removing a convexity meningioma. Patient is cured, seizures are gone, they do great. And I think that's what our art starts with that. It's slow, there's an arachnoid plane. But I think anatomy is necessary. If you're going to do petroclival meningiomas, you're going to do other meningiomas at the scaly base, you should know your anatomy really well. So I always tell the residents, go back to the anatomy lab, dissect again, make sure you know your anatomy, because otherwise you can get lost and not sure what you're doing. But it can also be diabolical. I mean, in the cavernous sinus, and I'll show you disasters in the petroclival region, or other places that you can have bad results. Petroclival, cavernous sinus, venous invasion, all those things hurt us. But I think the anatomy is still key. I think all of us, no matter how old we are, we need to respect and have a sense of worship to the anatomy of the brain. Because if you don't know the anatomy, you're going to get into trouble, and it, you know, it's not going to be great. Now, what about the complications? And I have arterial injury, cranial nerve deficits, CSF leaks, edema. These are sort of the diabolical aspects of what we do, and it kind of reminds us why we should worship at the altar of our craft. We say, listen, we want to get good results. What will it take for us to get there and improve? Yeah. And, you know, it's always an ego check. And I think during the Iliad, when they told Odysseus, you can choose between glory or you can choose between a journey home. So it was between Kleos and Nostos. Nostos was nostalgia, you go home safely. Kleos was glory. And we all know Achilles chose glory. So in neurosurgical parlance, glory is having a great looking post-op MRI. Okay, 10 centimeter tumor, completely gone, patient looks good. But how's the patient done? And sometimes our temptation is to go show great pre-op and post-op scans, but not look at the quality of life. And I think therein lies the sort of challenge. So I'll go through some. This is sort of a classic meningioma that I think is the triumph of our art. You go on the plane, patient does great, goes home. And this is sort of the divine nature of what we do, that we can be healing angels in a disease that can be a lot worse. Same thing with intraventricular tumors. You know, you go in from the side, you take this out, or even interhemispheric tumors like this one, where you go from one side and you can resect the whole tumor with a good outcome. Now, just historically, Durante in Italy and Sapienza University was the first one to publish a skull-based resection tumor. It was a meningioma, patient survived, had a recurrence 12 years later, was published in Lancet. And it's a great paper that I urge all of you to read, because they didn't have the microscope, they didn't have the stereotactic system, and they didn't even use gloves. And yet they had a great result. So sometimes I think we should honor that, yeah. Now I'll take you on a quick journey, a little bit about my experience. This is my experience with anterocranial-based meningiomas, now close to 200 cases. Obviously more females, and I always go unilateral. I mean, I would do a carpal tunnel tear only if I could. I don't like to go bilateral. I always go from the side. I don't like to hurt the other frontal lobe. We looked at these. We actually did a study to look at changes, T2 changes on MRI post-op, and clearly there was a difference. If we'd done neuropsychological testing, I think that would have also helped, but this is what we published, and you can see here a frontal large meningioma, and we looked at the T2 changes on MRI. Again, with olfactory groove meningiomas, these tend to do well. We get complete resection on these with good outcome, and I think they're sort of the more divine tumors we deal with. But when you come to other areas, again, with tuberculum cellae, here's somebody with a large meningioma. And you know, this is the social aspect of what we do. This is a woman that had recently got divorced, was not getting along with her parents. Nobody done a scan on her, did a scan on her, and you can realize she had bad cognitive changes. You know, this is a large tumor. Let me work. So you can see this. Again, I went unilaterally on this. People would say, why didn't you go bilaterally? I didn't touch the other side at all. You can see it's pretty big. So I came from the left side, but it's bigger. And move this on. It's supposed to be PD. But you can see here, we're peeling the tumor off. There's the internal carotid. And you can see now that we're seeing the anterior cerebral, internal carotid, MCA, ACA. This labeling was actually done by NIMHANS alumni. A lot of NIMHANS alumni here, but you can see here. And we're removing the tumor with this. And then we also went transcortical just to take out the part. We did all that. And then in the last part, you can see here, we're near the anterior cerebral, and here's the thing, and we're right here. And you know, I always open the lamina terminalis. That's something I always do for any case. There you can see lamina terminalis is open, and then we're peeling the rest of it off from the ACOM complex. And again, if there are perforators there, you want to be really careful that you don't sacrifice these perforators. So here it is, off the A complex completely, and we got a complete resection on this. Now, this was a grade 2. Our radiation therapist wanted to sort of radiate her, and I'm like, no. What's fascinating about this case is, you know, her life was a mess. She made up with her parents. Her parents were so grateful she's back. And sometimes we're judgmental about people, and we don't know what they're going through. Nobody knew she had a 10-centimeter tumor in her brain that was causing the cognitive issue. This was completely clear. So I think, you know, as much as we worry about the diabolical aspects, but I think technical virtuosity is something that we should pursue. I would tell all the residents that you want to be a master technician. You should aspire to be a master technician. And you should constantly reevaluate your results. Look at your videotapes. That's how you become good. And that's how these are masters in whatever field they go, whether it's painting or that. Here's some more of these that are removed unilaterally. Hemangiopericytoma, you remove unilaterally. And then clinoidal meningiomas. Again, these cannot be removed endoscopically, and the vision is an issue. So I'll show you this one. I don't touch the optic nerve at all on these. You can see I'm just peeling this off. You can see the vessels there. But I try not to touch the optic nerve. In my series, I've had about 10 cases where the vision got worse. Now, in about 30, the vision got better. But if it gets worse, it's normally some small blood vessel on the optic nerve that you affected. You want to be cautious about that. So you can see here, we want to take the entire thing off, and this was a good outcome. I think the cavernous sinus, we did a historical paper on the cavernous sinus, why it was a misnomer, because it's not a cavernous area. We published our series on this. Now there are over 100 cavernous tumors, meningioma, but this is a little more diabolical. This is not an easy tumor. You can really hurt the patient, give a lot of cranial nerve deficits. So I'm a little cautious on this. This is one that was easy. Sometimes it's like very soft and it comes out. And this is one of those cases, went really well. No problem at all, and it's a post-op MRI. But if you have something like this, you know this is a diabolical tumor. You're not going to get this out, okay? Now, when I was a resident, we did attempt to do these, We would do a saphenous bypass graft, and we would give them a royal flush. All cranial nerves are out, okay? These people got trachs, they got G-tubes, and they never got better. So sometimes in our obsession with sort of having a great result, you can really hurt somebody. So we moved away from that. We said, no, this is not working. And we looked at these, and what we found was that if you gave radiosurgery up front, your recurrence rate drops dramatically. So we gamma knifed them. This shows you the difference in the graphs between radiation and not radiation. And again, complete resection, only 41.5%, you know, and this is honest thing. You know, I get suspicious when somebody puts a paper out in our hands, 100% of the tumor is removed. A little pushy, you know what I mean? It's not really hard. So we did gamma knife, radiosurgery, and again, the follow-up results are excellent. So I am a believer in that. This was, Karolinska also agreed with this, doing radiation. It works well. But, you know, if I had to name a tumor that's really bad, I would say it's petrofibromatosis. So the Italians, Briccolo's group, once put it that they had never operated on a petroclival meningioma without making the patient worse. And I really admired their honesty because they told the truth. You know, you go in there and the brainstem and all, it's not going to be fun. So these are my results. I looked at now something like this was a soft tumor, okay? If it's a soft tumor, this is, you know, this is not a problem. It becomes divine. So this, you can see, it's a very soft tumor. It's peeling off beautifully. There's a nice arachnoid plane. You'll see the fourth cranial nerve here. We'll see all the nerves very well, you know. And you can see here, I like to devascularize it right at the petrous apex junction and the petrous bone. So you can see we're doing that with a real clear cut. There's the cranial nerve. We're peeling it now off the 7th and 8th cranial complex. And you can see I'm pulling it off that. Now I'm pulling it off the brain stem. And again, we're not touching the 7th and 8th cranial nerve. You touch it and you'll get paralysis. So I'm like manic about not touching it. The trigeminal nerve is a little hardier. You can sort of finagle around it. So you can see here, this is the trigeminal nerve. You can see how stretched out it is, twice the size that it should be. But the trigeminal nerve is much hardier. It can take this a little bit better. But we were able to remove it completely. And you'll see the fourth cranial nerve up above, slightly higher. She did really well. You can see she's now 15 years out. She had a small residual in the cavernous sinus. The gamma knife that. No deficit. She did really well. Another petroclival meningioma. Let me see if I have these. This is a trochlear, more high petrous, small lesion, yeah. You can see, you could say you could radiosurgery this. The patient wanted, she was young, so she wanted to go for surgery. And this one you can see was quite adherent to the trochlear nerve. And you can see how the trochlear nerve is so thin. Soft tumor, not that soft, but firm. And you can see we're moving up. And as you come up higher, we'll see the cranial nerve, the fourth cranial nerve there, very thin cranial nerve. So the trochlear nerve is the most susceptible. So if you're going to have that, here it is. You can see the trochlear nerve right there at 3 o'clock position. See that? And you can see how easy it is to take it. I mean, you can go, you're going fast or whatever. So anyway, we were able to save her. And again, I talked about Kleos and Nostos, when Achilles has to choose between glory of a safe journey home. And I think for neurosurgeons, this is an eternal struggle. Where do we go for broke, end up harming the patient, or where do we go where we think we'll do a good job? So that balance needs to be there. I can tell you in my series, complications are significant. You get third nerve palsy, and we should talk about them. Yesterday, I gave a talk on complications in NIMHANS, and I sort of bared my soul. These are all 18,000 surgeries. This is all the disasters that have happened. And it happens to all of us. This is our study that we published, and I was recounting this yesterday just for the residents. It's important to publish, okay? It is important to write. You're privileged to be in a great institute. You're privileged to enter a great profession. You're privileged to practice a great profession. And a way to give back is to write about these things. When I was the program chair, I told the residents, you have to publish 2 papers a year. And I would put somebody on probation if they didn't. I'm like, you got to publish. That's what it is. So this paper was published. I was operating in Kuwait. And the neurosurgeon comes up to me and says, listen, I just want to thank you for your paper. I'm like, why? He says, I was sued for a petroclival meningioma, but what saved me was when you said in your hands, your complete resection rate was 28%. That's what saved me. And so I felt really deeply, we published because of Lord Saraswati, okay, as the goddess of learning, her blessings, you do that. So I kind of felt good that, listen, this is the right thing to do. And that's why I published complications, and because this stuff happens, people say, oh, this doesn't happen, it does. Now, I will say when you come down to tumors in the foramen magnum, they tend to be fibrous. I don't know if this is a movement, but these tend to have good results. They don't do bad at all. You can see a resection here. So I'll move quickly now to Simpson grading system. So we looked at close to 700 meningiomas, and this was our paper, and we showed with skull base, again, the Simpson thing was relevant. And most of you know the Simpson grading, and it was devised in 1957 when he was in England. And I showed this yesterday as well. So another reason why we go into academics, why we publish. So I thought Professor Simpson was dead. I'm like, this guy's gone, So then I get a letter from Australia, and he sends me this letter. He says, I'm 89 years old, I'd had a stroke, but I enjoyed reading your paper on meningiomas. I understand you're going to give an oration in Melbourne. I won't be able to come because I'm not in great health, but maybe we could talk about meningiomas. This is such a beautiful thing. Here's a guy who's 89 years old, wrote a landmark paper on meningiomas, and still cares about it. It's not like he's like, I'm 89, I'm going to go to Brahmalok now, I got to figure out what I'm going to do. He's like, no, I still like the academic life. I like to read these papers. And I think that's one of the secrets, is that you keep yourself intellectually involved, and you keep thinking of new ideas. Like we are now doing this whole study in Depo-Vera. I think I would tell even the senior neurosurgeons here, pick an idea, something that, oh, this interests me, and think, maybe I'll write about this, maybe I'll write. And, Sri Sathya Sai Hospital done that. Sumit's done a great paper on telemedicine with Orissa, which was published in Neurosurgery. So those are important contributions to science that I think help all of us move forward. So these are some of the papers, have a ton of publications on meningiomas with different things, but this was the study that we published that Simpson talked about, meningiomas arising in every area. But I think the important thing is self-reflection. Okay, you have to be a master surgeon, we all make sacrifices. Dr. Hegde was a phenomenal surgeon. Why? He looked at his mistakes, he looked at his videos, he trained with Sugita. Sugita was a master surgeon, drew everything. And I think Rembrandt was like that. Rembrandt never showed himself as he was aging. I think Sarita showed a picture of me from 20 years ago, my hair was all black. And we changed, So here's Rembrandt, and he shows himself without Botox, without a facelift. This is who I am. And I think as neurosurgeons, we need to remember that. We need to be really honest. You know what I mean? What have we learned? What you don't want to be like Picasso. Okay, they call these cubist pictures that don't make any sense. So sometimes neurosurgeons become diabolic, and they're like, oh, we have no complications. Everybody went home post-op day 2. Like a little bit of a stretch there, yeah. But to the residents, I would say this is the Czesław Miłosz was the Czech poet who got the Nobel Prize in poetry. And he said, in a room where people unanimously maintain a conspiracy of silence, one word of truth sounds like a pistol shot. That pistol shot is divine, okay? And I would urge all the residents, when you see something like that, you have to tell the emperor he has no clothes, okay? If we don't do that, then we're not doing good science. We're becoming hierarchical organisms, and we're just following orders. And you know what lemmings do? They keep following their guy, and they all jump off the cliff. You don't want to jump off the cliff. You want to question what's happening. Well, I don't agree with this. I've done 5 of these with you. Every time we had a complication, And that applies for the diabolical nature of what we do. This is the petroclival meningioma I did in emergency room medicine. I was pretty happy. I took this whole thing, 90% out. The guy had an apraxia. He was not that good with the right side. He could never go back as an ER physician. So I could come and tell you this is a divine thing. Look what a great job I did. But in my heart, I know I failed this guy, Maybe I should have stopped earlier. He didn't go back to what he did. And that happens to the best of us. So that's the diabolical nature of meningiomas that you have to be aware of, where you push it too much. And it doesn't have to just be our technical skill set. This was a meningioma I removed, complete resection, no deficit. 3 weeks later, he's in rehab. He gets C. diff. He goes into sepsis and he dies. Okay. Now, can I say this was not my fault? No. I operated on him. He wouldn't have got C. diff if he'd not gone there. He died. So that's sort of the diabolical nature of what we deal with. And I think that's important. And I love this poem. This is Agamemnon's poem. Actually, when I think of the first skull-based meeting, I kind of quoted this, that, you know, God whose law it is that he who learns must suffer, and even in our sleep, pain that cannot forget falls drop by drop upon the heart, and our own despite against our will comes wisdom by the awful grace of God. It is these diabolical tumors that give us the wisdom to say, no, we didn't do the right thing. We hurt the patient. And I think that balance is important. And the second victim syndrome is very important, okay? There's 3 victims of the complication. The first victim is the patient. Second victim is the surgeon who loses sleep about what happened. And the third victim is the hospital itself. Now, there was a nurse in Seattle. She gave a child a wrong medication. The child died, all right? 2 weeks later, that nurse committed suicide. So the second victim syndrome is happened a lot during COVID. There was an emergency room physician at Columbia, very talented, he committed suicide. So I think the victim syndrome is important. And again, I showed this one yesterday about Robert Liston. Robert Liston did the fastest amputation during medieval Victorian England. So he did an amputation, and Dr. Sundaresan will appreciate it. He's an orthopedic surgeon. So he did an amputation in 47 seconds. Well, the patient died. He cut his assistant. So the assistant died, went septic and died. There was a woman in the audience that got a heart attack looking at this, and she died. So 3 people died. That's like 300% mortality. So if you feel bad about yourself with a complication, think of Robert Liston. He had it much worse, yeah. But I don't think he lost any sleep. So I think just to sort of wrap up, you know, our goal is to do no harm. You know, I think the natural history, and we see this now in the United States, that everybody, the smaller and smaller aneurysms that are unruptured are being treated. Chris Ogilvy from Harvard had a paper that showed that every 5 years, unruptured aneurysms go down, indications go down by 0.5 millimeters. So in 25 years, you go down like 2.5 millimeters. So all of a sudden, like 3 millimeter aneurysms are being treated. It's not good. And you know, salve lucrum, if you look at the ruins of Pompeii, one of the things they found was salve lucrum, which is Latin for profit. And that's become the healthcare modus, salve lucrum. And if anything, this hospital and the centenary of Bhagwan Baba's birth and the 25 years, if anything, this place is anti-salve lucrum. There is nothing about profit here. This place has no billing department. They have the best equipment. And I think we need to give a big round of applause for that. They've done a great job. And it's you know, it's only an avatar could do something like that. He was phenomenal. And I think there's no salve lucrum here, you know. This is just my series, again, for the younger people in the audience. Pick a niche. I kind of picked skull base, and I published on that. But I think more than anything else, this is from Shakespeare, that die amongst all, you must be truthful to yourself. So I think I had a friend who always said, I always think my chairman's in the next room when I operate. Because he'll come and say, I did a good job, I didn't do a good job. Was this surgery indicated, not indicated? So I think that balance is very important. And the diabolical can happen not just with surgery, okay? This is, in Chicago, they installed this new radiation system like Gamma Knife, and they gave 10 times the radiation to these patients for an innocuous disease, trigeminal neuralgia. All 6 of these patients died horrible deaths. Their brainstem was cooked, they could eat, they got paralyzed. So stuff like this happens, and we have to talk about that. So I'll sort of end with this case. This was a 28-year-old, really nice person who picked up his aunt from the airport the day before. He comes to the ER, the referring hospital, and he's comatose, okay, unresponsive, not moving his arms or legs or anything like that. His pupils are a little dilated but not blown. He gets transferred to us. We get this emergency film, and he's got this large skull-based meningioma, unresponsive, and you're like, should we do it? Is this going to be diabolical, or is this going to be divine? So I did a skull-based resection on this guy, you know, and we didn't think anything of it. We're like, okay, maybe he'll wake up, maybe he won't. But this is the divine. The guy had a perfect outcome. After surgery, he woke up, no deficits whatsoever. Now, I might tell you I'm a decent technician, I can do well. That's not me. That's the grace of God. Okay, this guy should have been brain dead, should have been in a bad shape. He walked out of this hospital with no deficits whatsoever. And that's where we need to have the humility of our heart, because we can do good things, we can't do great things. Only the big man can do great things, okay? So that's where I think that comes in. And, this is the Cavendish lecture in Cushing, Dave, and I felt all of us have resonated with this. There's nothing in the whole realm of surgery more gratifying than the successful removal of a meningioma with subsequent perfect functional recovery, especially should a correct pathological diagnosis have been made. We have all experienced that divine apotheosis of taking out a tumor with a great result. I am coming out with this book on meningiomas. If any of you want to contribute, this should be out for next year's meeting. And I would be remiss again in not paying tribute to this, to Professor Hegde and the wonderful team here. Unfortunately, we in the US, we do work for Salve Lucrum. You know what I mean? The healthcare system, whether you're a university and stuff, it's about making money. And we do take care of patients, but this place has done, if you look at the number of surgeries done here, it's phenomenal work, and I think Bhagwan Baba's spirit permeates this place. The pioneers like Hegde permeate this place, and we are blessed that they were here and they did this. And I, once again, would pay tribute to this fantastic department. They've done a great job, and we are appreciative of all their efforts in taking care of the poor from every part of the world with the best equipment. And, I would end with the immortal words of our guru. Lord Krishna tells Arjun, if you see me in all beings and see all beings in me, you are dear to me. And I think what Bhagwan Baba reminds us that if we love all and we serve all and we see that divinity in all, we are truly blessed. Thank you very much.
Thank you, Dr. Nanda, for that wonderful talk. I'd now request Dr. Sarita to present a small token of our gratitude and appreciation to you on behalf of the entire Department of Neurosurgery here. The first of our sessions today concerns the contemporary management of cranial and spinal trauma. I would now like to respectfully request the moderators of this session, Dr. Bopanna from Manipal Hospital, Old Airport Road, and Dr. Nupur from Nimhans to take their places on the stage, please, sir. To set the ball rolling today, our first speaker will be Dr. Edmund Jonathan, professor and head of the Unit 3 Neurosurgery at Christian Medical College, Vellore. A nationally renowned neurosurgeon with a focus on advanced and complex spine surgery and a noted surgical innovator, Dr. Edmund will be providing an update on the contemporary management of acute spinal cord injury.
Good morning, everyone. Indeed, it's a great privilege to stand here. Greetings from Christian Medical College. I wholeheartedly thank Dr. Sarita, Dr. Sumit, Sudarshan Sarkar, and the organizing team for having me here. Dr. Anil sir, it's been a great talk listening to the diabolical versus divine. I would try to do my sort of justice for the controversial topic. And indeed, it's an honor to stand here. Thank you for the time. The topic given today, this morning, was talk on guideline-driven care in acute spinal cord injury, what's new and what matters. I'd like to acknowledge Dr. Gio, who has been a part of our team, who helped me put through a few of her slides. The broad outline of the talk is going to be on what is the timing of surgery, what are the guideline-driven care in management of optimal blood pressure and intraoperative spinal cord injury, what are the recent advances, a few slides on brain-computer interface in artificial intelligence and machine learning. So what is the best practice guidelines? We see that spinal column fracture is more common than spinal cord injury. And spinal cord fractures has early mortality. Spinal cord injury has 7% mortality. And mortality always doubles 1 year post-trauma. So how are we going to use this talk? By the end of the talk, we should be able to apply the latest AVO spine and praxis guidelines and recommendations. What is the optimal time for decompression and what should be the hemodynamic targets? And also, we should understand the guidelines that do not settle few things like ultra early surgery. What is the best vasopressor that is used? And something about spinal cord pressure, perfusion pressure monitoring, and what are the high-risk situation in intraoperative spinal cord injury and how to apply the AVO spine and SRS pathway guidelines. A case that we commonly come across for all the residents, you'll be frequently called to come and examine in casualty, a 32-year-old male motor vehicle accident. He has a C5, C6 fracture dislocation, Asia B with neurogenic shock, CT showing purged facets and canal compromise. And the emergency physician asks you, do we transfer? What is your MAP goal? And do you want to give steroids? And the OR team asks, what is our IRC plan if there is IONM drop? What is going to be intraoperative spinal cord injury plan? The key decision in the next 6 hours that runs through your mind should be to immobilize, airway, CT, MAP augmentation, transfer decision, OR activation, and definitive decompression plus stabilization. These are the things that roll through your mind. So do we have a set diagnostic values? Do you have a set guidelines? Do you have a set recommendations? That is what we're going to learn today. What is the timeline of anatomical changes that happen immediately after a spinal cord injury? It starts setting within the first few hours, then progresses up to 1 to 2 years. What are the strategies that you would like to have? It is divided in as a primary injury and a secondary injury. Primary injury is the immediate phase where you focus on reducing the cell death, and the acute phase, you try to provide the neuroprotection, and in the subacute space, you want to do a tissue modification, and in the chronic phase, repair through neuroplasticity. Secondary injury is time dependent. The early window is where we can change the biology. So whenever there's a compression, there's going to be subsequent hypoperfusion that sets in edema, inflammation, and apoptosis. The two levers that is supporting by the modern guidelines is to decompress early and to prevent hypotension, to provide adequate perfusion to the spinal cord. And everything else has a weak recommendation. So the golden 0 to 24 hours is the highest yield window through which you need to operate. This is the Swiss guidelines where they have concluded. This slide would be repeated even at the end of the talk, where they talk about treatment at a qualified trauma center. Early transfer to a spinal cord injury center is mandatory. There's no role for corticosteroids. Decompression within 24 hours is key point. Blood pressure stabilization and standard neurosurgical examination. Dexamethasone for those patients will have a spinal cord injury due to metastasis, secondary causes of steroids. The rest continues to be the supportive management. We have a lot of gradings in place. Asia grading most commonly used. Then we have three-column concept proposed by Vaccaro, talking on SLICs and TLIC scoring, Punjabi and White scale to talk about instability. The most common is AVO spine classification, which factors in the mode of injury. So what is this AVO spine praxis guidelines for 2024? They focus on 3 areas. 1, the timing of decompression. There is a strong recommendation to decompress less than 24 hours whenever feasible. Ultra early surgery less than 12 hours is ambiguous and it is uncertain. Hemodynamic management, MAP augmentation is suggested to maintain 75 to 50. That is a lower limit, and upper limit goes to 90 to 95. The duration they suggested is for 3 to 7 days. And if there is, this is a new things that have come up, is intraoperative spinal cord injury, the definition of what are the high-risk categories and what are the modalities that have to be used in these cases. This is what we're gonna look forward. What is the new thing? There's a strong recommendation for decompression in less than 24 hours. The previous guidelines have mentioned that it is moderate, but now the recommendation strength has been upgraded to strong. We recommend. Offering early decompression surgery whenever possible should be the key take forward. And previously it was operation time from the time the injury has happened to the time the patient reaches to OR has been changed to time for decompression. And use of 24 hours is the key performance indicator whenever the logistics allow. This is the most important change that they have come up. And they found whenever a patient has been operated less than 24 hours, there is a chance that there is improvement in the Asia grade by more than 2 grades. And also there is improvement in the motor power score by points by almost close to 4 to 5 points. Overall, there's not been a difference in the complication rates if operated early versus late. So what is the guideline position on ultra early surgery that is less than 12 hours? There's not been a clean guideline. But when do you push faster? When there is an ongoing cord compression, and when you know that there is a reducible dislocation, and when you know that you have all the resources aligned, ICU, blood, OR, and the intraoperative neuromonitoring team. So you have to standardize making 24 hours, less than 24 hours as standard care, and document the neuro examination consistently at all checkpoints. Few points about the central cord syndrome. There is a weak recommendation to time and early decompression, but central cord syndrome can be of 2 types. One, it could be due to a hyperextension, another it could be due to hyperflexion. But if you have a central cord syndrome due to a mechanical instability or an ongoing compression, there is a role for surgery. This is from the acute trauma cervical central cord spine syndrome. Systematic review had shown that there is a weak recommendation for intervention in central cord syndrome. As you can see, there is level 3 evidence for surgery versus conservative and timing of surgery and early surgery and delayed surgery. But where do we draw the line? We know that TLIX score 5 is plus minus towards the surgery. And when you base it on the Asia grade, there is a latest recommendation suggesting even operate on Asia A because there is a tendency to improve in the Asia grade power and also the Asia grade A. In subsequent slides, we're going to look towards it. But definitely there's a strong push for surgery in B, C, and D, and E depends on observation versus bracing. So here is an article that's published in the Lancet in 2011. It's a pooled data analysis comparing all the subjects from 1991 to 2017. They included even patients operated for Asia grade A, and they compared between the late surgery and early surgery. And here we see that the total motor score improved by 23 points when offered an early surgery. Similarly, after 36 hours, the motor improvement has plateaued. This paper supports an early surgery as a key parameter for those with spinal cord injury. The forest plots in subsequent papers have also supported offering early surgery as a true indicator for improvement. In 2015, a group of surgeons have come up with an idea on expansile duroplasty, and they compared those patients, a group of cohort of 26 patients, they have compared between laminectomy alone versus laminectomy with duroplasty, where they have increased the space for the spinal cord. And they found that there is definitely decrease in the intraspinal pressure and better spinal cord perfusion pressure and reduced secondary damage to the cord in those patients who underwent duroplasty. However, they did not look at the differences in their functional outcomes. They found that it only improved the radiological and physiological parameters. So, is it reliable in the immediate trauma period, whether all patients are ASIA-A or are they ASIA-A because of spinal shock? The cohort that remained ASIA-A might have been the original ASIA-A in the previous studies. So we have to take it with a pinch of salt, but we have to know what is the real truth. What's the update on hemodynamic management? Now we are clear at the mid-talk that definitely early surgery is helpful. The next parameter to concentrate is the hemodynamic management. So the augmented map target is 90 to 95. Upper limit is map of greater than 95. However, the evidence quality is low, but there is a weak recommendation to keep the perfusion pressure up. And the practical points for the neurosurgery and the critical team is to avoid hypotension, treat neurogenic shock, aim for a protocol that has continuous art line and clear escalation rates. And what should be the ideal duration? You should maintain it for 3 to 7 days. Longer support, higher ICU resource burden, and you should tailor to phenotype, and you cannot have the standard practice. There is no choice of which is the best vasopressor. We leave it to the ICU in charge to choose it. So the checklist that you read or that you mandate whenever you see a spinal cord injury is to have an outline, continuous map, define target range, and escalate based on the requirement for fluids versus pressure, and avoid iatrogenic hypotension. And document time in range and hypotensive episodes. Everything has to be clearly documented. And plan to wean as early as possible and maintain the target for more than 3 to 7 days. Intraoperative spinal cord injury should be an important point of discussion because that also contributes to acute spinal cord injury. So what are the factors that contribute to the intraoperative spinal cord injury? Is a patient having a pre-existing severe myelopathy or a deficit, poor physiological reserve, and those who are susceptible to hypotension during anesthesia? What are the pathological factors when you're operating on an intramedullary versus an extramedullary? Those with severe deformity and those with calcifications. The surgery factors, the deformity corrections, long constructs and high blood loss, and long level surgery. What are the 5 phases? So first you should have an initial assessment, have a pre-op planning, surgical and anesthesia plan, intra-op management, and post-op management. And whenever there is a drop in signal, you have to pause and reverse your lost maneuver. Check, is there any hardware that is causing the problem? Is there a deformity correction that you have done that is causing problem? Or is there any retractor that is pressing onto the cord that is resulting this intraoperative IONM drop? Optimize the physiology, raise the map, correct the blood, oxygenation, allow for the spinal cord to regain, and confirm the signals with multimodality managing. If persistent, you can try for wake-up test. The SRS guidelines for 2022 on expert concerns defines the high-risk cases or the deformity cases, and they have provided the consensus response that which we are going to read subsequently. So it contributes to stop the lost maneuver, check the position of the electrodes and anesthesia, fix raising of the map and reverse the correction, and reassess multimodality, confirms the recovery. And you have to decide whether you're going to stage it or abort it. So what do we need to change in our practice? We have to ensure that making less than 24 hours as a reliable and optimal time of decompression. You have to have a standardized map support, and you have to adopt IONM in your spine surgeries. There's a recent upgrade in the machine learning, and now we're going to see the advances in AI and the machine learning that will help us to predict early drop in signal than when the signal is lost. What would be the non-surgical considerations that we look for the intraspinal cord injury? What are the recommendations? I'm not going to stress much on it. It would be a brief touch-up. Role of steroids, methylprednisolone, as we have seen the NASIS trial, is not recommended. There are a few authors who stress on spinal cord perfusion pressure monitoring, but it has its own risk of infection and pseudomeningocele. But if we measure the spinal cord perfusion pressure, it would be ideal, and that gives you a more targeted goal rather than without measuring it. Those patients who have an injury above C4 try to do a tracheostomy, and there is a strong recommendation to wean them off the ventilator. And of late, there's been heavy push for diaphragmatic pacing because it improves the respiratory mechanics and makes them less dependent on the BiPAP or the CPAP. Again, stressing on the same point that we discussed, the Swiss guidelines. And what would be the recent advances? For this, we need to know the pathophysiology of the spinal cord injury and what are the inflammatory markers that are responsible for the spinal cord injury. It's mostly because of ECM, extracellular matrix degeneration by the matrix metalloproteinase, interleukins, and cytokines that are released during the damage. Riluzole has come up in a big way, and the recommendation is to use 50 milligrams BD for 12 to 14 days, and it is used across Asia A, B, C. And all the subgroups had shown a significant improvement. However, multiple randomized control trials need to be done to ascertain the use of riluzole. There is more stress on phrenic nerve stimulation. This was not a recent practice. They had already tried in 1786. They have seen the movement of diaphragm with electrical stimulation of phrenic nerve. Only those patients above C3 injury benefit with the phrenic nerve stimulation and diaphragmatic pacing. There is definitely a role for spinal cord stimulation because spinal cord stimulation and neuromodulation helps to restore the voluntary motor control. It improves the bladder and bowel function. It manages the blood pressure and definitely eases the chronic pain that is associated with it. Neuromodulation with transcranial direct current stimulation, with transmagnetic stimulation, deep brain stimulation, and epidural electric stimulation have been tested. This is a brief diagram capturing all the things that have been tested, but still the recommendation is not strong. A few snippets on how we do the spinal cord stimulation, how the transmagnetic and direct cortical stimulation and functional electrode stimulation that helps for managing spinal cord injury. Is there a role for brain-computer interface? Yeah, definitely. The recent push for Neuralink has seen some improvements. It is divided into invasive and semi-invasive and non-invasive. And this is still test in process. Is there a role for stem cell therapy in spinal cord injury? We have to understand the main stem cells that play a role in spinal cord injury, the mesenchymal stem cells and neural stem cells. And there are anecdotal reports of improvement, but still it has to go through the test of time. Recently, there's been push for biomaterial scaffolds. These are the scaffolds that help to organize the matrix around the area of gliosis, and it helps to develop and push the neurotrophic factors, including the stem cells, in order to regenerate or help for nerve recovery and nerve growth. This is a small picture depicting how they implant the scaffold in the area of the gliosis, and that helps in regeneration and improving it. However, the literature is sparse and needs to be tested more. We had our experience with mesenchymal stem cells that we have used in brain injury, and we have used it in the subacute phase of brain injury, that is 72 hours later. And we did not see significant improvement in the functional recovery between the control and the experimental group. So what is the thing that we need to remember before we conclude the talk is to decompress whenever feasible, maintain adequate spinal cord perfusion. There is no mandatory pressure choice, and intraoperative spinal cord injury is real, time critical complications, and SRS avospine alignment is the thing that is of practice, and all those patients who are at high risk, better to do it with multimodal monitoring. Thank you for the time and opportunity.
Thank you, Dr. Jonathan. That was an extremely lucid talk. Several nuggets of wisdom there, and so many things that will change practice. Just one question for you. If you get a young patient, Asia A, who say in about 6 to 8 hours is improving to Asia C, and it comes to you, do you still advocate urgent intervention, say there is compression, and by the next morning, you see he's improved further to Asia D?
Definitely, sir. The patients who are improving, definitely I would wait and watch. But if there is an evidence of mechanical instability, would recommend a surgery.
I think the take home would be you have to still individualize based on
Yes.
the given patient.
We have a question in the audience.
So IOM monitoring and all that is, I don't think it is restricted only to institutes or maybe some handful amount of hospitals. Because I'm working with 16 districts in Gujarat and 240 hospitals. In and out, I operate spinal cord injury. I only think three things are important: time, pressure, and steroids. This is what we do since ages, and good amount of results are also coming. So I don't advocate ion monitoring to be must. If it is not available, still like young children should not get that message that you have to do ion monitoring. I know there are so many seniors here, they can also focus on this.
Yeah, I agree to that. The spinal cord injury, the topic
The amount
is
of time what you waste shifting the patient is absolutely useless. What I do is I tell them I'll blink the implants, autoclave it, put the patient in OR, get one blood, manage your pressures, and we operate. Hardly within 2 to 3 hours, everything is done. Less than 6 hours, all the spinal cord injuries are operated.
agree. The topic here is on a spinal cord injury that includes even what is happening at the OR. It is not only limited to the spinal cord trauma. So that's why the point of IONM is there included in the latest AO spine and axis proxim guidelines to even talk about the intraoperative spinal cord injury that happens during the regular cases, non-traumatic cases also. That also has to be included. As a routine, we do not advocate IONM for trauma cases. IONM here is talked about for intraoperative spinal cord injury that happens in non-traumatic cases. So we have to carefully look at what we are working on. So the acute spinal cord injury, the topic includes even non-trauma, which can happen during non-traumatic cases also. So definitely there is a role for IONM. There is no debate on not using IONM in the non-traumatic settings. Thank you.
Edmund, what about close reduction? I mean, I think neurosurgeons are not very in favor of that, but what about close reduction of the cervical spine subluxations? I know a lot of orthopedic colleagues who do it.
Yeah, that's an interesting question, Nupur. Closed reduction is definitely not advisable if we do not have an MRI, because closed reduction without an MRI, if the patient has a disc prolapse, can worsen the neurology. But there is we advocate using cardinal well traction for those patients who have facetal dislocations, and if the neurology is intact and if there is no disc prolapse on the MRI, we definitely advocate. And if it reduces, we can directly just do an fixation. If not intraoperatively, also we can use the distractors and reduce it.
Thank you.
Thank you. Yeah.
Steroids, whatever said and done, lot of controversies are, but still people do use methylprednisolone.
Yes, sir.
What is the key point against methylprednisolone as per your experience? Where saying it should not be used or you don't use? Any reason for that?
So use of methylprednisolone has a lot of adverse effects with in terms of recovery and also the long wound healing. So as a unit protocol and as a institution protocol, we are not been trained with using methylprednisolone. Definitely not. Yes, sir.
And I waited, okay, because I was like, let me wait. I'm looking at this. Did I do the right thing? I operated on him like 6 to 7 days later, did the thing, good, he had a good outcome. But then he didn't want to live like that. And he refused all medical therapy, and 2 weeks later he died. So my question was, should I have operated early based on this with a large C3-4 disc and cord compression? And was I at fault waiting to do it?
So the patients who have a central cord syndrome, and if there is an evidence of compression, definitely better to operate early. But those which do not have a structural cause for the central cord syndrome, there is a weak recommendation of surgery.
How strong is that recommendation of early surgery, central cord?
It is level 3.
Okay, thank you very much, Dr.
Thank you.
Edmund. We'll
Thank you,
move
sir.
forward in the interests of time. Up next, we have the first of several of the debates that we have planned today. This debate is the motion for the House is ICP monitoring in traumatic brain injury, whether it should be used to guide therapy or is it just measuring numbers. Our speaker, we have two esteemed speakers for this debate. The first one is Dr. Shalini Nair. She is a professor of neurocritical care at the Christian Medical College, Vellore. She will be speaking in favor of an ICP-based approach to the management of traumatic brain injury.
Morning, everybody. Thank you, Sarita, Sumit, and Sarkar for this opportunity. I've realized I'm the only neurointensivist in this room, surrounded by all neurosurgeons. You've pushed me on a back foot already, but I'll put my best arguments forth. So, taking away ICP from us, or rather denying ICP monitoring to us intensivists, and asking us to manage the patient is like switching off the light and making us blindfold. Not fair at all. So, I am all about, yes, ICP is not just a number, it's much. Yeah, so it's much more than number, just a number. And that is what I'm trying to put forth in next few minutes. So here was a boy, 20-year-old boy who came to us with a severe head injury. His GCS was around 7/15 when he came to the ED. And so our ED guys have gone on and intubated. Now, in the intubated state, we stuck to the principles of TBI management and we put an ICP. ICP numbers went up slightly and then reached the threshold of 20, went down for a CT scan, and we found this. Now, if you were not monitoring the ICP, how would you judge the time to go down for a CT scan? How would you find out this? My esteemed colleague is definitely going to bring forth in his discussion about best trip trial and the instance of not doing ICP monitoring and just CT scan, but the evolution of this injury or the perilesional edema is not dependent on your CT timing. When is it going to happen? How is it going to happen? You have to monitor and find. Without monitoring, you do not know. We've moved a little ahead of the Brain Trauma Foundation guidelines. What we are talking of recently is the CIBIC guideline. All the tiers of CIBIC guideline is based on ICP. Without ICP, you cannot. Let's move forward from the numbers the ICP shows. So you have an ICP monitoring in place, everything is hunky-dory. The number, the waveform, everything. Here the number goes, the waveform pattern goes. What is it telling you? If has this waveform morphology to change only when the number goes? No, and it is not me speaking about it. It is it was a review done by all the neurosurgeons in states. I'm not sure, sir, they reached out to you or not. But then the neurosurgeons among themselves put forth the first question: if the waveform morphology was abnormal and the numbers were normal, they do wanted to intervene. They were not happy to wait till the numbers went up. Vice versa, the other situation in which the numbers went up and morphology remained same, they wanted to wait more. They wanted to do more intense monitoring, and they didn't want to commit to escalating their therapy. So yes, ICP is more than number. The morphology matters. What else can ICP give you? It's a sneak peek into the physiology of the cerebrum. What is happening there? I will go into the y-axis a little more in detail, but what this tells you is one number doesn't fit all. ICP of 20 is not dug in stone. It can change for each individual. Not far from us, within our continent, the Koreans have shown us it is much more than number, and the intensity of therapy, increase or decrease, has to be based on the monitoring that you're doing. And that makes a functional outcome. I know many people are very averse to Western ideology, so it is coming from Asia. Don't amalgamate things. Do not bring a lot of physiology. Just on bedside, we have a very simple bedside tool of finding out what is happening to the physiology. Is the autoregulation intact or has it gone away? And that makes a big difference to what you're going to do in the management. All that you need to do is, if the patient is on inotropes, bump up the BP and see what is happening to the ICP. If your autoregulation is intact, like we have shown on this side, if when the autoregulation is intact at a map of 100, injured side and uninjured side both have the same caliber of the vessels. If the autoregulation is gone, you drop at the instance when the map has dropped down to 70, on the normal side, the vessels are dilating. That is what should happen. But on the injured side, it is constricted and ICP is sitting at 40. Same here. So when the inotrope is gone up and the map is built up to 150, the injured side is dilated. That is not what physiologically should happen. Well, how will you know it unless you're monitoring? You will be blinded. You don't know what to do. Thing I was talking about in cerebral physiology, the y-axis I showed in the previous picture, is about pressure reactivity index. Here, our engineering colleagues have come in a bit. They have amalgamated two continuous waveforms, the ICP and the arterial waveform. And that gives you a continuous sneak peek of what is happening to cerebral autoregulation. And that is the index called as pressure reactivity index. It ranges from a minus 0.2 to plus 0.2. It should remain as negative as possible. What it does, it gives you a multimodal monitoring. That is what the world is going towards. Only ICP debate, I think, is a little redundant. World is moving forward and we are looking at multimodal, but ICP remains integral to it. So if you were monitoring ICP alone, this is a point where the first time the ICP has risen. But look at this last one. What happens? The red is where the pressure PRX index has gone up, and it's almost an hour earlier to than ICP. And if you were to know that ICP is rising, physiology is changing, how much you can prevent damage happening. Physiology becoming aberrant, you can prevent it. And what will that translate into functional outcome? We do not know. Come to hemodynamics. We have to maintain cerebral perfusion pressure, but same limit doesn't remain the same throughout the day. A CPP of 70, 80 is not going to be constant throughout the day. How do you know at this hour of the day what do you want? Again, combine ICP and pressure CPP, you get CPP opt. And this parabola keeps changing every 4 hours. And the nadir is the best optimal CPP you need. On hourly basis, you're being told what is best for your patient, how to go about titrating the NORAC. I know the neurosurgeons are not interested in NORAC, but that makes the functional outcome different. Come to oxygenation of the brain. Here again, PbTO2 and combined with ICP gives you a whole lot of 4 options how to go about and treating the patient. Everything written in black and white, no gray zones. But you have to monitor ICP. The last of all, LMIC advocacy. It is expensive. We can't afford. No. This is coming. This is almost a prayer, almost a plead from all the big names. Look at this. All the big names on TBI. It makes a difference in functional outcome, number of days without employment, and eventually it is economically beneficial for us. So my argument is the title is a little biased. It should have been, are we there? Can we use ICP more intelligently? That should be the title. Thank you.
Thank you, Dr. Shalini. I'd now like to call upon Dr. Shalini. You can just stay back on the stage. Our next speaker presenting his arguments against the topic will be Dr. Subhash Konar, Additional Professor of Neurosurgery at NIMHANS. After Dr. Konar's presentation, we will allow for Dr. Shalini to offer a rebuttal to his points and vice versa before the moderators then throw the question open to the audience for further discussion.
Morning all. I'm very honored that I'm presenting in front of my mentor, my teachers, and my colleague. So the argument is about ICP monitoring, about number. First, I start to Madam. Where is Salini Madam? Oh, sorry. Madam, in NIMHANS, we work together with a critical care team. What is shown, like we are doing ICM Plus, we are using. We are doing PRX management. We started doing microdialysis also. So I'm also part of that. And actually, I am a pro ICP monitoring, but here I am doing a debate. For the debate's sake, I am doing. So when Sarita madam called me, I told, okay, I'll do it because you should know the limitation first to improve your monitoring. So on that sake, I'm doing the debate. So why ICP monitor? That is most important things that ICP reflect the intracranial compliance and it influences the cerebral perfusion pressure. That is very important for a neurosurgeon, not only for head injury, for SIH, for any intracranial pathology. Our target is to maintain the cerebral perfusion pressure. The traditional goal is to avoid ICP more than 20 to 22 millimeter to prevent secondary ischemic injury. Now the questions arise, does ICP monitor or treating to a number actually improve the patient-centered outcome? So what is the BTA Brain Trauma Foundation guideline says? That ICP monitoring, it will help to early identification and treatment of detecting the new lesion or the progression of the hematoma and to maintain the adequate CPF and oxygenation. Though the recommendation is not a level 1 evidence and all the data in BTA derived from retrospective and limited prospective observation data. So there is no level 1 evidence. So now I'll come to the problem with ICP monitoring. So first, monitoring related. So it is not a number. There is a called ICP metrics. ICP metrics means we have to see the mean pressure, we have to see the pulse, amplitude, and those values are still not predicting and they are not correlated as per different studies with the outcome. So the ongoing debate is that indications definitely, the ICP monitoring may, and even in the indication also dramatically vary across the institute, across countries also. So there is no universal consensus indication for monitoring. Now the next point is the quality control gap. Because right now for ICP monitoring, only we have a Codman ICP and now they launched the CereLink device. So different company, they have a different parameter, they have a different calibration procedure. So like it varies from manufacturer to manufacturer. There is no standardized protocol for validating the ICP signal quality across device. Like whatever value you're seeing, when you want to see the waveform is more important than value. But we don't have the equipment or you have to pay more, buy one card and it will connect with a specific one multimodal monitoring. Another problem is the time signal integrity monitoring. Like it is not consistent till now, but may come. And the less invasive methods like what we are doing, non-invasive like ONSD, TCD, all modality needs more data. Still the data is not that, and the correlation with the invasive ICP is still not that significant. The most important things with ICP monitoring is the zero drift. Zero drift is an inherent problem with invasive ICP monitoring. Like if you will keep a ICP monitor, still there is no guideline how long we should keep, 3 days, 5 days. But if you will keep in a single day, it is over time, there will be a drift. And that is because of the movement or because of the brain pulsation, because of the CRF. The study shows the average drift is 6 millimeter. And if you will see the different modality of ICP monitoring, the max is with epidural, next is subdural, then parenchyma, and least is interventricular. So this is inherent problem with invasive monitoring. Now the questions come, measurement of accuracy crisis, like what the researchers has found, the different studies says that there are 20% of ICP readings are inaccurate because of sensor drift, because of calibration error or technical fault. So still not that accurate. So based on this, and like the ICP monitoring, why we do that, that because we'll step later follow, like we'll go from tier 1 to tier 2 to tier 3, and we'll start the aggressive intervention like hypermuscular therapy or decompressive DC. So next things, the technical and physiological complexity. Now the era of geopolitics, there is no role of regional politics like in the modern era. So that is same in the brain also. Like when you're putting ICP monitor, invasive ICP monitor in a parenchyma, it will give a value of that lobe. Like suppose you shown a CT scan of left side frontal. If you put ICP monitor, it will not give you value of what is the pressure of the right side hemisphere, what is the pressure of the left side temporal lobe. So we need a more global monitoring, like whatever the available ICP monitoring invasive, it will give a regional value. There are multiple dynamic factors like the changing cerebral blood volume, CSA production, absorption, brain compliance, systemic factors like blood pressure and ventilation. It all changes the ICP value. And that we should know the brain is not a uniform fluid field container. The regional compartment can experience critically different pressure. And that is still now, though interventricular will give the best value, but in a trauma patient, when the ventricles are not dilated that much, it is a technical challenge to place a EVD or interventricular catheter inside. The easiest way is parenchymal, and it is a regional, it is not a global. Now, what are the threshold and ICP burden? The values, different studies, critical ICP values 20, what we should set a target, 20, 22, 25. It varies from different study to different, though 20 to 22 is the cutoff. The simple target of maintaining target more than 20 to take result. That result, Madam mentioned about the best trip. Best trip, they failed to show the benefit of targeting more than 20 millimeter. So the study-based argument, what we are targeting, that's a crude pressure threshold, and it is poorly validated monitor in case of invasive ICP monitoring. So the challenges in non-invasive and less invasive is the data is not that much. Study shows that the correlation with invasive is not that significant. Another problem is there will be a operator-dependent variability. It is a subjective value. It's not an objective value, because who is doing the TCD, who is doing the ONSD, that person's experience matter for the value. So there is a operator-dependent variability. There will be a signal technical point, signal noise challenges, like whatever you are getting values, there will be an external artifact, patient movement, other things. So now I'm going, these are the technical clinical evidence. The only one trial is available, best trip, and best trip result shows that the primary outcome composite of survival time and impaired consciousness and functional status as 3 to 6 months, it doesn't change between the monitoring group versus non-monitoring. Non-monitoring group is like you just follow the patient clinically and CT scan radiologically and compare. They did a two group and they compared. They found ICP monitoring did not confer superior outcome. So the critical interpretation of that paper that the 3-month, 6-month functional outcome doesn't vary between the two arms. Even that evidence, like I just saw this paper, even level 1 trauma center in US also, they monitor like the data of 5,000 patients, 10% patients, they monitor ICP. They found it is an independent extra risk factor of mortality, the mechanical ventilation for longer time, longer ICU stay, systemic complication, and obviously the decreased functional dependency in discharge. The Japan data also, the trauma data also says the same thing. They found there is no increased favorable outcome rate with ICP monitoring. The literature review, that there are several meta-analysis and umbrella review is also there. 2025 meta-analysis shows no overall reduction in hospital mortality. Even the umbrella review, no conclusion evidence that ICP monitoring reduced the mortality in TBI patient. And 2025 systemic review, the timing of the placement, when we'll place and how long we'll monitor, that also it is not very conclusive as per systemic review. Now, another problem with children, ICP monitoring in children, the normal, so-called normal of 2022, it is not same in infant, it's not same in children. Like in infant, less than 1 year, it varies where frontal is open. Even from 1 to 10 and more than 10, it varies. And another most important thing in children is the brain plasticity. So we don't have the true number for children, though we monitor 10 to 15. And the long-term quality of life, a 2025 meta-analysis found that where we are monitoring in children also, it is not correlating with functional outcome.
Thank you, sir. The time limit is reached.
Yeah, just 2 minutes. I'll just complication. Just 2-3 slides. Yes. Complication is 4.22 hemorrhage, guideline limitation, cost. That's most important, especially India like country. Like what you want? You want a luxury like bench or you want a regular car? Because the device cost of ICP Codman is 12 lakh. The Cerelink is 15. The most important is the recurrent cost of the catheter is 50,000 for and 70,000 for Cerelink. So it's not just a number. So we should move. I am going in favor of you, madam. We should go for a middle ground shift like multimodal. So we should go for a multimodal. We should go for individualized threshold. We should bring brain oxygenation like as per the Boost 2 trial. Boost 3 is going on. And always we should go for optimal CPP to focusing on cerebral pressure. So my conclusion slide, like we Indians, we are famous for spices. So we cannot do a good dish without putting everything together. So only one ICP, it is not enough. We should go for a TCD, we go for a NIRS, we go for brain oxygenation. When we'll do together everything, I think that will be a nice dish and we can monitor the brain in a better way. So the things come like we should, like may it come that better sensors should come where the drift will be less, there will be more stability, there will be more auto, like we can bring the AI here and then do more auto calibration capability, quality control study, and obviously multimodal. Thank you.
By the time I get the slides back. So you spoke about cost. I think one whole slide was towards cost. And even before that, you talked many times. I think CMC Vella for last 30 years, we have our own way of monitoring critical ICP. And that costs around 500 rupees only. So I don't think if you have a will, you have a way. Zeroing is possible. Intraventricular catheter, zeroing is possible. You can keep 5 days, our infection rates have the most minimal, and your cost is only 500 bucks. So that goes out of the window. Next, non-invasive ICP. I agree, there is a learning curve. ONSD has the least learning curve. It is not steep at all and very easy to learn and requires only 2 minutes to perform. 3 average values takes 2 minutes. I'm one of the, I think I do ONSD every day, some 10 or 12 every day. So that is very easy to use. And Be Iconic trial gave you one whole flow chart based only on non-invasive ICP, how to go about. That also is not correct. So ICP, as much as possible, ICP as much as possible should be done and I complete. So while the world was doing best trip and trying to make ICP infamous, these were two of the physicists who looked at ICP continuous waves, and what they did was they looked at the sensitivity and specificity of predicting before the ICP went high, and their sensitivity was almost 90% to predict it 5 minutes before the numbers went up. That's where we should be looking at. And like I said, non-invasive ICP, if you use, you have one whole assortment of ways you can do it. Combine them, you get a number which is very much reliable. It may not be accurate, it will not take the place of invasive ICP, but that is a number to go by. At least gives you a trend. Thank you.
Cost is like. Sorry, I would like to interrupt. There are 7,000 cases in Gujarat each year. Okay, there are 3 hospitals in Ahmedabad, one in Rajkot and one in Surat. Means only 5 hospitals in whole Gujarat who can monitor this ICP. There is no other facility available in any of the government or the private institutes. So coming to the baseline, what is the solution? We want a solution. Here we are all for solution. So what we thought is long back, we started using 3% NS. And then we observed that a sudden change in ICP or what picture you showed, that perilesional edema and increasing ICP and all that has come down a lot. Our death rates of traumatic brain injury have decreased from unseated like 10% to less than 0.6%. So we are also maintaining a data about that. And we just give 3% NS. We titrate based on the sodium, even if the sodium is less or more or whatever it might be. So we are not publishing it, but then where do we invest? We train our staff. We try to retain the neuro staff. We try to retain the neuro doctors, and we make a team. And there's an entire different concept of developing a team and working without tools. That is what we do at ground level.
Yes, sir. So we'll be taking questions again in the end. We'd like to ask Subha sir for a rebuttal.
So, madam, cost for institutional level, like in Niman, we are trying to get the cost less. But what is my thing is that this ICP monitoring should be not at the institutional level. It should be all over. So in all over, the problem with the recurrent cost of the catheter. The catheter cost right now is 60,000 from the company for an old ICP Express that they have now stopped producing. Now they are coming with Ceriling. Ceriling cost is 70,000 per catheter. And as per recommendation, FDA, one time, one use. That is one point. So my argument is for putting not only ICP, you have to go for multimodal. That is one point. Second point you raised, madam, about the problem with non-invasive is the subjectivity problem. Like who is doing? Like a person who is a first-year resident, second-year resident, third-year resident, the values will change. Like we sometimes will do in our institute, there are different residents. We ask you measure. So the ONSD will come 3.5 millimeter, another resident, and then we assess with the consultant. So we have found there is a subjectivity variability. Based on that, where you have a high variability, we cannot take a call of doing a decompressive craniectomy or take a surgical decision. That is the problem with non-invasive. Though we have done a study, I was also part of the study, we compare, and right now I am doing one more study with invasive, with non-invasive, but we need more value. We cannot take decision just right now based on your non-invasive. And third argument, madam, what is? So other problem with children ICP monitoring is very, very difficult. Like right now I am doing 2-3 study. And last week, like our critical team, when we are there, one patient of bifrontal contusion. So it's the ideal case for monitoring. We took to OT, we put all monitor except brain oxygenation we don't have right now. And then the argument like ICPT was going 40, then again it is going 15 like that. So I was keep telling that wait. But as per that study protocol, we are collaborating with Cambridge. As per that protocol, you have to do surgery. And next day patient was M5, M4, next day patient M6. The critical care team told us, no, you are correct that we could have waited for that and patient was improved. So still we don't have that much data to say, but definitely it is my suggestion to everyone, we should do ICP monitoring, we should do monitoring because it is a dynamic thing. It is not just one time, 1 minute, 1 hour. And if you have better, like even I have done one case, supratentorial 180 and infratentorial to demonstrate the central herniation. What was the pressure difference between supra and infra? Like when brain is herniating central herniation, is there any pressure difference? Just one study, one index case, but it is difficult to do in a trauma. So still we are doing a lot of research on that. That's
Do we have any more time? We'll take some questions from the audience.
Very nice debate, but to take home message, if there is a patient or scan that you make, which side do you put the, if you have a which side do you put the side of the lesion or on the normal side, are we using the local ICP for your treatment based on global ICP? Are we looking at the focal ICP or the regional ICP? And where is the recommendation? If there is a diffuse let's say a bifrontal contusion, right, then we can easily put it on non-dominant. Something focal, what is the recommendation?
You rightly pointed. As of now, the guidelines say safety first. The non-eloquent area would come first, irrespective of where the lesion lies. But you have to do focal. Microdialysis is the only thing, and I think only AIMS and NIMHANS has it. And very labor intensive. I've worked in Cambridge, very labor intensive. I don't think we are yet there.
Doing like what we follow in NIMHANS, like if there is a left side contusion, you have to try to put in the left pericontusional area. The tip should not be inside the bleed. So whichever side, wherever you are monitoring, best is intraventricular. If you have a facility to take to OR and you have a neuro navigation, you can use that. Like nowadays, people are putting shunt under navigation. So the interventricular catheter can use the navigation and hit the best result with intraventricular catheter. Another advantage of intraventricular is that you can release the CSF. That is one of the disadvantage I have not shown here, that you cannot release the CSF in interparenchyma. So intraventricular, you can release the CSF and you can get control of the CSF. Yeah, focal. That is the limitation right now. So that's why what the value you are getting is the focal only, sir. Right now, interparenchymal, whatever you are getting is the focal ICP.
Even if we put it on the opposite.
You can put that. There are people like I told you now, we have put supratentorial, infratentorial, you have a facility, you can put both sides. In AIMS, they put ICP monitor, Deepak sir, for all cases. So sir also like temporal if possible, like, but these are like at institute you can do, but in a practice it is slightly difficult. That 20, see, there are so many things. Shifting means there is a solution for that. I'm not telling just shift, just now you drain and see the ICP. If it is within range, stop. There is no continuous drainage. So that's why I started like it's not like in geopolitics and regional politics. Always regional politics will be there.
I'd like to highlight one thing alone. So intraventricular catheters in the traumatic setting is not as difficult. It's not as difficult as it's being mentioned or discussed here. So a technique which has been described in Neurology India from 98 by Matthew Joseph, sir, slightly medially placed and in the ICU is possible, and
But
that is
who
being done
is
regularly.
doing, these are all the critical care in the middle of the night. So in a ICU setup, who is doing, he is the expert. See, sir also told, we should not harm the patient. That is the most important thing. See, experts are there, daytime, consultant is there, you do it. Nothing is easy,
As
you do it.
ma'am mentioned, it's being
No, no,
done.
I'm just
It's a
telling you,
very
we also
safe.
do. Whenever possible, we do.
Only request from my side to all the neurosurgeons here would be train them for putting intraventricular. It should be an integral part of neurosurgery training. We are missing the boat altogether. We're not monitoring it. Thank you.
Thank you. Any questions?
Thank you. I think we're out of time for the neurotrauma session, so we'd like to conclude that. I would like to thank the moderators and faculty for their time and efforts. I'd like Dr. Bopanna and Dr. Nupur to kindly felicitate Dr. Edmund, Dr. Shalini, and Dr. Subhash. I'd now request Dr. Sumit Thakur, Senior Consultant, Department of Neurosurgery, to present a small token of our appreciation to the moderators.
Thank you, sirs. So now we're going to move to the second session of the day, which is going to be CVJ and spine. I'd like to take this opportunity to invite our esteemed moderators, Dr. Satish Rudrappa, Dr. Satish Rudrappa, sir, from Astor Whitefield onto the stage. And our second moderator will be Dr. Kiran M. from Chinmaya Mission Hospital. So now we're going to start this session. We have an exciting debate. Will MIS and endoscopic spine surgery make open surgery obsolete? So speaking for the motion, I invite onto the dais Dr. Umesh Srikanta from Fortis Healthcare, Bangalore.
So we have a beautiful two senior surgeons who will be debating on minimally invasive surgery. Umesh is good in that, and I have a fantastic friend called Sajesh Menon, who does from scoliosis to everything in spine, who will show how still open surgery is mandatory, not to forget about it. Umesh, over to you.
Thank you. Good morning, everyone, and it's quite an honor to be here. Thank you, Sarita. Thank you, Sarkar, for inviting me and having me over and giving this exciting topic. And I'm sure that everyone here has tried their hands a bit in minimally invasive and endoscopic spine surgery, and that is the one. And we all know that it's a very rapidly upcoming field. So, and it's not quite easy for me to, justify all that can be done in MIS and why MIS has, in fact, if possible, the potential to replace or at least most of the open surgeries that we are doing. And these are the points that we can consider while arguing on this particular debate. Why are we favoring this? Why are we favoring MIS versus endoscopy over? Is it just a glamour of small incision? Is it just cosmetic, or is there a scientific rationale? Are the nuances in minimal invasive and endoscopic spine surgery allowing us to do more number of cases than what we were doing earlier? And will we reach a stage sometime in the future at least where we can do everything MIS? And of course, if that is not reached, are we mature enough, or are we going to be mature enough to reach the balance where we can choose cases that can be potentially and effectively done in MIS fashion and those that require actually an open surgery? Now, open surgery, even though with very good exposure, with very nice exposures, less blood loss, subperiosteal dissections, we know that there is significant muscle damage, and that is what we are trying to prevent, which has been shown in several studies, and that is what we are trying to prevent in minimal invasive spine surgery, that is predominantly reducing injury to the paraspinal as well as the excess structures of the spine, which are actually innocent bystanders, not involved in the pathology. They are being disrupted, they are being invaded only to reach the area of pathology, and that is something that we are trying to prevent in minimally invasive. And this is the basic difference between MIS and open, where the exposure, even though limited, the amount of the decompression or the effectiveness of treating pathology is actually not compromised in minimally invasive. Now, literature-wise, I'm not going into the detail, the time is short. So there are significant literature to say that the clinical outcomes are much better in the short term and have equivalent long-term results as compared to an open surgery. You have a very good radiological results, even though the earlier studies showed that the higher rate of pedicle screw breach for a minimally invasive pedicle screw fixation, especially thoracic, upper thoracic. Nowadays, we know that it is almost similar fusion rates, early fusion with the lateral interbody approaches, and of course, better biomechanical stability with all these anterior and lateral minimal access surgeries. We know that the overall complication profile is similar. We know that the type of complications may vary in MIS as compared to an open surgery. Initially, you may have a higher incidence of dural tear, you may have a higher incidence of pedicle screw breaches, but overall, in the long run, that justifies the contradicting higher incidence of wound infection rate as well as reoperation rates that we actually see in an open surgical era. So it's not just a glamour. And of course, there is a scientific rationale sufficient enough to justify minimally invasive or an endoscopic surgery. Now, the next question, which is there in everyone's mind, everyone says that, okay, minimally invasive, we may be able to do a little bit. We may be able to do small, simple things like this for canal stenosis. And that is something that I am not going to say at all today. We all know that minimally invasive is good enough in treating discs, good enough in treating lumbar canal stenosis, good enough in achieving fusions in simple cases. What I'm trying to show, or what I'm trying to say here, is it can be used in much more complicated cases as well, and it is quite effective. Even it is effective in achieving bilateral decompression in these cases where there is severe bony canal stenosis. You can achieve a good over-the-top decompression by just angulating the tube and achieving good results, even with minimal access techniques. Open surgeons always say that you can do simultaneous bilateral manipulations whenever you need to reduce a complex listhesis, and that is something that can be achieved, as you can see there in examples, with minimal access techniques as well. And to actually reduce the listhesis, even higher grade of listhesis can be reduced using minimal access techniques. With lateral retroperitoneal approaches, the evolution has been even more significant, where we can actually enter the disc through a virgin area between the anterior border of the psoas, and a good result can be achieved even without entering the canal, even without removing any of the structures. No facetectomies, no ligament removal. All this canal remodeling can happen with just putting or distracting interbody, by putting interbody cages and distracting the disc space, even in complex cases. And where these lateral interbody approaches have played a significant role is in these grotesque degenerative deformities. Imagine earlier we used to treat this for hours together using open techniques, but nowadays you just have to go with the lateral retroperitoneal approach, jump from the anterior border of the psoas, on the anterior border of the psoas, from one disc to the other disc, and each level takes hardly a half an hour extra. And you can just, by putting interbody distractive cages, uniform interbody distraction, you can reduce the degenerative deformity as well as the lateral listhesis, avoiding these kind of open degenerative deformity correction surgeries in these eras. Obviously, even complex cases like iliac fixation, which actually require a significant amount of muscle dissections, can also be done using minimal invasive techniques. In fact, presence of navigation intraoperative imaging also helps us to actually select only a single midline incision with which two S2 AI screws can be put with the same incision in the midline. And that is something that is possible. Now, again, there are people who will say, okay, revision cases, definitely MIS is not possible. You need to do an open case in these particular cases. And that is something that can also be achieved in MIS through minimal invasive techniques. Examples like these, where there is a screw breakage, there is a pseudoarthrosis, the fusion has not happened, you can actually do a revision MIS TLIF and extend your fixation into the pelvis. In these cases where their screw has been broken, you can leave the broken screws behind, treat the adjacent segment disease with multi-level O-lifts, and as well as put in new fresh trajectory screws through minimal access techniques, connecting all of them with a new rod altogether. Cases like this, which have failed with the single lateral, for lateral interbody, standalone lateral interbody fusion for a adjacent segment disease, you can actually do a multi-level fixation from behind and actually reduce to restore even the sagittal balance. And all this D12 to L1 or D12 to S1 or pelvis can be achieved with minimal access techniques. Now, you must be wondering, I'm just showing lumbar cases, I'm just showing degenerative cases. What about non-degenerative? Spine is not just degenerative cases. You can have complex traumas, you can have tumors. So again, these cases can be done. Apart from simple fixations that we can do with MIS techniques, you can do corpectomies. You can do corpectomies even for these kind of cases where there is a neurological deficit, where there is a vertebral body destruction. You can do a corpectomy and multi-level fixation using MIS techniques. Even large tumors like this patient was actually scheduled for a thoracotomy, and he had a good sense of just checking whether it is possible to do this minimally invasive. And this can be done with just putting in a tube through the rib, through the transverse process and the rib, and then enter the thoracic cavity and remove the complete tumor like this. So these tumors also can be achieved. Good amount of decompression, good amount of tumor excision, as well as fixation can be achieved with minimal access techniques. We can also use even these complex cases where the tumor has gone into the extraforaminal area. You can use these tubular retractors in a biportal fashion, and actually you can work simultaneously intraspinal as well as spinal, preserving the facet joint, obviating the need for fixation, which otherwise you would invariably end up doing in an open surgical era. Again, cervical cases, I'll not go into the detail. People think that very few cervical cases can be done minimally invasive. You can actually do multiple number of cases with minimal access techniques. Cervical C1C2 fusions, even bilateral C1C2 joint manipulations, as well as putting in the cages, cervical pedicle screw fixations, using even intraoperative 3D imaging, as well as multi-level cervical decompression. Fortunately, all of these we have already published. Even for difficult cases, using two incision techniques, we can decompress all the way from C2 to C7, even in tough cases like these, OPLL avoiding the fusion cases. So we can do much more in MIS than what was originally thought. Now, economic perspective, even though there is a slightly higher initial cost, but we know that the long-term cost effectiveness is better with MIS. The market adoption trends, if you can see, these are data from the US. MIS has grown by 18.7% in the last 1 year as compared to open surgery, which has grown only by 5.4. You have a CAGR of nearly 7. Some studies say of about 16% for minimal access surgeries. Training, majority of the training programs that are happening these days, more than 75% are actually focused on MIS and endoscopy, increasing emphasis on MIS and endoscopy in conference. So ultimately, I would like to say that there is a growing acceptance to MIS and endoscopy, and MIS is here to stay and grow. And the earlier we get onto the bandwagon, the more better prepared we are for what this wonderful technique has to offer in the future. Thank you.
Thank you, sir. So please take a seat on the stage. I now invite Dr. Sajesh Menon to speak against the motion. Dr. Sajesh Menon is a senior consultant at Amrita Hospital, Ernakulam.
Yeah, it's a nice talk by my friend Mesh. And see, I am not against MIS because I am also doing MIS. What I am trying to say, the question is, The argument is that traditional open spine surgery has become obsolete, or robotic and minimally invasive techniques are the best and the future. So I differ in that in these questions like does the innovation means elimination? Whether newer technology can fully replace open surgery across all spinal pathologies. We are discussing as of now. We are not discussing about the future. For the present day, I not. You all know that surgery. We are all trained in traditional surgeries, and I don't need to say the good thing about surgery, positive things about surgery. But I go through some run you all through a few cases, and you'll see. These are the. This is the scoliosis. This is pretty rigid, and it is probably it is 120 degrees, and we could correct it. This because of the just open surgery only. Other another case is a rigid neglected AIS case. You can see that it is 90 degree, 160 degree, and not much correction with flexion and extension. This we did it in two stages. Anterior first correct the lumbar, and then we went and do the posterior correction. Correction. That is the results. Maybe he has a scar in the back. Yes, but if you see the pre-op and post-op, I think this is can be accepted. There are the congenital scoliosis. You can get a different kind of scoliosis because there is a butterfly kind of things, hemivertebra, or a segmentation failure. So these are the cases if you need to take the excise the fragment of the vertebral body and correct it. I think it's better because we cannot play around. The spinal cord is in front and we are going side and getting the entire thing. I don't think it is safe. So the open surgery would be the. I will choose the open surgery. Sometimes you can get this kind of, you can see that the vascular vascular anomalies, and that also can come in the way while doing the cases. The post of kyphosis, you can see how much, early you can see the spinal cord there. So such cases without, you will see some dura only and some minimal compression, even the vibrations or drill itself can produce neurological deficit. So such cases better to have a open surgical surgery. Here also you see this. There is no spinal cord as you can see there. It is so compressed and stretched over it, and you cannot play around the spinal cord. I'm not saying that the simple disc and the simple the fusion cannot be done with cannot be done with the MIS and all. I am saying that the question is the end of the scalpel. That is the question I am answering that. I'm not saying I can see this is a child with a C6 tumor. You can see that a tumor. This I did a total colmectomy front and back, and then I did it something like this, so that I could preserve the neck motion for the child. That is the positive images you can see. Another case of ABC, you see the big tumor itself, and running fast because of the lack of time. Okay. So that is the picture. This is the reconstruction we did, and we usually C1 and C3. We are not touched even the occiput or OC joint or even the C4-5 joint at all. Another case of D2 codoma. So I did a total en bloc total spondylectomy for that patient. You see this kind of tumors. If this is I did it yesterday, I think. See this kind of it is reported as intramedullary tumor, but you can see that is not intramedullary. Probably it is a intramedullary extramedullary tumor, and it was extramedullary tumor. So we exercise in toto without much difficulty. Only thing we did the laminectomy. Actually, the laminotomy, we cut the lamina, and then we put back the lamina back and stabilize it with a small mini place and all. So we are not losing much there. See the extensive infection nowadays, you can see that almost up lower thoracic vertebra, they were involved. So I did a cervical-dorsal fixation. Another case, similar case like this, like the infection, the long segment fixation. This is a good case. This is an Ethiopian boy, 17 years. He came there with a scoliosis. We all thought scoliosis, but he had some neurological deficit, and MRI was showing this. The huge ependymoma sitting all over from D5 to S1, and he has a kyphosis, and all two bodies are good. So this is a big challenge because there is anchor points are very limited. You only up a few vertebral bodies available, and the lower L4, L5, and S1 is available. So I had to use because if you do something like that, there is a high chance of failure because there is no anchor points in the middle. So I did with the four pro technique. I hope that so far he is doing well, and how long that it's going to survive, I'm not very sure. And his neurological devices are improved. Trauma, sometimes you can get this kind of trauma, and I have no clue. It's very difficult otherwise to with MIS. Some severe compression. Another thing, if it is at 50% of compression, probably you can do MIS and all. But more than that, and the spinal cord is too much thinned out, I prefer open surgery. Okay, this is a case of CVJ here also you see that too much compression in the cervical dorsal spinal cord is not seen at all, and that is the comparison PTs. So what I'm saying is in high complexity cases and severe spinal deformities, high-grade spondylolisthesis, extensive tumors, and trauma, and most of the revision surgeries. And you showed that some cases revision can be done, but most of the revision cases you need open surgery, and the limitations are morbid obesity, severe osteoporosis, multi-system disease, tumors, infection recurring by debridement. These are the technical limitations like long learning curve, radiation exposure, complications as you mentioned, cost and efficiency. And the evidence are limited because there is the recent thing, and the biology of fusion, you see that that's the difference between the open and MIS area of fusion. So high chance of fusion failure is possible, and you cannot resect what you are seeing if the endoscope or the tube is not reaching up to the pathology, you won't be able to take it. So minimally invasive doesn't mean a maximally effective procedure, and the illusion and the clinical reality. There is not much difference in long term, and you are trading millimeter incision for identical long-term functional recovery. So I'm stopping here. The future is integration. You have to have MIS, minimally access, open surgery, and hybrid surgeries also. That is the future, and the scalpel should remain like it will remain. That's what my opinion. Thank you very much.
Thank you, sir. Please have a seat on the stage, sir.
Excellent. I think both the speakers have spoken about their forte. And Umesh, you have anything to counter his argument?
I think it's perfectly reasonable, and yeah, I completely agree that minimally invasive also cannot be done without the scalpel. We are not throwing the scalpel away, but I think as time progresses, we will be probably able to do more and more complex cases with MIS, or at least a hybrid technique rather than resorting to a completely open procedure.
Yeah, probably after a couple of decades, we'll be discussing the role of, there is a human surgeon, is there end of human surgeon or even surgery. We cannot say anything like that because all this AI are coming up in a big way. That may be here discussing today's scenario, not tomorrow.
Yeah.
We have showed examples from today's scenario.
Excellent. I think it is an apt topic. In fact, I'm very happy to be here in Satyasai Hospital because 25 years ago, I first started the minimally invasive surgery in this hospital. And from that day to today, so many surgeries are done in this place beautifully. And from my perspective, though I've taught many people so many things, I think the combination of the two, you have to know where exactly to do the open surgery, when to do the minimally invasive surgery, the most important for all youngsters. And the second thing is, as being a neurosurgeon, this debate is very apt for the orthopedic surgeons. But when I teach the orthopedic and neurosurgical colleagues, I find many neurosurgeons, when they dissect the muscle from the minimal invasive, is not just putting the screw. How you dissect the muscle, how you maintain the fat plane between the muscles and the periosteum, how beautifully you dissect ligaments, and how you not roughly manage the nerves and the cord is also minimally invasive. And I've seen some of the open surgeons, so meticulously they do. Even in the minimally invasive surgery, you can't do that. So it doesn't mean that minimally invasive surgery is just putting the screw, but it is advancing significantly. From the time we started to today, in fact, minimally invasive has expanded so much. With the robotics coming, pedicle screws are put by one of our juniors nowadays. And the rest of the open surgeries in the anterior procedures can be done. So the minimally invasive surgery is evolving significantly. And only way, where you cannot use it when there is a malignant tumors, where you have to take out all the tumors in and around, and in patients with the degenerative scoliosis, severe severity, or in kyphoscoliosis. I think these are the only two conditions where you cannot do minimal invasive, where kyphoscoliosis and a tumor excision where WB classification wise, you have to take out the periphery also, otherwise there is a recurrence. In such patients, open surgery, overrules the minimal invasive. You have anything to say with that?
I think a lot of thing has been spoken about deformity and why MIS is not suitable for doing deformities. And we can see a lot of papers coming up on different ways where MIS techniques have been used to treat even adolescent idiopathic scoliosis, as well as neglected scoliosis. For example, a combined anterior-posterior approach, which is done open. I think they have done a hybrid procedure where just a minimal invasive lateral approach for removing the apex vertebra, apical vertebra, and the rest of the things is posterior. Only at the apex you need to do a proper open surgery and do a proper osteotomy. Where osteotomy is not required, those levels can still be treated. So as I was telling that more and more applications are coming up in all the fields. Probably, I think infection, even I had slides on that. Cases which require a lot of debridement, cases which require redos, where multiple complex revisions are required. I think those are things that probably going forward also the technology may not be sufficient where we will be able to do MIS. But even PSOs, pedicle substruction osteotomies, PVCRs, everything has been shown, at least technical descriptions are there that it can be done minimally. Of course, it is still an evolving field.
Yes, thanks. Yeah. Anybody has any questions? Anil, you have anything to say?
I'm in complete awe of your minimally invasive skill sets because that's something, I didn't train on.
Correct.
I didn't know where the pedicle was when I was a resident. We just did laminectomy.
Correct.
And then at that time, if you look at ortho versus neuro, almost 90% of spine fusions in America were done by orthopods. Today, it's flipped completely.
Yeah.
So 60 to 70% of fusions are done by neurosurgery. And they've really pushed the field of the minimally invasive stuff. I think it's great results. I think you push the envelope. And it's better for, my friend Mike Wang does T-lifts under local anesthesia. He sends the patient home the same day, which is unheard of.
Yeah, correct.
Yeah.
Correct, perfectly correct. I think there is significant evolution with minimally invasive surgery. We have seen a tremendous evolution. I'm very happy that it evolved so beautifully because neurosurgeon, when I started the spine surgery, people used to wonder, why is he taking spine surgery? He doesn't have enough of brain surgeries to do. But today I can do both so much at ease. And we are teaching many more people how beautifully neurosurgeons can do minimally invasive surgery. I think that's the beauty with which spine is taken. With the use of microscope, endoscope, minimally invasive, we have acquired this field fantastically. Good.
Any comments from Dr. Kiran, sir?
I've just summarized the whole thing to put in a perspective. Some of the factors which I have found out over years, I was worked under Dr. Sajesh and we have utility using both, is, over years I have reduced of what can be done. It's more of importance of what we should do. That is what, which many things can be done, but what is ideally we should do in my hands. It may be literature may say this is safe, if time is same, but at my hands, what is safe? And how much it differs from what exactly is the standard. That's what in my hands, if the standards are same, what I'm comfortable with is. Another thing is over degenerative, even the best MRIs do not give the picture, complete picture. Even though we do all the cases correlative CT, it may not. So one of the advantages of open or microscopic, which we routinely do, is we can look around. There may be sometimes we have seen overriding lamina or facetal hypertrophy with spine, spicule and many other things, surprises, we can deal with it. And more so in cases of tumor others, the time taken in my hands, other things, and the learning curve. Of course, nowadays, even from PG days, you start with many years. If those people, it is okay. Is it worthwhile the difference, especially in a microdiscectomy where incision is same almost in both the cases, and whether is it worthwhile the exposure of radiation, other things. And ultimately, it is our own introspection and reality check of what is good for the patient that we need to do. And over years, I think as Umesh has said, we see a lot of literature workshops on minimally. I think now regular microsurgery, everything is a part of curriculum. So many feel that it is not needed. I think that may be one of the reasons why we don't see so many workshops on, regular spine fixation. All said and done, I think both have its own utility, and I feel both have its own future. And of course, scalpel for a surgeon remains the pole star along with every other technique revolves. Thank you.
Thank you, sir. I thank both the speakers and the moderators for making this a very stimulating debate. I request the moderators to hand over a memento to Dr. Umesh Srikanta. I now request the moderators to hand over a memento to Dr. Sajesh Menon. I request the moderators to stay on stage.
The next topic is redefining precision, robotics navigation, the next frontier in spine surgery by Gandhi Verma. Gandhi is here.
So he is presenting his topic remotely. He's in the
Online.
US.
Okay. So if you know, the Gandhi Verma was the first student of our DNB student at that time in Satyasai Hospital. He graduated under us, and very proud to see him, now, but he has gray hairs now, but he's still a young man. Gandhi, over to you. Gandhi, can you hear us? I'm not able to hear you. Really? Can you hear me? Yeah, I can hear you. Yeah, I can hear you. Can you hear me? We can hear you, but can't you hear us? Can you hear now? Yes.
System throughout the surgery. Preview, which shows the extent of the extent covered with one single spin, which reduces the amount of the X-rays which we need to take before the spin. Also, there are two different type of field of vision available. The one is 15 into 20 centimeter, another one is 15 into 40 centimeter. The 15 into 40 centimeter usually helps for a iliac screws as well as the sacroiliac screws. Also, the recent OR images can cover up to 43.8 centimeters. So with one single pin, we can cover feet into ilium. Once we transfer the images to the navigation system, verified accuracy and navigate and use the pedicle probe or the screws. There are certain disadvantages. Dependency or failure to verify the accuracy can lead into a malposition of the screws, or movement of the reference array during the surgery can cause the errors or poor techniques. We can use variety of starting from C1 to almost iliac screws with the navigation. There are a lot of literature support available for more than 20 years now. They're all demonstrated a very good accuracy up to 97 to 99% with the navigation. For radiation exposure, in the olden day study, they compared fluoroscopy versus the navigation. They thought that the radiation risk is higher with the intraoperative spin. But currently, when they do the intraoperative the imaging, the surgeon is outside the room, so our exposure to the radiation is very, very less. When it comes to the cost effectiveness, initial capital cost is definitely more compared to the CR fluoroscopy. And also there is a capital, the disposables as well as the everyday cost. But it avoids the revision surgery rate significantly. The average cost for revision surgery in the United States per year is approximately $40 million. So lot of studies correlates or suggest the navigation is cost effective for high volume centers. If you do 250 cases or more navigation per year, this is very cost effective. So lot of literature currently supports the more accuracy, less radiation, and the navigation is cost effective. When come to robotic assisted navigation, there are three types of robotics available currently. One is supervisory controlled system, telesurgical system, and shared control system. The shared control system is the commonly used one, which determines the stereotactic trajectory using preoperative and intraoperative imaging. The advantage of robotics, this offers improved accuracy compared with the traditional freehand pedicle screw insertion techniques, reduces radiation exposure. It enables minimally invasive applications. The robotic systems can overcome human limitations by improving the precision of tasks that may be affected by the fatigue, tremor, and repetitiveness. There are varieties of navigation, the robotic navigation currently available. Almost most of the spine companies are making it. The first one came as a Maser X from Medtronic, and followed rows up Exelucius GPS from Globus. This is the new generation robotics in spine surgery made by Johnson & Johnson called Valis, which is designed for the enhanced precision. This actually uses the active robotic technology, which automatically adjusts to the patient or the bone or the tissue movement during the surgery, especially with the breathing, it actually moves. The adaptive tracking, that is high-speed camera and pure sight optical reflectors to maintain the proper pre-planned alignment throughout the procedure. This is a short video of the newer version of robotics, which uses the adaptive technologies. So the robot moves actually with the movement of the patient, which can very helpful to minimize that few millimeters of error and screw placement. Robotic arms not only helpful for placing the pedicle screws, it also helps to adjust the screws and lineups, also helps in rod placement and planning. But people have started using robotic arms not only just for the pedicle screw placement and more than that. And the first in the world robotic assisted spinal surgery, especially the end block resection, was done in 2018 from Penn Medicine. Now, commonly people are using for MI screws placement and also for the probe placement for a lid procedure or ablations in tumor. There are certain disadvantages like other navigation. This also need a bigger OR footprint, preoperative planning time, increased OR workflow, and cost effectiveness. But in the future, we are maybe get better with the small corridor surgeries, allowing the movement not physiologically possible with the human hands with the articulated arms of robot, potential for remote surgery, and also currently we don't get a tactile feedback, it may come. The goal for the future is the surgery performed by the robot and supervised by the surgeon with the increasing indication for MI corridors, which is not currently accessible, and increased precision and reduced errors. There are studies shows the screw accuracy rate with the robotic arm is pretty good, more than 97 to 99%. Almost all robotic data shows average of 96 to 99% screw accuracy. When it comes to augmented reality, it enables a real-time user interaction across virtual and the real-world objects. Again, people are doing screw placement, the surgeries, the intradural tumors, actually extradural tumors, in-block resections with augmented reality-based navigation. At the end, the value of spine navigation, definitely it gives us safety by avoiding a neural or a vascular injury. It reduces the radiation exposure for surgeon. It reduces the cost by reducing the war time and avoid revision surgery. And also it helps for the marketing. I conclude with my own experience. Definitely navigation is very easy to use. It helps a better screw accuracy. Very helpful in thoracic and upper cervical and iliac screw placements. Very useful in deformity correction and spine tumor surgeries. It reduces the war time and radiation exposure. It's cost effective in large volume centers. Robotics is definitely helpful in percutaneous screw placements. I don't see a major advantage in open cases. Maybe in the future, when we commonly use for laminectomies or facetectomies and deformity correction, maybe it will have a better arm than the conventional navigation. Again, I conclude that technology is not a replacement for anatomical or clinical knowledge. Using the technology wisely will definitely make our workflow better and also gives a better clinical outcome. I also take this opportunity to invite all of you to attend Cleveland Clinic's Spine Review Cadaver course. Happens in July 2026. If anybody interested, feel free to communicate. I'm happy to take any questions.
Any questions from anybody? How many of you use navigation here in your center? Yeah, very good. I think almost about 30% of the people. Yeah. Gandhi, very nice talk.
Thank you, Chief.
And you have concluded very well, because the navigation as of today is useful to reduce the time, increase the accuracy, and to reduce the radiation. And tell me in how many cases you pushed the navigation and used your own anatomical knowledge?
Very good question, Chief. Even when I started the fellowship, my mentor always says, one chance for me to keep the navigation flow, make sure that I'm in a perfect anatomical trajectory. So from that time, I always think anatomically before I keep my probe, and I use navigation as a secondary one to make sure that my screws are going in a perfect alignment and orientation, what I want to. Yes, sometimes if the anatomical correlation is not happening, the navigation shows, I just to take away the navigation, I do a freehand screws, or I re-register or re-spin, just if it's a critical one. Yes, it do happen. Maybe we disturb the DRA without knowing it, or sometimes obese patient with a very small incision, so sometimes the skewing can happen. There are a lot of times the errors can happen still. So anatomical knowledge is very, very important. If your anatomical judgment is not correlating with the technology, I obviously abort the technology and use my anatomical.
Excellent. And how often use robotics for cervical?
We just use for some of my partners use more. I use for I do very few MIS cases. So cervical, we are not routinely using currently, at least not me. Yeah.
Yeah, because I've too used it, but cervical, the problem is the angulation of the pedicle. Usually use it for the pedicle screw fixation.
Yes.
But it has to be much more angulated with robotics, and it requires multiple stab incision, and we can't do with the exposed incision.
Yes.
So in that way, it is not useful in the cervical. As of today, robotic is useful mainly for the lumbar cases. And beyond that, I'm not finding anything useful. So as you said, the cost effectiveness comes down significantly when any equipment is used only for the limited use.
Yes.
More so in India.
Yes. I agree with you, Chief. Yes. Maybe lower thoracic and lumbar, it's pretty good.
Yeah.
As I said, open cases, I don't see any advantage at all. It's more hindrance than any good. But MIS cases, the recent ones, it's really very useful because you just make a stab incision and just make a pilot drill hole, and then straightly you can put the screw straight. So you don't need to use the navigation probe or a tap or anything like that. So it saves a lot of time. If I'm doing a MIS screw placement like a T10 to helium or something like that, it makes your workflow very quick and easy. You can put all the screws within a few minutes than using the conventional navigation or the fluoroscopy. I see an
Perfect. And
advantage
it'll be done
there,
by the
but not
residents.
for regular.
It'll be done by the residents, right? If the robotic is there, residents
Yes.
can do the flow very easily, and they can put the screw. And as a surgeon, you can do the T-lift work or O-lift work.
Yes.
Yeah, that's good. Okay. Anybody has any questions? Anil, you want to give any tips for navigation?
I tell you, it's become a resident-run thing now. I just did a thoracic fusion last week with a trauma call, and with the residents, it's like a video game. Boom, boom, boom. You know, we just and the problem is, I had a case 2 years ago where the system O-arm was down, and the thoracic screw placement was not perfect. You go by AP lateral, it's not as good. So I think this is a standard of care. It's a safety issue now.
Yeah. Good, Gandhi. If no questions, we really appreciate your presence here. So next time you should be physically here.
Definitely, Chief. Yeah.
Okay.
My visa appointment got cancelled, Chief. The next appointment is only in May. If I come, I can't return until May. So.
Oh, no, good. You took a good decision.
Thank you, Chief.
Good.
Thank you, sir.
Thank you very much.
Thank you.
We now move on to our second debate of the session. It is a discussion on aggressive versus a less aggressive approach towards CVJ anomalies. Speaking for an aggressive approach is Additional Professor Abhidas Shah from KM Mumbai.
So good afternoon, everybody. So as you know, I come from the department that has shaped craniovertebral junction surgery for the world. So to start with, CV junction surgery is not surgical aggression in a generic sense, but rather how understanding and surgical strategy and individualized planning influence outcomes in patients with complex craniovertebral junction pathology. The aggression lies in recognizing the atlantoaxial instability. Craniovertebral junction surgery is surgery that is philosophical, it is surgical understanding, anatomical understanding, and it is a skilled surgery. It is fast driving, but it is not rash fast driving. It is skilled fast driving. So let me just go through with you about the history of craniovertebral junction surgery and how we use passive or skilled aggression in treating these patients. So even though first cases of basilar invagination were diagnosed radiologically in 1911, they remained anatomical and radiological curiosities because no one knew what to do with them. So in 1964, the Department of KEM at Mumbai published this paper where they reported craniovertebral junction anomalies and how to recognize them and how to treat them. It was this paper that changed the surgery for craniovertebral junction anomalies professed by Professor Goel, where he advocated plate and screw fixation for atlantoaxial subluxation. So this is the technique: opening up the joint, denuding of the articular cartilage, stuffing the joint with bone chips, and then doing a lateral C1 lateral mass and C2 pedicle screw fixation. While doing these procedures, it was realized that the joints are not fixed. There is nothing like a fixed atlantoaxial dislocation. It is mobile. You can manually manipulate the joint and make the dislocation reducible. So this was that technique. This was extrapolated. Here you can see a patient with fixed no movement during flexion and extension, but you can see that the joints are maneuvered and the reduction is achieved. This was extrapolated when it was realized that basilar invagination is not a fixed anomaly. Before this, basilar invagination was either being treated by transoral surgery or by foramen magnum decompression. This paper changed the treatment of basilar invagination, where it was realized that it is a problem of the joints. This problem is mechanical instability. The joints are not only abnormally inclined, they're not only fixed, they're mobile or hypomobile. You can see the configuration of various joints that you see in patients with craniovertebral junction anomalies. So basilar invagination is a disease of the atlantoaxial joint. It is dynamic and progressive. It involves increasing slippage of the atlas over the axis, and it has to be treated by craniovertebral realignment, distraction, and fixation. So just to show you a few examples, you see the basilar, you see the realignment and fixation. This is aggression. This is aggressive surgery. This is the patient I did recently. You see the basilar invagination. You see the course of the vertebral artery, which is quite anomalous in this case. You see the position of the joints, but you see the result. This is aggressive surgery. But when do you have your control over aggression? You aim for craniovertebral realignment, but do not go after it. That is where the misadventure might occur. So you accept an incomplete reduction. As long as the patient is clinically better, you aim for a realignment, but the stabilization is more important than a realignment. Once you've addressed the atlantoaxial instability, the patient will clinically improve. So here you can see the basilar. There is definite reduction. It is not a complete atlantoaxial realignment, but that is acceptable because the patient is doing clinically well. So this was our large series on patients with group A basilar invagination. Now, when we were doing these cases, it was realized that a lot of neuromusculoskeletal abnormalities reverse after you do craniovertebral fixation and realignment. As you can see, the torticollis has reversed in the immediate post-operative period. This was then further, you can see some neck deformities that are being corrected just by doing a craniovertebral realignment and fixation. Here you can see the torticollis reverses in the post-operative period. You can see the neck lengthens in the post-operative period after treatment of basilar invagination. Looking at all these changes, it was realized that the whole process of basilar invagination, whether all these neural and musculoskeletal abnormalities that occur in basilar invagination are protective, and they can all be reversed by the process of atlantoaxial fixation. So you can see this atlantoaxial facetal locking. This was rotatory atlantoaxial instability. A lot of, it was not known what to do with this. A lot of people used to try a closed reduction or give a hard collar. It was then realized that manipulation of the joint and realignment, differential manipulation of the joint and realignment can reduce this facetal locking. As you can see the facetal locking in these images, and you can see the patient has improved in the post-operative period clinically and radiologically. So these are various techniques that we have used in the process of fixing the craniovertebral junction. Various permutations and combinations have to be learned. We used to use joint jamming, the use of spacers in atlantoaxial joints. We have realized it's not necessary. Bone graft is enough. The fusion is important. The stabilization is important. So basically, the whole problem of instability in the atlantoaxial region revolves around the facets. You don't just look at the atlantodental interval. You have to look at the facets. It's the facetal malalignment that is responsible of the instability. This was a recent classification where we called these three types of facetal malalignment. Type 1, where the atlas is in front of the axis. Type 2, where the atlas is behind the axis in neutral position. And type 3, even when there is no malalignment in the atlantodental interval in the facets, but there are neural and musculoskeletal markers of atlantoaxial instability. So this is what is recognizing atlantoaxial instability. It is subtle chronic atlantoaxial instability that are causing all these markers. They are presenting as these markers, and the treatment of this is not treatment of those markers, it's the treatment of atlantoaxial instability. This is our recent paper on the subject. I'm not going to go into these divisions of central atlantoaxial instability. I'll just quickly run through a few examples. So this is group B with Chiari and syrinx. Group B basilar invagination used to be treated by foramen magnum decompression, not anymore. Just atlantoaxial fixation. See the reduction in the syringomyelia with the clinical improvement. Coming to Chiari. Chiari, people are questioning, why are we doing a C1C2 fixation? Foramen magnum decompression might suffice. But you look at our results. I'm in a position of surgical equipoise. If I know my technique is going to give this result, I'm not going to do a foramen magnum decompression. So this is Chiari, no bone abnormality. You see the Chiari, the syrinx completely reversed 6 months down the line. Patient doing clinically well in the immediate post-operative period. This is a patient I've done about 2 months back. This is a MRI 48 hours after surgery. See the reduction in the syrinx and the resolution of the Chiari, just treated with atlantoaxial fixation. This is again another patient that we have done resolution of the syrinx. Now, because so many times it was being questioned that where is the instability in Chiari, we started doing dynamic imaging. Before that, the question of failed foramen magnum decompression. Your patient comes back to you after a failed foramen magnum decompression. What are you going to offer to him? A C1C2 fixation, because that is going to take care of the problem. We did this to see the recovery of transcranial MEPs after doing the fixation, and these were our results. The MEPs improved by 30 to 40%. Coming back to the status of dynamic imaging, we have seen in patients with Chiari, there is rotatory atlantoaxial instability. See the overlay, see how the facet is actually gone off the facet of atlas or axis. It may be unilateral, it may be incomplete, it may be complete. But the key is identifying this dynamic instability and treating the atlantoaxial instability by C1, C2 fixation. Here you can see the rotatory instability in these images that I've shown. Also for syrinx, idiopathic syrinx, when there is no other cause for the syrinx, if the clinical presentation is at the craniovertebral junction, you do a C1, C2 fixation, the syrinx will resolve. So this is what is aggressive surgery. In pan fusions, even though there is no atladodental abnormality, if the patient is symptomatic, if there is torticollis, you go ahead and do a fixation, the patient will improve. C2-3 fusion, indication of C1, C2 fixation. Another 2 minutes, please. Then pan fusions, here you can see the instability. The surgery is difficult because of the short neck, but you do the stabilization, the patient will improve. Bifid arches, only bifid arches. Patient is clinically significant. No change in atlantodental interval. There is lateral dislocation. Identify this lateral dislocation and treat the instability. Here you can see revision when patients come back to you, operated probably by some other technique. If there is fusion, then again, as I said, there is precise aggression. If there is fusion behind, do not attempt it. But if you see there is mobility and there is no fusion, you can go ahead and you can see these beautiful results of our series of revision of craniovertebral junction surgery. The last one, this is completely central atlantoaxial instability. Look at this image. There is just rotatory instability. This patient comes to you. The marker, the clinical marker is craniovertebral junction. Most of this paper will be written off. Now you can go back and read these papers. There are certain neural and abnormal and endocrine, and there are a lot of clinical markers that will point to the central atlantoaxial instability. You do a dynamic imaging and you will see the instability. I will just show you this one video to end before I end my presentation. This is a patient. Just see the walk-up. The imaging is right in front of you. The dynamic imaging is just showing rotatory atlantoaxial stability. There is no change in atlantodental interval. Everything looks okay. This is
Okay, go back.
Yeah. And now this is the same patient, day 10 of surgery. Playing. Is it? Just one, it's the last video. Just play it from there. Yeah. You can play it.
Come.
Make it full screen. Make it full screen and then it'll play. The last video, just from the beginning. Yeah. Just go to that slide. No, up over 50 or something. Not this. Go, up. Go. Yeah, this. And do full screen.
Come. Absolutely normal. Go back, turn.
Okay, it's playing. This is the patient, same patient, 10 days after surgery. You see the dramatic clinical improvement.
Absolutely normal.
Normally.
Go back,
This
go
is
back,
what
go
it
back,
is.
turn.
It is recognizing this central component of atlantoaxial instability. You recognize this and you will give new life to this patient. So this is just a few cases that we have done. So craniovertebral junction surgery, as I said, it is aggressive surgery, but it is planned, skilled aggression. And once you do it right, these are the results that you will get. And if you do it wrong, you will have a bad patient on your hands. Thank you very much. I'd like to invite you to the 15th ACNS, which we are hosting in July, August. Thank you.
Thank you, ma'am. We now invite Dr. Nupur, Professor Neurosurgery from NIMHANS, to speak for a less aggressive approach towards CVJ anomalies.
Thank you, organizers, especially Dr. Sarita. I'd like to tell, as a senior and as a faculty of NIMHANS, we are really proud of you, what you have done. There's no point arguing with Abida here. The only thing I have for her is respect, not only for her, for the institute where she works, and for the man with which she has trained. So I just will bring a slightly different perspective. There is significant paucity of literature. I mean, despite numerous publications which this country has published, especially the Abida Center, but still you have to understand that there is paucity of literature. Ultimately, the outcome for our patients is what matters. JCVJS 2017, top 50 most cited articles on craniovertebral junction surgery. Proud to say that we have 3 or 4 articles from India, and no prizes for guessing from where the articles are. But if you read the last line in this results, the significant majority of the articles were designed as case series providing level 4 evidence. What is the problem? I looked from my perspective, and I think best is, I think I should give my institute data to you. And Dr. Rajesh Krishna, one of our very hardworking residents who finished in 2016, did his thesis in which he over a decade of our experience with posterior screw and through constructs, he evaluated all the data, and we got some interesting results. So I think which is has been very beneficial to us in our practice itself. Unfortunately, it's not published. So we divided the cases in which there were 110 cases of screw and rod constructs by that time, and we divide them to 3 categories based on the reduction of AAD and BI in immediate postoperative scans. So if I see a measure of aggression is radiologically how well you have reduced your AAD or BI. So good, almost 84%, 92 cases achieved complete reduction of AAD and BI, but 12.7% of cases achieved partial reduction. 3.6% of cases did not achieve any reduction at all. This was a 3 to 4 surgeon case series. Very good follow-up. I think 20.1 month follow-up for any kind of spine study is good. In that, we can say that 80% of our patients improved. Status quo was 19% and 3 patients percent. Follow-up was available for almost 102 patients. When you compare, things are not that bad. I mean, even for neuric grade 5, if you just look at the last row, there were 19 patients with neuric grade 5, 19 with neuric grade 4 also. I mean, these are patients who are almost wheelchair bound or bed bound. After these surgeries, out of these 34% gross, there were only 15% who stayed in that neuric grade 4 and 5. So there is good amount of improvement after these surgeries, which you need to understand, and that is why you have to make all the effort to get to that level to doing these surgeries almost without complications. And that's what Dr. Abida also talked to you about. It's not easy, but yes, if you do it, these are the results you will get. This is an interesting slide, looks a bit complicated, but I'll just simplify it for you. Do we have a pointer here, please? The slide says when you do partial reduction and when you do complete reduction, what is the difference in outcome? So if you see the first row, it's neuric grade recovery rate. The slide is gone. Okay. Thank you. So if you see this slide, partial reduction, there's a 22.5%, 24.5 numeric grade recovery rate. But if you do complete reduction, there is 50%, the numeric grade, and it is very close to statistical relevance, though not exactly. But when you check GOA recovery rate and the neck disability index recovery rate, it is definitely statistically significant. So the amount of reduction, I think it matters. Unfortunately, we don't have great data on this. But as per this, our own data, we can say that partial reduction versus complete reduction, there is a difference in neurological outcome in these patients. And I think that's what matters to the patient. So we need to strive hard to understand these pathologies and to aim for as good reduction as possible. I know complete reduction is not possible in all of them. What about the role of bone effusion? As per this study, we got a 88.2% bone effusion rate. Unfortunately, the relation with the outcome was not studied. The relation of bone effusion with the outcome, or to simplify things, patient who got a bone effusion, what did they have a better outcome? We did not study in this series. So quickly, I'll just show you a case which will stress upon you the importance of bone effusion. This is a boy 15-year-old boy who came with symptoms. We have his own surgeries. So this was his initial surgery, before initial surgery, of high grade baseline imagination with AAD. This is pre-op dynamic CT. I'll just rush through these slides because I just want to come to the point where I this post-traction X-ray. He was operated. Operated in an outside center where we got these images. So I'll just come to that. And this is the immediate post-op of the first surgery. Great. I mean, I don't see it's a bad surgery at all. It's a very good, the dents was somewhere here. It has come down to this level. And there is a AD, but still, I mean, I will accept that. All the screws are in perfect position. But local bone graft is used, and see what happens at 5 months. Everything gets collapsed, comes to the same level. So this was the immediate post-op scan, and see at the end of 8 months, everything has come back again, and patient has become more symptomatic than what he was at. So why did it happen? How did it happen? You need to understand, and this is what patient has also got lower cranial nerve syndrome and worse quadriparesis than what he had previous admission, and now he comes to us. We put him on traction, we get some kind of a distraction. We see his vertebral artery CT angiogram, again, a very important investigation. You see both the vertebral arteries on both the sides are, if you want to address these joints, they are just sitting behind the joint if you want to address them. And remember, this is a re-exploration case. So I'll just quickly come. So what I planned was, I thought the screws are in great position. The surgeon has done a great job with the screws, so I'll keep the same screws. But what I will do, I'll just add to a little more distraction and add occipito C2 laminar screw fixation. It still remains a C2 fixation as the C1 C2 fixation because C1 is assimilated, as you can see. And that is what I achieved on day 1 after the second surgery. But what I did in addition to this one thing is I added this small occiput single hole plate to a laminar screw here, which you can see here. I'll be finishing very fast. The only thing I added was this strut graft from occiput to C2. And that is what, in my opinion, worked. He went on to have a fusion, though he had tracheostomy. He walked out of the hospital despite being bedbound. And you can see these results you can see by the time of discharge. This is his scan at 4 months. Yes, not a very ideal reduction, but yes, solid bone effusion is there. And that is what mattered. And this patient improved. And at the end of 9 months, you see the fusion at that 9 months, and patient became perfectly ambulant and independent. This is what we published, our series of around 20 cases, surgical strategy and decision-making in recurrent atlantoaxial dislocations in World Neurosurgery, I think last year. Let's learn from our neighbors. Do we need to really break our head for this perfect reduction? The lumbosacral spine is not very far away. So the debate in lumbosacral spine, high-grade lumbosacral spondylolisthesis, whether we go for partial or complete reduction. Still, I don't think the jury is out. I'm no expert on this, but I don't think jury is out. There are benefits and advantage disorders of both. People who go for partial reduction say that definitely the neurological outcome, especially it is safer for the L5 route. And in complete reduction, there's a definitely significant higher incidence of the C5 root palsy, maybe temporary, maybe permanent. Another thing which is not studied at the level of CV junction is the relevance of cord signal changes. I think all of us in our audience whosoever does these cases, we have cases in which we have beautifully reduced these dislocations, but still patient is not neurologically improved. Yes, if you go back, a lot of these patients have cord changes, cord signal changes, and that is the reason, which is very well established in cervical spondylotic myelopathy, the prognostic importance of cord changes. So this is again something we need to review in CV junction and probably get it to light. The last word always belongs to the master. And I asked him in one of the webinars directly, what is more important? And he told, anatomical realignment is great, but what ultimately benefits the patient is bony fusion. I hope people will remember this. Thank you very much.
Excellent, Abhida and Nupur. Anybody has any questions? Questions, comments? So whatever they have presented, you have?
Yeah,
please.
one second. We do quite a few CV junction anomalies here, and I agree with you about this strut graft. In fact, it's gotten to the point where we routinely put strut grafts for all patients, because we have seen patients who come on follow-up where the CT done at follow-up shows sometimes surprising degree of resorption of the bone in the joints. And what takes is a strut graft in the middle. So we have started doing that for almost every case.
Kiran, you have anything to say?
Both of you have presented almost, not versus, it is a complementary thing. The main is to have an open approach. That means the open-mindedness. In fact, even Cherry, when we discussed with Dr. Atul Goyal, when he presented his fusion, we were a little skeptical. And we started off with recurrent cases. And to our surprise, we have shared the images, the syringes disappeared. And afterwards, now we do fusion in almost all cases with Cherry and extensive syringes. We haven't got that much, guts to go for routine all Cherries. Of course, it is a bony fusion, which ultimately matters, as Nupur has told. Even in many cases of partial reduction, patients have done well. So that is one good thing. And main is to have boldness and to approach, because unlike other cervical myelopathy, this will give very good results, regardless of even when they are very high grade neurics. Post-operatively, they do quite well after the stormy post-operative period. So the aggressiveness comes in approach and appreciating the anatomy and the will to do the what is best for the patient. Thank you.
With the last picture of yours, what is the anatomical substrate with which patient had that kind of a gait?
Cervicomedullary junction. So we've seen a lot of these patients who come with very weird clinical symptoms. Some of them have been labeled as psychiatric. So there are some keys in this. Some of them have suffered a major trauma some years back, where the instability didn't occur occultly. I mean, it was occult. It was not very obvious. It was neglected. The patient worsened from the trauma down. That is one. There is another subset where there is not much trauma, but still the symptoms are there. They're a combination of neurological symptoms, autonomic symptoms, then symptoms like brain fog, confusion, ringing in the ears, visual ataxia, then stiffness in the legs, tingling in the necks, bladder bowel complaints. It's a whole symptom block of complaints. If this constellation comes together, you could look at the atlantoaxial joint.
And MRI-wise, you don't find any problem related to anywhere?
No, you've seen the images. But rotatory scan will show you the instability.
Instability in
Yes.
these patients. I think, CV junction is one of my favorite subject also. So what is required for the CV junction? The main thing is the mobility of the junction creates so much of problem. I think main aggression is to release and to realign. Every surgery, because it's extradural component, extradural compression, 95 to 98% of patients will always recover irrespective of their neurograding if there is a realignment is done and reduction is complete. So I think releasing this whole joint is the key in these patients. The releasing varies from each procedure. For example, in some patients, just putting a traction, it can get released. In some patients, the high grade, whatever you see, the grade 3 sublux, in that patient, you had to do it under GA. Sometimes it reduces. In some patients, you have to openly reduce that from posterior, if not anterior, put them in traction and re-release. So sometimes it takes 24 hours. Many of the times, it can be done on table, releasing the joint. I think this releasing the joint and realigning and distracting the joint is the key in CV junction. If you achieve that, and how much time you spend patientfully to do that, I think that is the result. And the results are always fantastically gratifying. I think that is the beauty of the CV junction. You can't compare this with the lumbar listhesis. The reason being, yes, both are junctions, and because CV junction and the lumbar junction happens because of the bipedal nature of the human being. The reason we cannot completely compare the lateral joints of the lumbar region versus the cervical is, cervical there is a cord, whereas in the lumbar region, it is just the last few roots. Second, the Baxton plexus, which drains from below to above, which will have a significant compression in those patients, and venous edema is common in the CV junction compared to the beginning of the venous plexus in the lumbar region. Otherwise, anatomically, it looks the same. And even in the lumbar listhesis, we look at the joint release first rather than the reduction. So after joint release, jacking up we see. Similar way, if you do it in CV junction, many of them can be reduced very well. And who does it, how you do in the first stage is the key for this success. I think the first surgery should be the best surgery. I completely agree.
Paritosh. Yeah, I have a general question to all the panelists and everything. And I come from the vascular background. And whenever we introduce any new procedure, it is investigated threadbare with randomized control trials, with multiple randomized control trials, not just one. Why is it that CV junction evidence is, I say so, so it must be true at that level? I mean, you have thousands of cases. Why is the evidence not better?
Abhita, you want to answer?
The evidence comes from mainly our country. And some locations, CV junction, complex CVJ anomaly is not very common throughout the world. That is point one. Second is not many people are venturing into it. They will get away with doing some anterior transoral when combined with the fixation. They're not actually addressing the pathology. It is our country actually that is dealing with this CV junction anomalies, and we are the answers. Everyone has a different way to do it, but they see the clinical gratification. And, that's why they carry on with the technique.
Every case is, as Abhita told, the most common pathology in India is congenital CVJ. You look at all American series and other country series, there's trauma and rheumatoid arthritis form the major bulk of all the pathologies. So congenital, every case is very different. I mean, you cannot apply one formula for any. So
okay, let me rephrase.
Yes.
There is a standard procedure for Chiari malformation with syrinx.
I'll come to that. So
there is a new procedure which is introduced. Now, whether the new procedure is better, good, or worse than the other procedure must be tested with a randomized control trial. There is no confusion regarding this.
Yes,
and this is a worldwide problem. This is not an India-supposed problem.
Yes.
So why is, I'm not saying about India, why is the CV junction community in the world so averse to better evidence?
So I think WFNS consensus, would you like to tell about it? WFNS consensus meeting is already, they have done that. I think it's already out. It's out.
Come up with the consensus on basilar, on Chiari, on a lot of craniovertebral junction anomalies. But again, it's a group of craniovertebral junction surgeons around the world who have come up with these guidelines and consensus. And it is based on what data is available. As you said, there are no randomized trials. And I think it is probably we should be doing the trials because we have the most number of cases in India. I don't know how to do it, but probably we should be answering this randomization.
So with permission of the chair, we did attempt randomization, and I know in PGI, Dr. Praveen Salunke also did it. We did not find, for Chiari, for pure Chiari without any BI or AAD, and we did not find, but that sample size was very small, 10 on 10, and we did not find any significant differences. For example, the disappearance of headache as a mild symptom. In Chiari, after fixation, as we would hear that, okay, the headache disappears after instrumentation, we did not find that. it's too small a sample size, but I agree that a randomized control trial should exist before we adopt the strategy universally.
Just as a closing remark, some studies or some cases we can't have a randomized control. For example, you have to find out the efficacy of parachute develop. Whether parachute works or not, we can't have a control. So similarly, of course, where there is a reasonable standard of treatment, then we can compare it with a newer one. And CV junction before this evolution of Atul Goel and others, the difference was drastic, the outcomes and other things. So most people, and because of the complexities, they keep on adapting, as they say, because once you see so many things. But ultimately, whether now, before we were, very particular about complete reduction, realignment. Now we are not so much, because and perhaps the randomized control study may throw more light at how much of a reduction is more effective. But of course, whether to find out whether some of these surgeries are useful or not, we may not get randomized control study at all. Thank you.
But in science, as you said, having a randomized studies is most important to prove, what is correct, what is not. I think in CV junction, there is no doubt about presence of the Atlanta axial dislocation, basilar nerve what is the gold standard? Is to see C1, C2 joint jack up, stabilize. There is no doubt in the word. But there's a doubt in another thing is whether to add the occiput or not. There is significant debate, because for last 78 years, I have stopped using anything in the occiput, because more you mobilize C1, C2 joint, fuse it, sure, there is no need of doing the occiput. Rather, you're restricting one more joint, which creates the problem. But there is no consensus on the syrinx, the purely reason being, there is significant study done previously about simple extradural decompression or open decompression, shrinking the tonsil. But CV junction, when you fuse it, ultimately what we are doing in this region is to give enough of space for the CSF to go in front and back at this CV junction. Whether you jack the C1, C2 joint or you decompress the posterior space, ultimately we are redistributing the CSF going in that region so fluently so that there is no stenosis happen and venous congestion happens. But that doesn't have a significant kind of correlation in the world for the randomized study. I'm sure over a period of years, finding out this, maybe with all these debates, we will come up in the future.
More and more people are started venturing into it and using it. We will see more results coming up, and then probably we'll get more answers.
Thank you for that excellent and thought-provoking debate. I request the moderators to hand a small memento to Dr. Abhidas Shah. And to Dr. Nupur. Thank you, ma'am. Thank you, sir. I request, thank you, ma'am. Thank you, sir. I request Dr. Sarita to hand over a memento to the moderators. Round of applause, please. Thank you very much. Coffee and snacks have been arranged, but we will be proceeding with the next session concurrently in order to make up for lost time. Please find the helpers. Thanks.
So from the spine, we move back to the brain. That was a very exciting session on the spine. So this session is on neuro-oncology. So I'd like to call the panelists here. First, the moderators, Dr. Anand Balasubramaniam and Dr. Vishwanathan K. Dr. Anand Balasubramaniam is the HOD and Senior Consultant at Amrita Hospital, Faridabad. And Professor Vishwanathan is the Head of the Department of Neurosurgery at Sri Ramchandra Medical College, Chennai. So the panelists for this session are Dr. Suchanda from NIMS Hyderabad, followed by Dr. Shyam Sundar sir from Kidwai Memorial Institute of Oncology, Bangalore, and Dr. Manjunath and Vaidehi Institute of Medical Sciences, Bangalore.
Yes, done.
So we have a few cases for discussion in this panel. The first is on recurrent gliomas. So when gliomas come back, so what do we do? The first case is a 48-year-old male who had a multicentric lesion in the left frontal and right insular regions. And he presented to us with recurrent seizures for 3 months. He got operated at our institute in March 2020. He underwent a left frontal craniotomy and we did a near total excision of the left frontal lesion alone. And it was, as expected, reported as a glioblastoma WHO grade 4. The IDH status was not done. So this is the scans, T2 and FLAR images showing lesions in focus slides. T2 and FLAR axial section showing lesions in the left frontal and right insula. And not much of contrast enhancement, just a patchy enhancement on the superficial areas. So this is the post-op image showing subtotal to near total excision of the left frontal region. The right insular tumor is still there. And since it was a glioblastoma, we referred for immediate RT and he underwent adjuvant chemoradiation at Manipal. 59.4 gray given in 33 fractions, VMAT, along with 6 cycles of temozolomide. We had subsequent follow-up images in 2021, 22, and 25 May, showing that there's no recurrence and maybe a little increase in the FLAR changes between 22 to 25 images. But he again came 4 months after that May scan with the seizures again, and he had an enhancing recurrence in the left frontal region. So interestingly, in the follow-up scans, we see that the insular part of the tumor also has gone. It was also radiated and that also has vanished, the subsequent imaging. So what would be the plan management of the recurrence? So we went ahead with the left frontal recraniotomy and fluorescent-guided radical excision of this lesion. This was in September 2025 when he came with the recurrence. So his KPS score was good. He had presented only with seizures at that point in time. So this is the post-op image showing near total excision. This was the histopathology report, which was again reported as an IDH wild-type glioblastoma, CNS WHO grade 4. We had some points in mind for discussion for the first case. So,
Yeah, so this is, what are the age of the patient?
48, sir.
48. 48-year-old coming with a multicentric kind of tumor. So what normally is your approach as a surgeon for multicentric tumor?
Anyway, whether it is multicentric or it is single centric, we have to get a biopsy first and foremost. So when you are getting a biopsy, the accessible lesion, you as well do the surgery. But yes, in today's date, I would like to do a DTI and all these things to see for my better approach of the patient. And if it is in eloquent, I would have gone through the IONM and all those stuff and take out as much as possible, maximum safe resection. And I think they did perfectly well. But now the question arises whether that insular was just an edema or it was really a multicentric glioma because it has completely vanished. So that, and the approach would have been same, like I would have also, once the patient has come, and the first thing is that for a IDH wild type in this case, surviving almost 4 years with the radiation and temozolomide only, right? So that itself is a good uh,
So we don't
surgery,
really
you
know
know.
whether it was really IDH wild type. Of
Yes.
course, if it is multicentric, these things don't matter. We should have had actually a histone typing done. So because these could be a pediatric type diffuse glioma, the old glioblastoma cerebri type. We don't know if it belongs to that group. For that, you need H3 G34 mutation studies. Having said that, as you rightly said, the larger of the lesion, the symptomatic of the lesion, has to be attacked surgically. And once you have a tissue with you, then you can better prognosticate. Given that multicentrics uniformly tend to do bad. So once you have this multicentric etiology, as a radiation oncologist, how would you go about treating? Like you would insist on biopsy from the other side, or you would cover the other side with radiation?
If you have a biopsy, it will definitely be helpful. But I think this was an insular lesion. Probably it was not biopsiable. So, but as per MRI, it was a lesion. So we will make sure that we will cover that lesion. But very unusual that multicentric glioma, that to GBM surviving for 4 years is very unusual. Probably good tumor biology at that point of time. We don't know. But yeah, if the lesions are only 2, even though the second one is not being biopsied, we'll definitely cover it with radiation.
He has done well.
He has done reasonably very well, actually.
Very well.
Very
in
well.
fact, yeah. So that's why the doubt comes whether it was still IDH mutated tumor.
Probably.
So even though they could be bad prognosis overall, but they are doing better. It's IDH mutated, probably grade 4. We would know only if we had done a sequence.
Correct. And right now, sir, after recurrence, now that the gap is around 4 years and it's in the frontal area, definitely we will consider this patient for re-radiation.
Yeah, before we go there, from medical oncology point of view, if it is IDH mutated tumor, of course, here we didn't know. Will that make a difference between your adding a chemotherapeutic agent or not? Because now currently we do have trials to say that adding a temozolomide concurrent is to be withheld in astrocytomas, whereas in oligos you tend to do to prevent hypermutation.
Though, I mean, that thought is coming up, but still the category 1 recommendation remains that in the initial setting, we do give temozolomide. There have been studies where we added lomustine and temozolomide together, but too much toxicity and not worth the going after all the toxicity, not too much of a difference of PFS, everything. So otherwise it will be during radiation, it will remain that the patient has temozolomide and adjuvant temozolomide. But then if go back to that, you'll be discussing that again in that slide, this one. So later, the need for these the prognosis.
Pardon? The last one.
Yeah, the last one.
Okay. Yeah, you can mention.
Yeah, in the sense, as both of them mentioned, my colleagues, so the thing that GBM for 5 years without recurrent, this goes to the biology of the disease. Probably the P16, TRT, CDK10-2A, maybe the P16 is not less than 5%. So we have to check that if it is more than 50%, probably has a better prognosis. If very low levels, then they have got very poor prognosis. Just about 10 to 12 months survival, median survival.
These things become important only when you are looking at a low-grade looking tumor.
True.
But you don't want to miss a high-grade behavior. So then you have to do additional studies. But if the tumor is already necrotic, microvascular proliferation is there, it's already grade 4, and we know it is IDH wild type, they're all going to behave badly whether they express or they don't express. They're all uniformly bad. Further categorization in the IDH wild type, of course, IDH wild type, you have to mention that you have not done PCR studies.
Yes, sir. We couldn't do the sequencing.
According to WHO,
What is the age cutoff?
Reporting, if you are not done PCR, you have to mention it.
Yes,
so
that's
that we know that your workup is not complete. You are looking only at one mutation, that R132H, and you are not looking at the second mutation.
Given that he was a 48-year-old, sir, do you think that the IDH sequencing would have made a difference?
Maybe it is IDH mutated grade 4.
IDH mutated.
They may lose their mutation when they go forward. But again, second time also we have not done the sequence.
Yes,
We don't
yes.
know as yet. But he has had a good prognosis. He has obviously has survived for 4 years. And the other one has actually vanished. So this is one thing about multi-centric gliomas, which are different from multifocal. Multifocal is maybe connected in some way or the other. Multicentric, you have very two distinct tumors. They still tend to share the same molecular features most often than not. That's why you don't insist on a biopsy. You can treat them if radiologically or convinced it is tumor and not non-tumor. Now, considering that he has temozolomide already given and he has disease in both hemispheres, will your chemotherapy change for the recurrence? First, we'll ask the surgeon, what will you do for the recurrence? You would go for surgery for recurrence always? What would be the points of considering surgery in a recurrent glioma?
The points are like accessible, eloquence versus non-eloquence, and what all gadgets I have in my hand to go safely. The experience of the surgeon definitely matters there. And if I have all the gadgets and I know the patient is good enough, awake enough, I'll definitely go for surgery. I mean, that's how we approach, like do the maximum safe resection, and then, of course, I can go for central
Does the
radiation.
duration of recurrence change the duration of progression-free or recurrence-free interval, does it change your approach?
No. We are even going for 2 or 3 recurrences. There is a study in the low grade, as you have mentioned by before, that there are 5 times they are going, because you see I think the GBM, we are somehow perceptionally, we know that this patient will not do well. But what about the low grade gliomas? They'll wait for a long time. So even people are going up to, that's before, not we, but then they're going for 5 times. They're showing almost 95.3% of good functional outcome. So my first priority, if I can preserve the functional outcome of the patient, I will go for surgery, irrespective of the duration. If I know that the functional outcome, quality of life will take a hit at my surgery, that time maybe I'll be conservative. So that balance is required, onco-functional balance.
So 2 important points to consider before operating on recurrence. One is the ability to deliver further adjuvant therapy. So if that is not there, then your surgery alone is not going to be of benefit. Second is the time to recurrence. It has happened within a very short time. Like he has not even finished his primary temozolomide 6-month cycle and he has got a recurrence. You're hardly going to get any benefit by reoperating on that patient. But if somebody who has survived for a year or more without a recurrence, and then he is showing up a lesion, then they are likely to benefit. Rule of thumb, the second recurrence is going to be within 50% time of the first recurrence. So the first recurrence is short, second recurrence is going to be 50% short. So you'll have to consider.
Also, there's a scale that helps us decide based on simply the KPS, whether it's more than 70, less than 70, and whether the lesion is here. I think it was close to the ventricle. The ependyma was involved. So only these 2 points. So 0, 1, 2. So the more number of points, worse the prognosis, may also help us decide whether the patient is, in a good prognostic situation, and then help the family make the decision.
Functioning status of the patient prior to this recurrence is very important. So what kind of radiation caveats do you have for recurrence? Like, would you radiate within 2 years, 1 year? What type of radiation would you modify if you have to radiate in a short period of time?
So the bottom line is that the patient should have a KPS of 60 and above, and he shouldn't have recurred within 6 months of the previous radiation. This is the bottom line. If these 2 are not met, then we will not be considering for radiation. If the patient is beyond this, then it will depend on how long he has been disease-free. The longer he is disease-free, the better it is for us. Okay, and also the size of the recurrence. If the lesion is small, then it is much easier for us to treat, and we can use a little what we call as hypofractionation. That is more dose per fraction. But however, if the disease is quite large, usually at more than 6 centimeters, then we'll have to go for the conventional radiation. So considering this patient, so we have quite a long treatment gap. And also, if he is fit for surgery, gone through, so his GC also will be good, only seizures he had. So definitely we will plan radiation for this patient, re-radiation. What will change in terms of radiation is the dose and the volumes. The type of radiation will definitely be the conventional radiation, that is the uh, photons that we use, the normal VMAT, but we'll be using a more conformal type of treatment, probably a VMAT, or that sort of a rapid arc sort of a treatment, so that the field is very, very concise. And second is when we treat the patient like primary treatment of GBM, we give a large margin. So for the GTV, we give about 1.5 to 2 centimeters as our CTV to cover the microscopic disease. Whereas in recurrence, we don't do that. We just cover the GTV with minimal margins, so as to spare the normal tissues. So in this patient, that will be the plan. And the lesion is not very big, so probably I will go for moderate hypofractionation, about 39 grain, 13 fractions, or 40 grain, 15 fractions. That will be good enough for this patient.
6 months, I think, is too short. Maybe all radiation oncologists may not agree.
Yes, sir, I get it. But that is
It was 2 years. Now,
Correct.
most often they agree after 1 year.
Correct.
6 months, I think, is too.
Correct. That only depends on the recommendation to recommendation. The latest ENO recommendation is what it says. But previous to this, we have one more recommendation which says 12 months.
12 months.
Correct. So below 12 months, more than what Sir told was same. That scoring 0 and 1. So if it is less than 12 months, it will be 1, and more than 12 months, it will be 0.
What is the role of focused radiation, like stereotactic radiation, in recurrent lesions?
Yes. Yeah.
Especially when they are short in time. And newer variants like proton, now that so much of about proton, do people wrongly go for proton just in case it is shorter period, or will the ill effects and the duration be the same?
First, coming to stereotactic radiotherapy, there is a definite role of stereotactic radiotherapy, provided the disease is small. So ideally, the disease should be within 3 centimeters. Then definitely we can use stereotactic radiotherapy. And also, when you don't expect the patient to live very long, then definitely you will go for less fraction numbers. But there is a definite role in that. And also, when you do SRT, because it is very conformal, you don't give a lot of margins, you can little escalate the dose also compared to conventional fractionation. Now, coming to photon and protons, outcomes in terms of disease control, there is no difference as of now. But where it may make a difference is if it is very close to a critical organ, probably protons will give me a better sparing of that normal organ. Except for that, there is no data saying that protons will increase either the disease-free or the overall survival in gliomas.
I think that's correct. Yeah. So if the consideration is because of duration, then SRT maybe or SRS may be a good option, provided it's a focal nodular recurrence. And nowadays we do have LIT also. It can be tried, but it's not yet available in our country. And if there are other considerations, then it becomes important for proton. Like if it is very close to eloquent area, which cannot tolerate further radiation, but you still want to radiate, then proton might help. Otherwise, proton
very near to the brainstem. All this will be.
How would medical therapy change in the recurrent setting? Would you still go on with temozolomide, or would you consider alternative agents? What are the factors you would choose?
Just as per the previous discussion, suppose if the disease-free interval is quite short, I mean, with very short-term recurrences, most of the time it will be like a palliative kind of setting. Suppose if it is slightly more, 6 months to 1 year, little more than 1 year, then almost all the patients we just re-challenge the temozolomide, because the other agents which are there are not as smooth or as good, to enable them to continue the radiation effectively, because we do not want any of our chemotherapeutic agents to cause any toxicity and cause a break in the radiation. Then that decreases the effectiveness of radiation. So very few are there which are as smooth or as good as temozolomide when we are giving with radiation. In some patients, we do have tried, in the sense, carboplatin with or without vincristine. Sometimes we have given PCV, in sometimes when these were not available. So, but almost all the patients, again, it is re-challenge the temozolomide.
When do you add bevacizumab? Because that's a very favorite drug for most medical oncologists. What is your indication for adding bevacizumab?
It is not my favorite in the sense I do not personally believe too much in bevacizumab. So because a few times when we do have used in these brain tumors, the patient ended up having hemorrhage, the tumor internal hemorrhage in the brain, and there were problems with the blood pressure, and the other problems were with the cost of that because just like what these departments see over here, or in Vaidehi also, I see only very poor patients actually. So we're unable to give it at a proper dose and manage toxicity if they do develop that. So we have had very few experiences with that. Mainly bevacizumab I used when it was recurrences when radiation cannot be given. So this is the only option for me. Yes, we have given. We have had a few good experiences with that, but not while giving like this radiation operated adjuvant RT. In that times we have.
It's very useful when you're suspecting radiation necrosis. So when there is a combination of radiation necrosis versus recurrence, your perfusion data is not very suggestive of recurrence, but still there is a lot of edema and enhancement going on there. Then bevacizumab throwing in, I think, is very useful, symptomatically at least.
That was the indication when we were trying that, but we ended up having other problem.
Other
actually doing that. That was another issue.
Yes, audience wants to ask some questions. It's open for discussion. Yes.
Absolutely. I mean, in the sense, in most of our patients, we do not stop at 6 months actually. So in the recurrences, we always give it.
No, I'm not talking about the recurrence. I'm talking the first treatment only, because the patient got a very good response in the first sitting only. Maybe I'm just asking retrogression, but it's only for the point of discussion. The patient got an absolute very good response by giving 6 doses of chemo along with RT. So in such patients, we should give 12 doses of chemo. There is a new study which is saying that if the response is really good, you give extended chemo so that the chances of recurrence come down drastically. That is what I'm stressing here.
That is true only in low grades, not in high grades. In GBMs, there is no data to show increased benefit beyond 6 months of stup regime. But from the Codal study, which has come recent data, the low-grade astros and oligos, they do very well if you give up to 1 year.
Yes, sir. That's what.
So in some oligos, some people even continue up to 2 years, because as long as there is sustained remission, which is seen on the scans.
So it's
positive as well, because it's a 48-year-old. Only IHC has shown that it's wild type. Maybe you should have done a FISH to confirm whether it's IDH2 positive. Maybe it's a valid point which you could have considered, but that was the time when all this data was emerging. Maybe that was the standard at that point when it was being considered.
I'd like to ask, because Madam was telling us that she would like to be as aggressive as possible surgically
more than 6
also.
cycles, there's a lot of complications as well. We need to balance both. It's just like I asking you to operate on all cases. It's not possible.
How aggressive would you be about surgery for a recurrent glioma, especially if it's a high grade? Suppose there are 2 lesions. Would you necessarily chase those 2 lesions surgically if they are surgically resectable?
If it is in my same craniotomy,
It's
I do it
only if
both.
it's in a single
If it is
craniotomy.
not, then you are not doing that.
Suppose it's on opposite hemispheres or something.
In this case, obviously the insular has vanished totally, right?
Mhm.
But if it's separate, you're not doing that. You will do the symptomatic one.
The problem with recurrent tumors, especially malignant tumors, in low grades, there is enough data to show recurrent tumors reoperating is very good. Whereas in malignant tumors in grade 4, that is disease, there is little data to say that surgery is of benefit. There is no level 1 data at all. Level 2 is also very doubtful. But having said that, most of the case studies which have presented on recurrent tumors have clearly shown a benefit on progression-free and quality of survival for that period. So as she rightly said, if you can preserve the quality of life, and if you can do a surgery without harming the patient, then whether it is 1 site or 2 sites, we can operate. The only caveat here is the KPS should have been good and adjuvant therapy should be possible. If you are not going to offer any adjuvant therapy, that surgery is of no use.
I think in December, Cancer 25, this KPS, based on KPS study has come, which has shown that with a good KPS, you do the surgery, it's good.
So just one question regarding the IDH status again. So I know your opinion. We have had discussions in the NSI about this also. Like, would an IDH sequencing in this case have made any difference in the management of this patient,
It is
except
only-
for prognostication,
Yeah,
given the
exactly.
cost factors?
Exactly. So cost is okay. There is a element of cost involved in it. How is the treatment going to change? So your IDH mutation status versus non-mutation status does not change your treatment for grade 4 lesions. It's only going to change your labeling as GBM versus this is a malignant astrocytoma. When it comes to low grade, it makes a hell lot of a difference. So if you are not looking at histological features of microvascular proliferation, necrosis, or increased mitotic activity, you are having a low grade looking tumor and it looks IDH negative on IHC, you have to go ahead and do. Otherwise, if you're going to label this IDH wild type, this is going to behave like grade 4. And you're going to treat him completely, even if it looks grade 2. There it makes a world of difference. But if PCR comes positive, this man is going to be only observed. That is when you do your CDKN testing to make sure it is not a low grade looking and it comes up positive only in 5% of cases. So if you don't do CDKN2A, you are excused. But if you don't do IDH, you cannot label it. You may have to only call it NOS. So that is why WHO added that NOS so that people know when they read that this has not been still fully characterized.
I think philosophically also, right now, we start with IDH and then the road folks. And going forward, I think there will be drugs which target, say, BRAF V500 mutation and the CDKN2A2B pathway. Drugs may come up. So knowing that information may actually help us tailor precision medicine. I don't know at what cost, but that's probably what's going to come up.
That is the important point he raised. So now with IDH inhibitors, which has been approved and it has been launched in India too. So Vorsenadib is now available in the country. It is mighty expensive, but the company is selling it with a 1+5 free. So that means the one vial of 30 costs you 18 lakhs for 1 month. But if you take for 1 month, they give you 5 months free. But the trial is very limited role that in grade 2 astros, if you are planning observing these patients without giving them upfront adjuvant therapy, if you put them on Vorsenadib, the time it takes to start the next treatment or recurrence is prolonged in these patients. Now, whether overall survival improves, whether this is really useful, whether they have to spend so much money instead of waiting and watching, or should they undergo radiation upfront, is that superior? We don't know as yet. But yes, if you know IDH status, there is another drug available for people who want to take it. Your thoughts on that?
So the other thing is, when we do NGS on this resected specimen, we can still look at NTRK, then BRAF. Right? So when we do come across these kind of mutations, they're very, very less, 1%, 4%. So here we are able to do that NGS on quite a few number of patients. We just had about 2 or 3 patients on that. One patient did very well on that, still 1 year plus going on now. One patient has defaulted, another one progressed in 3-4 months. So these medicines which are there, entrectinib, NTRK inhibitors, then we have BRAF, vemurafenib, then these inhibitors which are there, a few of them, if we find out that they are mutated and they're able to take them, some of these drugs, as you said, they're only available on compassionate basis. We have to get them, or they're very, very expensive. But there are other ways of getting also. There are some others who manufacture and we're able to get them. Suppose if the patient is still, they are also still not cheap. They are also about 50 to 70,000 every month. But if we do find that mutation and that one patient, some of them respond very well, like the other patient I'm telling, they'll just do extremely well with that. So now probably is the time where, which I'm seeing these driver mutations and agnostic therapies in other areas like say breast, lung, gallbladder, endometrium, everywhere. So slowly it is now coming into the time now is there for brain tumors also. So we have had decades together of temozolomide, platinums and everything. Now gradually a lot of data molecules are coming. Hopefully we see much better survivals and we're able to help the patients better with these kind of smaller molecules. That is the way forward actually.
I think we can go to the next case.
Yes. We'll have 5 minutes. And Case 2, it's a 45-year-old male who presented with speech and memory disturbances for 1 month. It improved with steroids. It was a known case of temporal supratentorial ependymoma, operated in June 2025 in another institute. He underwent a left pterional craniotomy and subtotal excision, and IMRT was given in August and September 2025 immediately. It was a grade 3 ependymoma, and he was asymptomatic till 1 month before presenting to us. This was the pre-op images before the first surgery, where we see a left temporal lesion and with peripheral enhancement and a nodule. This coronal is inverted. It's a left-sided lesion. And T2, there are cystic and solid areas. And this is the post-op image where most of the tumor is excised except probably for the small nodule near total excision. And post-RT, he had a recurrence in a different site. It's a frontal recurrence which he's had. And actually, if we see in the coronal, there is some lesion in the other side also. There's some enhancement on the opposite side. That seems to have gone in the post-RT images. This is before his second surgery. He underwent total excision of this of the recurrence, frontal recurrence. So this was the grading on the second surgery, ependymoma WHO grade 3. So the points for discussion are prognosis. He's come back, as we were discussing the previous case, during the RT, and immediately after that, he has come back with a large recurrence in a different site. Management
so
of
ependymoma is a different beast altogether. So, yeah, just sure. So I'll ask the surgeon, what would you do if you see a residual tumor
Recurrence.
like that and the histology has come to you as an ependymoma?
And this is difficult to say, but I think when I can see a very excisable lesion, first I'll go and excise the lesion only and then hand over to my other colleagues. That is the trend we do, right? And that I just could not follow how much was the gap?
June, he presented with the first lesion, and then RT, he came back in Jan. So 6 months.
6 months. So it's a very less. So obviously,
If such a residual tumor comes to you with residual tumor for RT, would you refer back in your multidisciplinary tumor board discussion for re-excision consideration? Or would you accept for radiation?
No, definitely re-excisions. We'll definitely go for.
I think that's a point which we should all understand, that ependymomas are very difficult to treat with radiation, and chemotherapy, practically, we don't have any good options. And even in a fully excised ependymoma, there are chances of recurrence. So there is no role for leaving behind an ependymoma. If you have a lesion picked up on your post-op scan, I think you should do everything to go after it again and then go for radiation rather than just consider direct radiation to the residue if it is excisable. Any newer techniques in radiation in ependymoma which is likely to reduce the recurrence rate?
Nothing.
Do you increase the dose, or do you just
As of now, dose escalation has not shown any improvement in survival or DFS. So right now, I think we stick to the same doses of 59.4 to 60 gray is the dose that we can go. The limitation being that only depends on the position. Again, if the ependymoma is very close to the brainstem optic chiasma, then probably we will not be able to deliver 60 gray. We will restrict ourselves to about 54 gray. But other than that, dose escalation has not, translated into any improvement in outcomes.
That's true. Any questions from audience for ependymomas recurrence? Because the molecular grading in ependymoma is only to signify prognosis. It doesn't change the grade. Especially in supratentorial ependymomas, the grading still remains as per histology. So would you change your approach if it is, say, grade 2 or grade 3, or would you just?
Grade 3, everybody will get radiation adjuvant. Probably grade 2, complete excision with no disease visible on the MRI. Probably there is an option of wait and watch. But
So
if it is grade
currently,
3,
yeah, grade 1, WHO has taken away completely.
yeah,
It is only subependymomas are grade 1. Even myxopapillary has been upgraded to grade 2. All other ependymomas are grade 2 or 3. So better to treat them more cautiously rather than wait and watch. Other question was, would you consider in supratentorial ependymomas craniospinal radiation?
No, sir. As of now, if the MRI spine screening and if CSF both are negative, then it is only local RT. So we will
Because
not.
this is a case wherein the location was different
Correct.
surgery, but it has arisen somewhere else. Would whole brain radiation would have prevented this?
May not be, but usually whole brain radiation we don't use, sir, for nowadays, because the toxicity is quite high.
Correct.
In especially the cognitive, disorders and all will be very high. So it is usually local radiation only. Unless definitely if you have some CSF seeding, then definitely CSI is a role. Otherwise, it is just localized radiation.
But you still do a lumbar puncture study.
We do, yeah. We will rule out. We will rule out CSF involvement, and also a spine screening will be done for any deposits.
Would redo surgery, seeing that small recurrence, have prevented this situation?
Definitely.
Probably,
I think
yes. Early
if
surgery
you
would have-
actually go back to the pre-op scan, that solid part was the only solid part.
Yeah,
Rest of it
that's
was
true.
cyst.
Yes.
So the surgery has dealt with only the cyst, and the solid part practically has been left behind. So I would consider it.
My question is that it's not that we just do surgery. We have to emphasize now on the functional outcome. So we have to take all the gadgets, whatever is possible with us, with all the monitorings. If possible, if the patient is good enough, do an awake surgery. It's on the left side. So I just wanted to make that point that we have to be careful. Whatever life he has, we have to give him the quality of life. I think that stretching is required.
I'd like to
I
thank
think,
the
yeah.
panel for that. Yeah.
Yeah, the MIC amplification is bad prognosis in spinal epipendymomas.
Yeah, MIC
So
is
they
for
directly go to grade 3 and they have very poor prognosis. So they have to have more aggressive management.
For supratentorial, maybe chromosome 1,
Yeah.
1q loss.
The RELA fusions are bad in the supratentorial. The YAP fusions are better.
In recurrent scenario, for those cases, maybe you could consider CSA.
Yeah,
That's one
CSA.
exception which you can take.
So I think the bottom line in both these cases is the extent of resection, in spite of our understanding and so many newer techniques coming up, still the extent of resection is very important. So as neurosurgeons, we can't give up on these tumors, and the more we resect them and the more we preserve them functionally, the longer they are likely to live without recurrence and the better they are likely to do with our treatment.
But the problem is like when you do on a re-irradiated places, so I think you can talk a little bit about there are problems like, the skin takes a hit many a times in all these cases. How do we deal with that? I'm only asking.
I think that's a very interesting question, but I think in the interest of time, we'll have to move on.
Sure.
This is a very engaging discussion. Perhaps we could continue this off stage or during lunch or over coffee.
Thank you. Thank you.
Yeah, I'd like to ask our moderators to please felicitate our panelists. Our next speaker for the neuro-oncology session
Is Dr.
is Dr. Shabri Girishan. He's an associate professor of neurosurgery at the MS Ramaiah Memorial Hospital. And today we've invited him to speak on maximizing safe resection of gliomas, building from his own personal vast experience with functional neurosurgery and neuro-oncology.
Hello, everyone. It's a great CME, and thanks to the organizers for such a wonderful program. And I'm glad Dr. I'll thank for this opportunity as well. So I guess wonderful session we had before this talk, and I guess it can be overemphasized that precision and safety is pretty much important in glioma surgery. And then in last discussion, we came across very often how maximal safe resection is important, and what gadgets are available. And depending on that, I'll may or may not go back inside. So that's where this talk is going to come in, that precision in glioma surgery, no doubt, it starts with surgical hand dexterity. There's nothing to replace that. And of course, then different layers are added on top of it. And that's kind of a luxury that a surgeons can have. So the question is definitely, and it's nice that this is not for debate, the precision and safety. We all had a major debate since morning. So obviously, we're not talking about a setup where you don't have image guidance, where you don't have intraoperative neuromonitoring, and I'm not really showing a very class one evidence randomized control trial to use a particular tool. But then if you have it, can you use it? Do you have the knowledge to use it? Because obviously a fool with a tool is still a fool. So please take this as a knowledge sharing rather than any proposal for it, because a lot of controversies still hangs around this particular tool I'm going to discuss about. So obviously among all these infrastructure that is available to maintain the precision, I have chosen this particular tool of connectomics. I'm not really sure how many of you started using this connectomics. It's been there for quite some time, and maybe I guess roughly 5-6 years now, because one of the group which came with connectomics, they even exited India. They couldn't really survive in India. That's the, I guess, the omniscient group. Now the brainside group is trying to spread the knowledge, and they most of the time probably they would have even approached you to show this as to how to use it and all that. And as a disclaimer, I'm one of the scientific advisors for this particular tool, which is going to be in our kit. So what is connectomics and how is it different from the regular task-based fMRI that we use and the regular DTA that we use? Because that's been there for a very long time. So if we just put these two things together, does it really form a connectomics? So I just briefly take you through as to what this connectomics actually is. In a nutshell, yes, it is combination of both the functional imaging, but a lot more processing happens, lot more computational challenges are there to actually look at the structural and functional network of the brain. So, and how is it done? Basically, there is a structural network that they are creating by starting from the time series of the Bolt signals. So we have a lot of these computational processing that comes in to connect the structural DTI with the functional Bolt signals that comes up when we do a scan. So that's the beauty of resting state fMRI. You really don't need patients to perform any task in this particular modality. It's a resting state fMRI. So all these while the resting state fMRI was in a research arena, now it is coming for us for the clinical use at the bedside. So this is in brief how they structure it. Once the image is normalized, they'll put through brain parcellation, and a lot of computational processing happens where there is a correlation matrix looking at two different areas with the covariance of it, how those two fire together and how they are connected. And they go one step ahead, including graph theory on top of it, to know the centrality of it, how the major hubs are formed, how well these are connected. And it has a big role in epilepsy and functional surgeries as well. But today, let us see how a simple pipeline of connectomics can be used in the area of oncosurgery. So in the pipeline of acquisition, this is how it goes. The two simple scans are acquired, diffusion weighted scan and the T2 weighted gradient echo scan. And then that is uploaded, obviously anonymized, and uploaded into the the cloud processors called VoxelBox for BrainSide. And there's another cloud processor for Omniscient. And then the turnaround time is only around 10 to 12 hours. So you have the entire 12 connectivity maps at your disposal to look at the relation with the tumor. Then here onwards, it is as simple as any other fMRI DTA that we are used to. But in brief, you need to know the output, expected output. So the Omniscient came up with this connectomics, which is actually little more accurate because they literally trace the structural DTI to their functional connectivity. But in brain side, as of now, they are overlaying it with the resting state fMRI. They are in the process of acquiring the FDA approval and then further processing it like an omniscient pipeline. So this is how it would look like. So how do we use connectomics in awake surgeries? And why is it really important to go for it? Why can't we just stay with task-based fMRI as we've been doing all these days? Deficit is the major reason and the huge advantage over any other pipeline, because a patient is like semi-comatose or they're really not able to obey commands like 14/15, little bit disoriented. Obviously, if they are semi-comatose, then we may not be even able to do an MRI. That's a different question. But if an MRI is possible, you can add these sequences and get the sequences quickly for your operative. So yes, direct cortical stimulation will be benefited if we have this resting-state fMRI in patients with deficits, that is for sure. And why do we even require these kind of image guidance for direct cortical stimulation? I call it as 3Ds. One is distorted anatomy, then obviously a disrupted anatomy, and then the docked anatomy, the proximity to the major functional tracts. So what happens when there is a 3D shift? Usually, this is a very basic modality in the surgery, that is intraoperative neuromonitoring. The same principle. We go on doing this fishing expedition during the surgery, and that takes up a lot of time. And obviously, doctor and patient fatigue if it's an awake brain surgery. And then the increased stimulation mapping duration does go up, and that is going to lead to the seizure. And there are n number of literature that has shown that it carries at least 10 to 15% of stimulation induced after discharges. That's something all of us know about it. And they've even come across the threshold for the seizure induction is around more than 145 seconds and more than 60 trains of impulses. So there is even a threshold where beyond which it is going to cause seizures. So clearly it is time and dose dependent, and many literature across the world, now we know that there is a risk of around 5 to 10% of seizures when we do this prolonged stimulation mapping. So that is where this imaging pipeline is going to help us to cut down the time and the dose quickly, get to the point of interest. So how does it really look like? This is the language network where beautifully Broca's and Wernicke's areas are shown, and the arcuate fasciculus is seen very well. One caveat, and what you should look for is the laterality index for dominant hemisphere. And that a little bit obvious here. Obviously, you can see the left side Broca's area much more robust than the right side. Resting state fMRIs usually gives bilateral representations, but if we want the dominance, they give us the entire tabulation. And this is how the sensory motor network would look like. And we need to ask whether they've used a HCP atlas or another atlas that is a census atlas, where the area of distribution might vary, but it's good to be all-inclusive HCP atlas where the entire sensory motor network is available for us. So, and more importantly, cognitive networks, that is something was never available for neurosurgeons. So you have a very highly professional individual and you're going to operate on an eloquent area. You would definitely want to know whether any of these areas are involved in the proximity so that you can include it in prognosis. It may not change the management. Yes, you need, if it's a GBM or it's a high-grade tumor that you're operating, definitely none of this will change our surgical management. But it's a huge prognostic information. And you can even leave a residue if it is low-grade glioma with any of these networks involved. So addition of the cognitive networks is a huge advantage to going for the resting state fMRI. And neuropsychological evaluation is going to even further prognosticate. You can do a pre-op neuropsychological evaluation, look at the cognitive networks, and then prognosticate post-operatively. So obviously, it does going to help us with the dynamic stimulation. When we do a white matter tract stimulation, we can easily look at how far is it from the tumor before we even go in. And thereby, you can adjust your threshold current intraoperatively. So the three-dimensional relationship is something which is going to be very helpful. This is an example of optic radiation with the tumor. and a language network with the tumor. So how do we use now in our regular pipeline? So that is the standard selection of patients for awake craniotomy. I'm not going to go details into it, but awake craniotomy itself is a huge step towards the precision and safety. And of course, there's no doubt about intraoperative neuromonitoring. We use a standard set of parameters to do that. And then, of course, you look at the surgical workflow. A day before the surgery itself, we can acquire the images, and the turnaround time does give you a full set of data, and then you put it and load it into the navigation. That's a huge advantage. When the task-based FMRA was available for us, it was not really compatible with navigation. You need to evaluate it preoperatively, have an idea, then go apply it intraoperatively. But here, there's a huge advantage that it is sort of compatible with any of the navigation setup that you have, and then you go through the regular surgical pipeline. So now we have all the instruments ready and the tools are ready for you to go ahead. But how exactly we do that, I'll just show you through two case vignettes, one of the glioma and one for the epilepsy surgery that I used for as an example. So 56-year-old male presented with a progressive left with significant hand grip weakness. He was not able to make even the grip. Obviously, the task-based fMRI option is out of window. And of course, the distorted anatomy that is expected due to its location. And that's the motor network where the corticospinal tract was buckled and deformed. And this helped immensely to plan the trajectory because it was right under the motor cortex. Obviously, to get to the tumor, I need to violate the cortex. So that needs to be minimal. If you want to use a transsulcal to plan a trajectory, this has to be ahead of your functional areas. And that's the trajectory planning that has been shown here. And of course, now this is the symphony where you have the intraoperative neuromonitoring. You're stimulating the cortex, looking for the upper limb evoked response, but that entire stimulation is guided by the navigation. You bring your navigation probe into the field, look for the resting state fMRI. As you can see, on the affected side, the bold signals are not really great, but still you know where it is. So directly, you can go to that area and stimulate it, evoke the response, and then go ahead and finish your surgery. So, and on top, you can see the brain was completely normal. So obviously, one would argue the surface landmarks, it's very easy, omega sign, and there are 100 signs. But then if there is a shift, but still you end up in spending a lot more time stimulating these normal cortex, and intraoperatively, there is a huge risk of seizures, and that would raise the ICP beyond limit. So, and this is an example where dynamic stimulation was used by adjusting the threshold current based on the DTI information. That again definitely cut short the time as well for your stimulation. There's another example where we use it for epilepsy surgery. There's very small focal cortical dysplasia right under the Broca's area. This was a lesion causing multiple episodes of seizures right under the Broca's area. So obviously the similar pipeline where language network was used to figure out the area and the approach, and we went ahead and did the language mapping in an awake condition with a cortical stimulation at 2 milliamps. Within a minute or so, we were able to map out the entire boundaries of the Broca's area. Then we went ahead and did the excision of that lesion. So obviously one would ask, what are the limitations? There can be many limitations. The major ones are false positivity rate, and that is something that is still in the research arena. As to when there is an edema, obviously your DTI can have false positive. There can be reduced blood flow because of so many reasons that can bring down the bold signals. So, and obviously the intraoperative brain shift. So we have another tool to take care of that, which is intraoperative ultrasound, but still it's not very significant. We can still achieve good results with that. And obviously, when it comes to the cognitive networks, the normative data is something which is very, very important to figure out the boundaries of those cognitive networks. And the more we use this tool, more it's going to be better. Probably then we'll have a debate whether it's required or not later. I guess this is the future where AI and machine learn algorithms are coming into the help. And definitely they are going to tell us which trajectory is better on their own. and then obviously have a real-time dynamic connectome updating. As soon as you get the imaging on the patient's data, then obviously standardizing the cognitive mapping batteries are something which is very, very vital, and that's going to be with the prospective trials. So these are my references. I understand this is like not very scientifically rich. I just shared my experience, and there is a tool that we all can depend upon. For further reading, you can use these references. And thank you for your kind attention.
Thank you, Doctor, for a nice talk on showing how we can use all these information for better functional preservation of the patient. Neurosurgery is now moved more from just morbid tumor dissection to functional preservation of everything that you see.
Yeah.
And of course, no part of the brain can be taken as non-eloquent. Some part of the brain is interacting with some other area for some function, and how important it is to preserve that. If you can preserve it, it's good to preserve it. If you can't, then at least we should not harm it. Like, first we should do no harm.
Yeah, absolutely.
Yeah, in our interest of extent of resection going from complete to maximal resection, we should not land up doing harm to the patient. So that's where all these gadgets and technology come in helpful. Any other comments?
I've also used the BrainSat platform. As you rightly said, the left-right is one thing for the language. Apart from language and motor, if you add up all the other networks which they give, the salience, the dorsal attention, ventral attention, all of those, it's pretty much the whole brain. Yeah, there's no area that is
That you
not
can't touch
networked
it,
to
yeah.
anything else. So in that sense, how do you use that information to say, for this low-grade glioma, at this point, I would not venture further into? What are your hard stops using that information?
That's a great question. I don't have a perfect answer for it. Michael Shugru is a person who started using this in a big way. It's an Australian group. They have literature on these low-grade gliomas with the cognitive networks. They did preoperative neuropsychological and postoperative neuropsychological evaluation comparisons. And they found that if a patient is like very highly professional, and if the profession demands that particular network is not to be intact, for a low-grade glioma, definitely we can leave that residue based on the imaging parameters that we have, and then come out of it, provided the preoperative neuropsychological evaluation is intact. Because then the surgery is going to induce the damage. So let's not have that. If the neuropsychological evaluation already shows that the function is lost, then definitely we can give a radical excision for it. So, but then that's kind of anecdotal experience-based data we have now, but prospective trials will be more, enlightening in future.
I just had a comment to make. Excellent talk.
Thank
and certainly an emerging field. Now, I think that one of the main advantages that you don't require patient cooperation as in case of an fMRI. So even if a patient is has some behavioral abnormality or is not cooperating, you can still get a reasonably good picture. I will say the disadvantage actually comes from the images available do not exactly align with the surgical anatomy, where you align according to the vascular supply or through a gyri or through pile. We basically follow the pia and the vessels, which this anatomy does not align that perfectly with. One, we have been using it for last few cases now. Another problem is there are the currently available connectomics gives just one single picture as an association. There are connectomic systems available where you have a stepwise association. The first step is the most vague association with the with a function, up to 7 functions, where the last one is which is so intimately associated with the function, where you can choose to preserve according to the extent of involvement of a certain area with a specific function, because it becomes particularly important when you're operating on a person with extra high skills, like a teacher or a politician or a musician, where even the most remote associations with the function becomes important. I think that is a limitation that the system currently has, the connectomics. Probably it will evolve. Plus, it gives a very wonderful, white matter picture also, which can be utilized.
Yeah, absolutely. So the second point which you raised, that co-registration problem, like it doesn't really align well, that is improving a lot now, because the omniscient group, as you rightly said, the entire blobs is like outside the brain. So Co-registration is something the group is regularly working on, but right now it does match and it does stop at the surface of the brain, and it is respecting the boundaries. So it is much, and the gold standard is to compare it with the intraoperative monitoring. That is something we can never give up on it. So that's the gold standard anyway. So that will give us the boundary. It's just a guidance, as to where to start. So yes, of course.
We have to
Thank you.
understand, there are too many gray points here. One is, what are we trying to preserve? We have not yet reached a stage wherein in gliomas, we can justify leaving behind tumor for a assumed function of a connectomic, which we do not know where plasticity of the brain may take care, or how much is going to be the real life deficit if that tract is affected, if they are not the primary motor, sensory, or primary speech areas. So these are very gray areas, and we cannot yet jump the gun and say, I'm going to leave behind tumor. So we should not, you should understand that even Dufov's criteria is more to identify the margin of supramarginal resection, not to preserve the function.
Yeah.
Once you reach there, you stop. We don't know how much you have to destroy IFOF or SLF for it to manifest as a credible deficit in a functioning patient.
Absolutely.
So he says you can remove all this so that you avoid radiation therapy, so that patient does not have ill effects of function of plasticity in radiation. But if you're going to treat everybody with radiation, then these things don't matter. So there are a lot of questions that are still not unanswered, going unanswered. But it's very important that we know that the whole brain is eloquent and we have to treat it with respect, but not at the cost of extent of resection as yet.
Absolutely.
Thank you. I think we will conclude
Thank
the
you.
session on neuro-oncology with that. I'd like our moderators to please kindly present a small token of appreciation to Dr. Shabri for his talk. And next, I'd like to call upon Dr. Sumit to kindly present our moderators with a small token of appreciation. Our last session before we break for lunch will be on the multimodal management of cerebrovascular disease. Our moderators for this session will be Dr. Girish Menon, Senior Consultant of Neurosurgery at SP Wellford Hospital, and Dr. Harisha, Senior Consultant at Manipal Hospital. I'd like to invite both of them on stage. Next, I'd like to call upon our first speaker for the session, Dr. Paritosh Pandey, Senior Consultant of Neurosurgery at Manipal and also visiting endovascular faculty at our department in Satyasai. A nationally and internationally renowned endovascular and open cerebrovascular surgeon, Dr. Paritosh, will be discussing contemporary management of chronic subdural hematomas in the endovascular era.
Respected chairpersons, faculty at Satyasai, after this very heavy discussion of very, very complicated topics, we come to one of the much simpler topic of chronic subdural hematoma. And I'll start with a case here. I hope you can see this. This is a 72-year-old lady, mother-in-law of a very prominent neurosurgeon in Bangalore. She has headache and mild gait instability. And that's it. She's not on aspirin or any antithrombotics. And how many would observe these patients, her, and take a scan after some time? Okay, no one. How many would give DEXA for this patient? DEXA 1, okay. It's not bad idea. 6 months later, 6 months outcome, DEXA has bad outcomes than this thing. Immediate good outcomes, bad. Tranexamic acid. Anyone? No. Very nice. Surgery? Surgery. Okay. Middle meningeal artery embolization? Anyone? 2 people. One of my colleagues. And surgery followed by middle meningeal artery embolization or the other way around to prevent anything. Few. Okay, so that's fairly good. And this is what is there. As you can see, there is no burr hole, so she did not underwent surgery. She underwent a middle meningeal artery embolization. This is 3.5, 4 years back, which is complete resolution of symptoms without any recurrence. So the questions that we need to answer is whether a middle meningeal artery embolization prevents recurrence in chronic subdural hematoma, adjunctive, whether we should do middle meningeal artery primary, when should we do it, what should be the material used, what are the complications, and what are the future directions. And this is how we'll present this. What is the problem about standard treatment? What is the theory behind middle meningeal artery embolization? What are the initial reports, major trials, meta-analysis, consensus, and controversies? And I will slip in a couple of videos here. We know that it is a very, very common problem. It's almost going to be the most common neurosurgical problem in the US and other parts of the world by 2030 because of rising population, multiple falls, trauma, antithrombotic agents, and things like that. And here is what is there. This is important because this is the border cell layer and which is very important in the formation of chronic subdural hematomas. So how does it form? There is a traumatic event which has bridging vein rupture. Then there is a foreign body response, inflammatory cascade, and neomembrane. Now, this neomembrane is also supplied by the middle meningeal artery. And this has been shown that they show that newly formed vessel in the outer membrane of the hematoma demonstrate abnormal dilated structure with high permeability, which leads to continuous bleeding. This is how it is done. And the most important thing is the chronic subdural hematoma is primarily caused by inflammation of the meninges, which stimulate neovascular ingrowth that is susceptible to bleeding. So brain is trying to absorb the fluid, and there is continuous bleeding from the micro vessels of the outer membrane. And that is why it keeps on sustaining the chronic subdural hematoma. Now, when we stop this middle meningeal artery supply to the outer membrane, this is supposed to break that cycle. And that is why it is there. Multiple branches of MMA are seen to be penetrating through dura to supply blood to the outer membrane of the hematoma. And angiographic studies demonstrate that MMA branches become dilated and create an abnormal cell. And that's the rationale. MMA embolization blocks the blood flow to the membrane through the MMA branch occlusion, which prevents new vessel ruptures and allows hematoma to preserve in the body. Conventional management, we all know. Either asymptomatic small hematomas you just observe. There was some talk about DEXA or tranexamic acid, but both of these trials have been negative. Some of them have conservative treatment and resolve by its own, but larger hematomas are usually symptomatic and requires intervention. And everybody does either twist drill, burr hole, or craniotomy. Everybody has different techniques. And this is performed under GA and LA. These are evacuation methods. The recurrence rates are quite significant. It's not insignificant. So burr hole around 12 to 15%, craniotomy 20%, twist drill 28.1%. There is poor brain expansion. At day 14, only 41% have expanded. And once it recurs, it becomes a really difficult problem because it keeps on recurring and things like that. And other options have limited success rates here. There was a study by which when you put a drain, the recurrence rate comes down, and there was a randomized control trial, and nowadays most people, if not all, are putting drains in this kind of patients. Initial things were very good, and it was started by Japanese, and we see this here. This is the anatomy of the middle meningeal artery, the first branch of internal maxillary artery. There is an anterior posterior branch, and you have to go beyond the petrosquamosal branch to not to injure the facial nerve here. There are dangerous collaterals which you can see mostly with the ophthalmic artery. And if it is there, that's a contraindication for this thing. And there are 2 branches here. It is performed either in sedation or general anesthesia, 5 French sheath. It's a very easy procedure to do. You go ahead and cannulate both the anterior and posterior branch of the middle meningeal artery, and then put the embolic of your choice. PVA, onyx, squid, whichever is there. And this is supposed to be what is called as a cotton wool appearance of the middle meningeal artery, which shows that there is going to be inflammation of this artery. Yeah. So this is first we go ahead and do this. This is the, oh, sorry. So we take ICA runs. Then this is the middle meningeal artery. Sorry. Yeah, so this is the middle meningeal artery, anterior posterior branch. And then we go ahead and put middle meningeal PVA suspension here and then embolize this artery. Sorry. Again, this is the posterior branch. And this is the final thing. This is not a very complicated procedure. Every neurosurgeon should be able to do this. A middle meningeal artery, it is just one step ahead of the DSA angiography. It is done. And this is what is there. This was the MRI before. We waited, increase in size of hematoma, and then middle meningeal artery embolization. These are the embolic agents, PVA, onyx, squid, and other things. Sometimes you use coils just to do a proximal embolization, but that's not recommended too much. These are the contraindications: non-convexity hematomas, severe mass effect, dangerous collaterals, renal supply left. And this is again how we do this. Sorry. Okay, that's fine. There's no big deal. Now, since we are not spine surgeons, we also have to do some major trials to introduce any new things to the system. So these are the major trials here: Embolize, Magic MT, STEM, M-Protect, and Membrane. So this is the first trial which came in any JM. And this is 400 patients, 197 middle meningeal artery plus surgery versus surgery alone. So this is all the patients underwent surgery in this. Half of them underwent middle meningeal artery either before or after the procedure. As you have seen, 28.6 alone underwent surgery before the randomization itself. And this was the first trial which showed that recurrence comes down by 2/3. So 11.3% in surgery versus 4.1% in middle meningeal artery embolization. And there is no difference in function, mortality, any other things, serious adverse events and things. So that's the implication. It halves or more than halves the recurrence risk. This was again another trial, which is a larger trial, 722 patients with chronic subdural hematoma, 360 middle meningeal artery embolization, 362 standard care. Now, standard care does not mean surgery. There were some patients who underwent only observation. There are some patients who underwent surgery. Burhole drainage was performed in 78.3 of the enrolled patients. And most of the patients, they did embolization before the surgery itself. And this is the primary outcome. It's not significant, 9.9% record in the usual care, and in embolization group, it was 6.7%. So there is no difference, and there is no difference in the safety outcome. Then the third trial, which is the positive trial, is called STEM. And there is this either surgery or non-surgical treatment had been chosen by patients. And the primary outcome is, of course, recurrence or reoperation itself. And 310 enrolled patients. 16% of the patients in the embolization group had the primary outcome event versus 36%. Now, it is very important to know that most of this benefit was in patients who were observed versus middle meningeal artery embolization. And there was not too much difference between surgery versus surgery plus MMA embolization. So that the difference in the 16 versus 36% is driven mostly by the patients who did not undergo surgery at the first place. And this is what is there. And again, this is another trial which is called M-Protect. And this also is a negative trial, which is, they have said that there is no difference between the 6 months chronic subdural recurrence, which is 21 versus 14% here. And as this is all the things why it is negative. So if you see stem surgery alone and stem surgery plus MMA embolization, there is very little difference. But stem observation alone versus stem MMA only has large difference. So moderately sized chronic subdural hematoma can be treated with middle meningeal artery effectively. large size, of course, there is surgery, but there is a marginal difference reduction in this thing. Again, there is a membrane trial which shows that there is significant reduction in the chronic subdural hematoma recurrence here, which is 8.5% versus 20.2 in surgery alone group. And in the observation group, there is marginal difference here. This is the table with all the other things. Is there any trial between MMA and surgery? No, there is no trial comparing MMA embolization primary versus surgery alone. And there is some data with meta-analysis of retrospective data which shows that the recurrence rates for both is similar. If you do MMA embolization or surgery for moderate size chronic subdural hematomas, the recurrence rates is similar. Meta-analysis, most of them have used 3 RCTs, and I will not bore you with that, but surprisingly, there are 2 meta-analysis with absolutely different results. So in this meta-analysis, which has only taken 3 randomized controlled trials, there is no significant reduction in the recurrence. But in this one, there is significant reduction in recurrence. And this can happen because they can give different weight to different randomized controlled trials. And that can happen based on whether it is done. And very marginal difference as is in this thing. Our own NIMHANS alumni, Dr. JJ Shiv Shankar, is now in Manitoba's, and he's run a Canadian trial of middle meningeal artery embolization. And this is a data from his slides. This is not a published data, but this has been just been presented in World Stroke Congress at Barcelona. And this is one of the best data that you have for the middle meningeal artery embolization in recurrence, where they have shown that symptomatic recurrence reduces by 6.5 times with adjunctive middle meningeal artery embolization. So I'm sure there are more data is going to come, and that is where there are future trials, 16 of them comparing middle meningeal artery adjunctive plus surgery. So surgery versus surgery plus middle meningeal artery embolization, 16 trials are running right now. Middle meningeal artery versus observation, 9 trials. And there are 4 trials, fortunately, which also compare middle meningeal artery and surgery. So these are the questions we asked. Is middle meningeal artery effective in preventing recurrence in chronic subdural hematoma? 2 trials say yes, 2 trials say no, and this can happen because there are different patient population, embolic agents, risk factor for recurrence. Is primary middle meningeal artery better than observation? Many trials say yes. So if you have a middle meningeal artery, if you have a chronic subdural hematoma which you want to observe versus do middle meningeal artery embolization, it is better, which is obvious, I think. When to do it? In case of adjunctive, most trials actually have done middle meningeal artery embolization before surgery and not after surgery, though the latest Canadian trial has done within 1 week. And primary middle meningeal artery embolization is clinician's judgment. Embolic material, there is no evidence of superiority one over the other. Most positive trials have used liquid embolics like Onyx and Squid. Fortunately, there are no complications, very, very little complications. Procedure is very well tolerated, very occasional complications if you are not very careful, facial nerve injury, visual disturbances, and very, very rarely stroke. It should be pointed out that all these studies have taken recurrence as a surrogate marker of favorable outcome, which may not be true. There is no study which has shown benefit in clinical outcome, functional independence, cognitive outcome, etc. So all the studies have taken only recurrence as surrogate marker of favorable outcome. What it should also mean that it is significantly costlier than the standard treatment, which is surgery. And of course, if you do 2 procedures, you are adding 1 more cost for most of the patients. And of course, all these trials are industry sponsored, and hence, despite these being centrally adjudicated, they have a potential for bias. And there are now. So it is an evolving field. It is a very, very safe procedure at preventing recurrence. In a select group of patients, MMA embolization prevents recurrence. MMA is better than observation in another select group of patients. Liquid embolic trials have better results, though there is no head-to-head comparison. They can be a reasonable alternative to surgery in moderate-sized chronic subdural hematomas without significant deficits, and more trial will be necessary to properly understand the role of middle meningeal artery embolization in chronic subdural, and also to prevent its rampant use without good evidence. But it is my feeling that 10 years from now, half of the chronic subdural patients will be treated by endovascular route and not by burr-hole or craniotomy. And that's a huge, huge number. So I sincerely ask one person in every department of neurosurgery to learn this procedure, because so that we don't miss this bus that we missed in 2002 after the publication of ISET. Thank you very much.
Thank you, Paritosh. Interesting, and it's, as you pointed out, it's a mixed result outcome, and we are far away from making any judgments and conclusions. Before I put the questions to the audience, a couple of questions from my part. In the case, the first index case which you showed, the clot resolved. So how does MMA embolization help in resolution of clot? I can understand it prevents recurrence by stopping the neovascularization, but absorption is a natural process.
It's a natural process, yeah. So it's by brain. And this is happening continuously. The brain is trying to absorb the
So
blood.
I don't understand the logic of doing these studies where you have an MMA embolization versus observation.
So there are moderate sized.
Because the mechanism of the resolution is going to be the same in both groups.
Yeah. So if you have say a 10 millimeter chronic subdural hematoma in a 80-year-old person, many doctors would probably observe that without significant deficits. And the theory is that the outer membrane keeps on bleeding, leading to an expansion of those hematomas in more number of people than the absorption itself. So brain is trying to absorb that fluid, but there is continuous bleeding as well, so that the bleeding one wins. So once you stop that bleeding, it will absorb by itself.
The question is, as surgeons, when you're putting a burr hole, you might as well ligate the middle meningeal instead of doing an
So
embolization.
I think there is one person in the audience, Dr. Subodh, who did this but did not publish it. If he had published it, his name would be in any JM, but because he's a lazy person, he does not publish.
Subodh, any comments on that? How many have you done?
He always used to, he has told me.
Isn't that a simpler option rather than doing another added procedure?
So
Do
what
a
he
burr
told-
hole at the same time, ligate the middle meningeal.
Yes, so that is what he
Yeah,
told
do
me.
you want to share your experience?
No, but before that, I think the dura is a very vascular structure. So we don't do proximal middle meningeal artery embolization. It can come from the other side. There are various collaterals from the other meningeal arteries which are there. It may not be the best procedure, the proximal,
Might still develop
but it will still be better than this. And I know for a fact that he used to coagulate middle meningeal arteries in all cases when he did.
We started the middle meningeal thing with surgery only.
Yeah.
And later on moved on to embolization. But what happens in our scenario is, because we get a lot of, being a primarily a gastro hospital, get a lot of cases of hepatic dysfunction, where the recurrence rates are very high. They're not normal chronic subdurals. So in those cases, I think it's mandated that we do something to prevent recurrence. So with that, we started the coagulation thing and then moved on.
Yeah.
Okay, thanks. And just one more last before I pass it on. The logic of embolizing before drainage.
Yeah,
and
we
not the other way
don't
around.
know, but there is the logic that I can think of is that it cuts off the blood flow before you drain it again. So even if you wait for like 1 week or something, there is always a potential that it is bleeding at that point of time and it may not be there. But there is no significant, as I told you, that the Canadian trial did within 1 week, and they've got probably the best results in town as if now, though unpublished, but it's been presented in World Stroke Congress.
Thanks.
So just in the scan that you showed, after 2 weeks, there was transient increase. So how long would you wait if there is an increase before reassuring the patient? If there is a non-disabling neurological deficit, mild pronator drift and things.
So headache surprisingly gets better very soon because you have embolized the middle meningeal artery. Resolution takes anywhere between 6 to 8 weeks, the resolution. So we do not scan before 6 to 8 weeks. And that is generally the thing. But yeah, I mean, as you know, that most of the people do not even scan after surgery as well. Scan it only when there is symptomatic. Yes, please.
Sir, one more thing, like as surgeons, we cannot just give all the surgeries to other fields, as you told. So what first thing is like, whenever we drain the blood, we should be very sure that we have done our best to drain the blood. Second thing is, I always tell my patients to sleep for 3 weeks or 1 month and ask them to do spirometry 1 hourly. Believe me, after starting these two things, I don't have a single recurrence. Previously, I used to have recurrence, but I just, because you only presented the brain takes time to expand. So how are you going to make the brain expand? Because if you make them sit, if you make them walk, because of gravity, your brain is going to again fell down. So what I have started doing is just make them lie down. अरे भैया तू सोएगा नहीं तो वापस होएगा फिर मेरे को नहीं बोलना. Simple thing, simple. And I asked them to do spirometry 1 hourly, 2 hourly. Believe me, if you believe, last 5 years I don't have a single recurrence.
No, I believe you. You should publish this data. I think it is a fantastic thing. You should publish this data.
अगर तू सोएगा नहीं तो तेरे को होएगा बस.
100% you
Thank
should.
you. I
yeah.
guess somebody has rung
Thank
the
you.
bell and we need to be moving on.
Thank you, sir. I'd like the moderators to kindly facilitate Dr. Paritosh small token. Next, we will have a case-based panel discussion to explore various treatment options for high-grade brain AVMs. This panel will comprise Dr. Matthew Abraham from District Hospital in Cochin, Dr. Sunil Furtado from Manipal Hospital, Yelhanka, and previous head of the department here at Satisai, and Dr. Shweta Kedia from the All India Institute of Medical Sciences, New Delhi. My colleague, Dr. Sanjay, will be presenting the cases for discussion.
Yes, so we have an interesting session ahead, but we are running 1 hour behind schedule as of now. So I guess to crack things up and have it faster. In fact, Sanjay has prepared 4 interesting cases, and just saw in the previous panel discussion, we could hardly discuss 2. So we'll make it short for the sake of brevity and clarity. We'll try to make it very short, pinpointed questions, and we'll try to go ahead so that we can cover all the 4 cases, because all 4 are very important and very interesting cases. So you'll just start off, Sanjay.
Good afternoon. So why high-grade AVM matters? They have a highest treatment-related
Sanjay,
morbidity.
Can we just go on to the cases so that we can cut down on?
Yes, sir.
and
So
have
the
more of
first,
discussion, yeah.
the first case scenario, we have a similar AVM between one in a 15-year-old male patient, and the second one is in an adult patient, both presented with focal seizures. So both were the first case is an SM grade 5 AVM. The second one is also an SM grade 5 AVM, but this was in a 37-year-old female patient. She presented with left upper limb and lower limb partial seizures since 17 years.
So yeah, before that, I just forgot to introduce the panel. We have, fortunately, we have all 3 neurosurgeons here. One is exquisite surgeon, cerebrovascular surgeon. Dr. Shweta is into radiosurgery. Of course, baseline surgeons, all of them, and Sunil is good in intervention. So it's the right combination to discuss. So we have 2 cases, one adult, one pediatric, both Switzerland grade 5 AVMs, large AVMs, one on the right side, one on the left side, both eloquent. Now, both unruptured, presenting with seizures, both, no?
Yes, sir.
Presenting with seizures. So you can't call it asymptomatic. They are symptomatic. And we'll start off with Matthew. He's
First of all,
eager to.
First of all, these are unbled.
Yes, sir. Yes, sir.
At the outset, let me say that grade 5 AVMs come approximately 7%, 5 to 7% of all AVMs. So nobody should carry a concept that this is the average AVM that you face. 80% of AVMs are low grade. Now, the patient still has non-refractory seizures, but is a young patient, 15 years. So his lifetime risk of bleed is quite high. This is the previous
Is 15, one is 37 years.
The second one.
37.
This is 37
This is
years.
37 years.
Again, unbled, sitting on the eloquent area. Large lesion, but the advantage is it's a compact nidus. It probably has feeders from PCA, ACA as well as NCA. In this circumstance, I think this is a good operative case. But the extent of the lesion is quite large, and it's a lot of hard work involved in controlling the entire area. I would prefer to have the ACA and maybe the PCA feeders embolized.
Before that, Matthew, just to the three panelists, would you treat or not, Sunil? Would you treat this patient or just with anti-epileptics, or would you try to intervene or not? Just one word answer, just.
The first case, can you show me the first case?
Yes, sir.
This one, we just have to rule out whether it's actually an AVM or a cerebral proliferative angiopathy. I'm not sure whether this is an AVM to start off with. Many of the AVMs, as you can see, you have a compact nidus, and you should have a large, you should have an early training vein. Of course, veins are seen because that's part of the proliferative process and the blood has to drain. But
So
the picture
assuming this is an AVM, would you treat? Or not?
I would treat the other one, because you don't see large veins here, you don't see a varix in this case. But the other case,
So
the
why
30
the treatment is, what's your aim
the
of
risk of
treatment?
bleed, the chance of
Prevent
bleeding.
the risk of, so what would be your?
15 years old, this patient, I also would doubt whether this is AVM, this can. So I would give anti-epileptic to this patient and wait and watch. The second patient, 37 years old, I would send to my endovascular. If they can reduce the volume of the nidus, I might then proceed with gamma knife. But again, I would be hesitant because in that case also the radiation-induced changes would be high. So maybe I would still stick on to giving anti-epileptic and see if the patient
So
is
you
not.
would primarily watch. Matthew is keen on operating, Matthew, right?
This is, you need a early draining vein, from that it's an AVM. Taking it as an AVM, this 15-year-old boy has a long life ahead of him. I would prefer to treat.
Okay. Now, in the background, just one, the background of the Aruba trial, the controversial Aruba trial, all three of you, I mean, except Shweta, all three have differing opinions on the second one. And the first one, assuming AVM, I guess all of you want to treat. So when you have some evidence to suggest that intervention can be deleterious, you weigh the risk of hemorrhage above the risk of intervention, right?
Aruba trial, I will say, we need not find fault with the trial. Aruba trial is actually exposing the way AVMs are managed currently in our setup. That is 30% of cases. That is, of the 94 patients managed, 30 had only standalone embolization, which is unlikely to cure. And 31% patients, and 31 patients had a standalone radiotherapy, and only 5 were really operated on. 18 were operated on, of which 5 exclusively with surgery. So it does not give the outcomes of surgery. So it shows that the outcome was 3 times worse than the natural history of the AVM, which means that standalone embolization, standalone radiotherapy taken independently is going to worsen the outcome of your patient. So that's what the trial
We'll come
exposed
to that later because in the other cases. So just the highlight of this 2 cases were incidental or kind of unbled large specific Martin grade 5 AVMs. So what would be the opinion of the panel? Wait and watch or intervene? Because both are relatively young patients, I guess the opinion is to intervene considering the risk of bleed. Am I right? Whichever way, I'm not going into intervention.
So the risk of bleed, so we have these patients in follow-up. I haven't seen them come back with bleed. They are suffering from severe headache, which is what they occasionally come back with. Seizures are also manageable. There will be a long-term seizure control. So yeah, I would.
Okay. We'll go on to the next one so that we can have.
This is a case in so the no sir, we had sent the second one to the man for the GKRS. First one was under observation. The first one was under observation. Second one was sent for GKRS. So now we have a case scenario 2 where there was a 37-year-old lady. She had right-sided simple partial seizures This is an SM grade 5 lesion in the left parieto-occipital region. The feeders were ACA, MCA, and PCA. There were also meningeal branches from MMA. There was a large intranidal aneurysm with a bleb fed mainly by the meningeal branches of MMA and STA. So this is actually a case report where they went for a staged radiation for the lower half of the lesion. Unfortunately, the patient bled 1 month later. Uh, in this particular paper, sir, which I wanted to bring into discussion, they said that based on T1 weighted GADO images, they were able to say the focal weakness was in the wall of the aneurysm because there'll be a faint enhancement of the aneurysm wall. So what they did with this particular case is they did targeted embolization of the intranidal aneurysm. Okay, sir.
One thing is looking at the picture, it looks more like a venous varix than an aneurysm by itself. So I'm not sure whether the aneurysm has bled because to have the middle meningeal artery, I think you can see on the first picture, it looks more of a early venous varix.
Sorry, sir.
There. And if you go to the other pictures which you showed after the CT scan with the bleed, the angiogram, the one after that. Yeah, this is after. You can see in the first picture there that it's more of a venous varix which is formed after the nidus has been, the part of the nidus has fed into the aneurysm. So I'm not sure whether it's an actually intranidal aneurysm by itself. So in this case anyway, I would first embolize the central part, the one which is with the nidus, the area very close to the varix. The problem with that is you don't want a lot of the embolic material to go into the venous side because you're partially embolizing it. So try to cut off the nidus as much as you can, prevent the risk of bleed, and then hand it over to radiosurgery.
I agree. So this is what I would do. We do generally a dose, we prefer a dose staging. So I would send first to my intervention person and find out if there is any leaking point or a weak point. We would want that to be embolized. We prefer a sectoral embolization, but I think technically that has been very difficult for our team. So,
Would you like to highlight on that?
yeah, so that weak point would mean either aneurysm. So generally we see the...
So yes, sir.
Yeah, he said on the venous varix wall or the aneurysm that they were suspecting wall, he found it as weak leak.
Yeah, based on T1 weighted GADO images, they said you can see on the right image on the bottom, ma'am, they've shown that there's a faint enhancement which is not seen on plain T1.
I mean, generally we do not appreciate this. Now I will actually go back and retrospectively try and find out, but this is not the usual comment that we make on MRI that this would be weak. We generally depend on the DSA report that this is either a high flow area. Yeah. And, okay, is this a vessel wall?
One thing with one thing when you embolize an intranidal aneurysm which has ruptured, the risks are more than your ordinary.
In this case, it is not ruptured. It was after embolization, right?
So which one?
Bled after embolization, right?
Bled after radiation, sir.
Okay,
Not no, ma'am. It was just seizures.
Radiosurgery. The risk of embolizing an AVM is not the same as you embolize a saccular aneurysm. You don't tend to use a lot of coils. Here we use glue to involve part of the nidus, which involves the aneurysm there. So with that, the risk is more. The risk of having any untoward procedure, untoward complication is between 15 to 20% in these cases. The most risk is the vessels walls are much softer than in an aneurysm. And the other risk is the embolic material migrating into the venous side, which can block the venous flow and have a bleed by itself. So the risk is more. So you be as conservative, try to get as much flow reduction. And
So
then
Shweta, how do you assess this risk of bleed following GKRS? Like what happened to this patient? What are the predictors to say that, okay, this patient is likely to have a
So as per the literature also, a deep venous drainage location of the nidus closer to the ventricular end tend to have a higher, multiple arterial feeders, they tend to have a higher
It's the
risk
same
of,
as you predict for an AVM bleed.
absolutely.
And an
So
incidental AVM, you how to predict risk of bleed, multiple feeders, single draining vein, so forth. Same.
yes, same criteria. So based on DSA findings and location of the
Matthew, what would
nidus.
be your approach for this patient?
This is a blood AVM.
No,
Yes, sir.
blood
which
following,
requires-
following treatment, blood following gamma knife.
Okay.
Initially, I'm
I will go for, I will ask my interventionist to reduce the bulk of the AVM and go ahead with an excision. My feeling is that we should not wait too long for it to bleed again. It's a compact nidus, reasonably fair for excision.
another thing which we should always understand is whenever you partially embolize an AVM, you don't do any adjunctive therapy like radiosurgery. Radiosurgery reduces the angio architecture, the angiogenesis, but embolization has a negative effect or the opposite effect. It induces a lot of angiogenesis, new angiogenesis. So you have to do just doing partial embolization and waiting for saying that waiting for it to kind
So
of.
what would you prefer, Matthew?
I fully agree.
With
Agree with him.
But
But
you would prefer an embolization or a
Yeah,
GKRS?
within 48 hours, I will exercise. Immediately
If
after
you-
embolization, I will not wait for any new feeders to induce. And since it is blood, the embolization may further increase the risk of make it more unstable as from the bleeding point of view. It is unfair to wait two or 3 years for the radiation to take its course. The patient will carry an additional around 25% risk of a major catastrophic bleed during the waiting period. So I think the risk of an excision will be well below that.
So you would primarily prefer an embolization
Followed by excision.
as an adjunct prior to
Adjunct.
surgery rather than gamma knife prior to surgery.
The embolization will reduce the amount of work the surgeon has to do, like seeing the large extent and the blood flow. So that would be the advantage.
Proceed with this. What?
So we have also done a study on that, which is going to be soon published. We did not find it very different. And I think as in all other procedures, more and more patients would unnecessarily be going for embolization. If you're doing radiosurgery, I would want to wait and see the response for radiosurgery and then decide on embolization based on follow-up images. So either I prefer embolization followed by gamma knife or just gamma knife, not.
So yes, sir. So in this particular, case, post embolization, the patient underwent stage GKRS to the upper 1/3 12 months later, and a third setting to the residual nidus later. No surgery was performed. This was a case report from where the case was presented. So this just what ma'am mentioned just now. This case was to bring about that discussion. In this 12-year-old girl with the normal, she presented with GCS of 14. The CT shows a small bleed, and the CT angio showed a callosal AVM, SM grade 4. So the patient, the AVM had a feeder from the left ACA, the right ACA, and the left BCA. And the drainage was to the inferior sagittal sinus and the basal vein of Rosenthal. So,
what would be can I go back to the previous one? Next angiogram. This is again an unbled one, right?
This is a bled one, sir.
Bled one. So Sunil, what would be your line?
It's a diffuse nidus. Probably go as distally as possible into the distal anterior cerebral artery. Reduce as much as you can and then go for gamma knife.
I think I would agree with that. Yes. So So volume reduction, so not a targeted curative embolization, but a targeted embolization followed by gamma knife.
I would take the first part of Sunil. It's a blood AVM.
Yes, sir.
It is going to bleed again. The risk of bleed will be around 8 to 9% per year. And by the time the gamma knife does its job, the patient takes a 20% risk of a major bleed. So I will prefer to reduce the AVM size as much as possible. And I feel it's reasonably compact. You can remove it.
Not in this case, probably in the earlier one also. Sunil, what is your take on staged embolization? You said, of course, it increases the neovascularity and so forth, but what is your take on staged for such large AVMs which you saw earlier?
Unbled AVMs can be staged, but if
No,
there's a
and
bled one, then probably you'll have to go
Yeah,
for.
the previous ones I was telling. So, because that was not discussed. How often do you contemplate staged embolization with service? So, at what point, what is the exact sequence in which you decide to hand over to the radiosurgeon or vice versa?
When you stage an AVM embolization, you try to target the nidus, which is having a higher risk of bleed or a higher risk of complications, whether there's a nidus close to a venous varix, a nidus which is close to a venous stenosis, posterior circulation AVMs which have a lot of feeders, very ventricular. Try to get to those structures as much as possible. And if you feel that you can do the second stage or third stage over a period of 2 or 3 months, and the chance of bleed is still there in those cases while you wait for gamma knife, then these are the ideal cases that you could do a stage embolization.
Which are the SM grade 4 or 5 AVMs which you will not embolize?
Those which are in the eloquent areas, unbled, these would probably be better managed with the radiosurgery directly.
How about you?
Same. So if it's an unbled, and if my the intervention person thinks that they cannot access the feeding artery, we would go in for dose staging, preferably in these cases. Dose staging, direct radiosurgery.
Yeah, you wanted to show the planning for this patient and yeah.
Ma'am, so in this particular paper, they had mentioned that the nidus was diffuse, so they decided to go with a cyber knife and give 35 grays in 5 fractions, and followed by onyx embolization. And this was the immediate post embolization DSA, and this was after 20 months. No surgery was performed.
So the sequence was different. They did radiosurgery followed by embolization.
So there are papers which says pre-gamma knife embolization makes it difficult to define the nidus. It's all about defining the nidus. The rest of the thing is done by the machine. So irrespective of gamma knife or LINAC, the outcome is usually the same as what is said. So, but we have not found that. And if I have, as I said, if I have given gamma knife, then I would like to wait. What interval, when did they go in with embolization? What was the time span between gamma knife, between the LINAC and embolization?
Yes, sir. Volume states.
No, this is dose staging, sir. 5 fractions. They have given 35 grays. So it's almost like 7 grays in 5 days. So 7 grays each day. This is what is done routinely for any of our, if you're doing a dose staging in the same duration. The dose staging which we were doing with gamma knife earlier, where we did not have the ICON system, was at an interval of either 2 weeks or 4 weeks or 6 weeks, maybe at 3 months. Now we're giving fractionation over 5 days also, because we can do it with gamma knife.
I am not exactly sure, but about the interval, it wasn't too far off. It was within a month.
Is there a time interval defined? I don't know.
So Dr. Girish had asked, suppose this is an unbled lesion, and the patient is in maybe in the 4th or 5th decade.
Not audible, sir. The mic.
Suppose it's an unbled lesion. This location in the midline is likely to give severe neuropsychological dysfunction after a radiation. I would rather prefer to leave this patient any surgery. Observation.
Yeah. 10 minutes.
10 minutes. Yeah, we have that sequence of questions after that to discuss. Just before, so
Which are the-
before
there
Sanjay
is
goes
no,
on to the
access.
sequence of questions, the last kind of final take from all three of you. So for large Spessler Martin grade 4 or 5 AVMs, I understand Dr. Matthew's preference is always embolization rather than gamma knife because they wait
For blood lesions.
ones. Yeah. The sequence of the procedures from both of your sides, you would, as you said, you clarified the ones which you would not embolize and the ones which you. So now, Sanjay, wanted to the last slide, the next case.
So this case was to discuss volume state radiosurgical downgrading followed by microsurgical resection. In this particular case, there was a 28-year-old male who presented with an unbled AVM with an intranidal aneurysm, SM grade 4, superficial and deep venous drainage. Right MCA feeder was there. So yeah, I just want to ask your opinion on this before I tell you what was done.
Post radio surgery. This is an unbled AVM, no?
Yes, sir. They have done a partial irradiation to the.
This is a single stage radiotherapy done without
Yes, sir.
embolization.
Yes, sir. Yes, ma'am.
Volume stage.
Yes, ma'am.
This is actually a good and comfortable lesion to exercise. The vascularity has come down. I think that's a good choice. Directly, I mean, to exercise after radiotherapy. This is a 4 eloquent deep venous drainage, reasonably risky lesion. Unbled gamma knife followed by excision is a good option. But the most important thing is you have to do an angiogram after gamma knife. You cannot take an MRI follow-up. The studies have shown that more than half of all follow-ups in large gamma knife series has been only with MRI, not with angiograms. So the risk of a bleed persists even after, even if it shrinks, and even after total obliteration of an AVM by angiogram, there is a 1% risk of bleed persisting after radiosurgery. So if you have a shrunken AVM of this sort, it's a very good candidate to excise.
No, even before that, would you consider direct surgery for this patient?
I will prefer unbled, eloquent. I will prefer gamma knife followed by, since it's compact, it is small also. It is
on the right
3
side,
centimeters.
so I guess the direct surgery also would have been a.
Direct surgery is a reasonably good option. Gamma knife if they prefer. I'll discuss this option.
Oh, Sunil?
Yeah.
3 centimeters in size.
It's on the right side, and the angiogram shows it's pretty diffuse, not too compact, but the venous drainage is seen very early and very close to the feeding arteries. So embolization would be difficult. Since it's on the right side, if push comes to shove, I would probably operate directly rather than embolize or give gamma knife.
What was the interval between these two scans, post-RT scans?
So post-RT at 1 year, sir. The surgery was done at 1 year. So post-RT scan is 1 year, sir. And that's the post-surgery. The last one is the
I was
post-surgery.
wondering if you had waited some more, whether that would also have disappeared.
Yeah, so 1 year interval, I think it's too early to decide for intervention.
Yes, ma'am. So in this particular case, they had mentioned that they had only irradiated the medial half of the AVM. They've not irradiated the whole AVM. So this was something I wanted to bring into discussion about partial irradiation versus a complete irradiation.
The volume looks manageable to me, so I think we could have gone ahead with single stage also, but everything changes when you are planning. And again, as I said, we would otherwise dose stage it if the volume is large enough. But if I have given radiation, I would want the radiation effect, to see the radiation effect and then intervene. I agree there is chances of post-radiation bleed, but 2 to 5%, not much. And if we have an embolization option, that is the idea, to reduce the risk of rebleed post-embolization. And therefore, I would prefer waiting on the patients, and the risk of bleed anyways, I think is not too much.
What is an ideal interval to wait for post-radiation, ma'am? You said 1 year is too short.
Post-radiation, actually the effect starts at 6 months. So the idea of saying that the effect takes very long time is only because we do interval scans at a longer interval span. Otherwise, I think at 6 months also, if we've done, we've seen the nidus shrinking very well. The dose of radiation, which we started from 25 grays, has gone down. And there are certain locations where we have seen the 18 gray dose, 15 gray dose, like basal ganglia, responds very, very well. So the risk of radiation necrosis and catastrophe has also gone significantly down with current advances. The embolized material also are excellent, and therefore the hidden nidus also, that concept is also disappearing. Interval is usually 4 to 5 years. Before I decide my gamma knife has not worked, I would want to
4 to
wait
5
till
years?
5 years. 5 years.
Yes, thank you. And the concluding take-home messages for a large Spätzle Martin grade 4, 5, unbled one. I guess it's a divided house. Matthew wants to be aggressive, young patient. Pardon? Yeah, okay. Grade 4 in a young patient, you need to risk the balance between hemorrhage, risk of hemorrhage versus the natural course of the illness. As for intervention, I guess it is always a combined effort where all the three, embolization, radiosurgery, and then the sequence of events as there are some AVMs which you would rather give radiosurgery rather than embolization before you operate. Any last statements you want to comment? And one sentence, just one.
I would say
take-home
embolization.
message.
Sorry, I would say embolization is it's somewhere in between. It's just the start of the treatment. It's not always the curative.
It's not a standalone treatment.
So you'll have to combine it with your surgery or your not cured.
I agree with sir completely.
But radiosurgery can be a curative as well. For grade 4, not necessarily for grade 4.
Yeah, I fully agree. This is a small, I just want to re-emphasize, this is a small component of the entire spectrum of AVM. You have a much easier spectrum left. Nobody should get demoralized to think that this is a spectrum that you are handling always. Standalone embolization, I have a feeling, has very little role. And in a blood AVM, there is always a priority for curative. And surgery immediately eliminates the risk of a rebleed. Even if there is an element of risk of 10%, I think it's still worthwhile taking over any modality which is likely to cure in a late stage.
Agree with Matthew. We have a multiple times discussion. In fact, grade 1, 2, and some grade 3 surgeries of AVMs are sometimes much easier than that for aneurysms actually.
Any questions from the audience?
I will say, if you are having a good perinatal dissection technique, and if you see other than one patient, all of them did not have a deep extension to the white matter. They will not get major deficits if you go carefully. And if you can reduce your workload by embolizing the less accessible feeders. A deficit can come, but in general, AVMs are kind to the surgeon. Deficits are much less than what you expect. Probably the eloquent areas have moved away from these regions. Yeah, there are 3 stages in excision. First, you have a arachnoid plane through which you can go, followed by a gliotic plane, and very seldom you will have to go through true normal brain.
Thank you very much to the panelists and to our moderators. I'd like the moderators to please present some small tokens of appreciation to our panelists, followed by which Dr. Sarita will present 2 mementos to our moderators as well. We have a slight change in schedule to accommodate travel requests by some of the faculty. So the next session that was on skull base was supposed to be after lunch. Instead, we'll go ahead with the first half of that session, that is the panel discussion before lunch. And then we'll continue with Dr. Prakash Naik's talk post-lunch. So this next session will be on skull-based pathology. And the two moderators for the session will be Dr. Anil Nanda and Dr. Matthew Abraham. I request them to kindly take their places on stage, please. We have three eminent panelists for this panel discussion. The first one is Dr. Anand Balasubramaniam, who is a senior consultant and head of the Department of Neurosurgery at Amrita Hospital, Faridabad. We also have Dr. Vijay Sarathi, who is professor and head of the Department of Endocrinology at Vaidehi Institute of Medical Sciences and Research Center here across the road in Whitefield. And finally, we have Professor Rajesh Balakrishnan, Professor of Radiation Therapy and head of the Unit of Radiation Oncology at CMC Vellore. So this panel discussion will concern the management of patients with functional pituitary tumors that have failed in which biochemical remission has not been achieved despite a primary attempt at transfemoidal resection. So functional pituitary tumors, or PIT nets as they're now called, they're not. So so about 1/3 of all cellular tumors are biochemically functional, and hormonal hypersecretion in these patients manifests as the clinical syndromes typically of either acromegaly, Cushing's disease, or hyperprolactinemia. These patients are symptomatic from the hormone excess, and therefore it is necessary to, in order to ameliorate their symptoms, it is necessary to sort of eradicate disease completely. Now, the first-line treatment for growth hormone-secreting pituitary tumors and for ACTH-secreting tumors is transfemoidal surgery. For prolactinomas, it is usually medical management with dopamine agonists. However, what we wanted to highlight in this panel discussion is the fact that biochemical remission in aggressive functional tumors is becoming progressively more and more difficult to achieve. And this is because over time, the biochemical criteria for remission have become more and more stringent. And what that means for us is that a greater proportion of patients will therefore be classified as being in non-remission after surgery. And that also in turn means that a greater proportion of patients will need adjuvant treatments, either repeat surgery radiosurgery, or medical therapy to achieve true biochemical remission. Now, the first case that I'd like to present today this is a 32-year-old woman who presented with clinical features compatible with ACTH excess. She had progressive weight gain with a Cushingoid appearance, and her preoperative lab work showed hypercortisolemia, with her cortisols failing to suppress with either the 1 milligram or the low-dose dexamethasone suppression test, and a markedly elevated serum ACTH level. Her neurological examination was otherwise unremarkable, and her MRI showed these two hypo-enhancing nodules on almost symmetrically located on either side of the pituitary gland. She underwent endoscopic transsphenoidal surgery. Intraoperatively, when we incised either half of the gland, we actually were able to identify two discrete adenomas. These were then identified, removed piecemeal, and then we have subsequently histological confirmation that both of them were indeed adenomatous samples. However, this patient did not achieve hypocortisolism after surgery. Her lowest cortisol was 7.6, which was achieved on post-op day 2. In view of her cortisol levels to really plummet down to hypoadrenal levels, we did an MRI scan while she was in the hospital. And there was no discrete tumor really visible, although the gland did appear bulky. And at this point, we were really not sure how to proceed with the management of this patient. Some of the questions we thought were whether we should re-explore her now, reassess later, or refer for medical or radiosurgical management at this point. So I'd like to open this question to the panel for discussion.
At the outset, I have a question. Because there are two nodules, do you think it would have been good to do a total excision of that gland there, rather than incise the two?
Both are looking like microadenomas, so they are small. And if you are confident enough to have located them and excised them completely, the cure rate should be good. But having said that, having multifocal within pituitary is very odd. Maybe this is what we are seeing. Maybe the whole gland is not, there is some more infiltration in between that has got left behind. So if post-operative values have not normalized, 3 days, the question comes whether 3 days is enough. You want to give extra time before going in and doing a total hypophysectomy, or that is the question to answer. So I would say probably I'll wait for some time and see, because surgically they have got specimen histopathologically confirmed. So it could be a complete excision. And immediate post-op MRI depends upon interpretation. There are so many issues. I would still prefer to wait for at least 3 to 6 weeks, repeat, assess, and if it is confirmed, then I would then go for a total hypophysectomy.
I would like to start with your very first slide. So indeed, the assays are getting more refined. That's why the cutoffs are coming down. It's not something it's going to be a new challenge for neurosurgery. We are at the same level. I mean, the assays are changing. Check. So coming to the case one, so like as sir already mentioned, so having two adenomas is always a rare scenario. Maybe only 2 to 3% would have. When we have such a scenario, we will always have a doubt whether which one is secreting. Both are secreting. And the very first fact is that did any one of the adenomas met a criteria to be called as a definitive adenoma? Because at least the adenoma size should be more than 5 mm to directly go ahead and proceed with the surgery without the need for an IPSS. If the both were less than 5 mm, I'm still would be happy to go ahead with IPSS, confirm that it is a central origin, and then proceed with the surgery. Just to update the audience that if at all, if you really can have two tumors, you want double confirmation whether which one is an adenoma, we do have something called as a CRH PET CT now, even MDESMO PET CT, which are very specific PET CTs. So if available in the particular center, can also be used to know which one is actually secret. On the other hand, when we proceeded further, when we had two tumors visible, excised, yes, there were pituitary adenomas on histopathology, but they were also ACTH secreting. So maybe adding up the ACTH immunostaining for these tumors and to know that they were non-functional or an ACTH secreting adenoma would be more useful, because many times it may happen that none of them were ACTH secreting, and that may be the one reason why you might have not be able to cure the disease, and the disease may be extra pituitary also. So that's why ACTH immunostaining would help in that scenario to take a decision. And even if I say one of them or both of them are ACTH staining tumors, but why despite removing both the tumors, the disease is still persisting? The possibility is a part of one of those ACTH staining tumors might have remained. The tumor might have been removed incompletely. Or we might have missed a third tumor, which is very, very unlikely though, but most likely it's part of one of these tumors has been removed. The third possibility would be like something called a delayed remission. Because when the adrenal glands are constantly stimulated by the ACTH, even if I suddenly remove the ACTH, the adrenals may continue to produce a cortisol independent of ACTH drive. That may lead to delayed remission, but usually that doesn't last more than 6 to 12 weeks. If you evaluate after 12 weeks, usually it should have been reduced. It doesn't reduce even by 6 to 12 weeks, then it's a real persistence of the disease. If you want to assess this phenomenon, whether it's a delayed remission or a persistence of the disease earlier, we can also choose to do the ACTH. If I do an ACTH on day 3 along with the cortisol, if ACTH is low, but only the cortisol is high, then we know it's a delayed remission. If ACTH is also like high along with the cortisol, then it's a real persistence of the disease.
My role doesn't come now. Maybe a bit, I'm a radiation oncologist, but currently with this baseline, I will not irradiate. Maybe we'll wait for 3 months and then reassess and take a call.
Okay. The question is, do you think a total adrenalectomy in such a circumstances, a patient pays a big price? A total pituitary removal.
Hypophysectomy.
Hypophysectomy.
Adrenalectomy, I think, should not be done.
No, sorry, hypophysectomy.
Hypophysectomy, yes, you can go ahead, but after ruling out other possibilities, because total hypophysectomy are committing to the patient going hypopit for life. So even though we may say it is just replacement of some hormones, it's something which we can avoid. It will be better, because in at least in Cushing's, in cortisol secreting microadenomas, if surgery is done properly, you can have cure rates up to 85 or 90% or higher. So I think we have to focus on that. If that has not been successful, then going for hypophysectomy should be the last resort.
You will prefer to go for a 24-hour cortisol measurement or a ACTH measurement in the
Usually
post-operative period?
24-hour free cortisol we do at either the 6-week or 12-week follow-ups. Before that, to assess remission, we do a simple morning cortisol. If it's less than 1, we say it's a remission. 1 to 3 is also a likely remission, but if it's more than 3, we would like to wait for 6 to 12 weeks and reassess later.
There is a surgical problem actually. Immediate after the removal of pituitary tumor, it is very easy to re-explore within the next, maybe within 2 weeks. After that, your Haddad flap would have taken the attachment, the healing process and the granulation tissue around will make assessment difficult. So if you want to get a definite answer within maybe within 2 weeks, what will be the ideal investigation strategy?
ACTH is the best. ACTH coupled with cortisol. If cortisol itself is low, we're 100% sure. If ACTH is low but cortisol is normal or elevated, I would like to wait because it may be delayed remission. If both ACTH and cortisol are low, we're done. So no need to worry about this. But only if both are elevated, yes, you need to re-explore.
Another point here is whether the pathology came out positive or negative. You have to consider that also. If suppose the pathology had come negative, then the whole thing changes. Then you have to directly go in. If the pathology had come positive and your radiology was unequivocally a microadenoma, then be more aggressive. If radiology also was doubtful and pathology is also doubtful, then you have to investigate more. Then then IPSS and everything comes.
Go back to a fresh case and re-evaluate from scratch.
Suppose we attempt again and find that there is nothing else, but still the outcome is the hormonal outcome seems to be the same. Would What would you suggest test from a radiotherapy point?
Basically, it's more like a clean cell on the MRI, but biochemically you find that there is evidence of disease activity still persist. And maybe at that point, maybe we should definitely consider RT, because if there's a corticotrope adenoma, then definitely told for RT is there, where we treat the whole cell instead of only the contrast enhancing part.
Will you radiate the cavernous sinus also?
If there is no
And the stalk?
If there is no cavernous sinus involvement, definitely not the cavernous sinus. We will treat the whole cell. The stalk, maybe I'll try to avoid.
There is incidence of small adenomas even on the extending along the stalk, even in the hypothalamic base, in some of the diffuse cases.
Yeah, but it's a rare thing to have. But by treating the hypophysis, I think we'll be putting the patient into complete hypopituitarism. Maybe we should try to avoid it unless you have an evidence to say that imaging shows there is some radiological evidence to point towards that.
In such
As
a
routine,
circumstance,
we don't include that.
Okay, understood. In such a circumstance where you cannot eliminate, you find that there is no, even though you have reoperated, and maybe after a limited radiation, you have not been able to eliminate the ACTH secreting this one. When will you refer? After how long, or what will be your indication to refer for an adrenalectomy?
Sir, usually we don't.
A fracture, patient is having severe diabetes, multiple spine fractures.
Sir, frankly speaking, corticotropinema is one of the very good tumors that respond to radiotherapy. So most often we will have a challenge to just maintain the, control the hypercortisolism until the radiotherapy takes an effect. So typically we use either a ketoconazole as one of the initially preferred drug, so which usually responds well, though the escapes are well known, and in some patients ketoconazole may not be able to control. So the other limited drugs.
Is ketoconazole?
Sorry, sir.
How effective is ketoconazole? Found quite disappointing.
Ketoconazole, sir. Ketoconazole would control around 50 to 60% of the patients. So whereas another 40 may not control on ketoconazole, and then we have very limited options in India. But of course, if we look at the abroad, we have osilodrosode, which is a wonderful drug, which is doing a great job in controlling the hypercortisolism. But we talk about the Indian scenario. Yes, after ketoconazole, we can go for either a mifepristone. Again, it's a challenge to use. Either maybe a low-dose mitotane. So when the patient is a severe hypercortisolism, we can go for an etomidate. So otherwise, we most of the times will be able to manage only on ketoconazole till the radiotherapy takes its effect.
Thank you.
We have another case. Dr. Prakash Nair had one comment.
One point regarding the re-exploration. I think, like Sir was saying, it's very important to reassess the histology. If we have sent two specimens and we've labeled them separately, labeled them as A and B and sent it, and one of them is even positive, then there is a great deal of benefit in re-exploring early. Especially as Sir said, everything sticks, especially when we do flaps. Re-exploration is difficult. But if both your adenomas are negative, then I think an entire workup, including IPSS, would be very useful, because we have had scenarios, especially in men1, where patients have had gonadotropic tumors detected on histopathology, and a second tumor has been present in the viscera.
Thank you.
As a surgeon, we should not forget. We should see the pre-op MRI again. We should see all the endoscopic images what we have saved while doing the first surgery. And if we are not confident that we have removed the complete adenoma, then we should always go in. That is the point which all of us are missing here. Because you told that Haddad flap will take over within 2 weeks. So as a surgeon, we should first primarily do our own duty. We should be happy to see our own images. If we are not happy with our own images, our own work, better go in and do it with one of your colleague or a senior elder surgeon who is more better or efficient than you. This is also one point we should discuss here.
Understood. We can go with the next case.
Right. Our next case is a 45-year-old man who presented with clinically with features of acromegaly. He also had bilateral visual loss with bitemporal field cuts. His hormonal profile demonstrated an elevated GH level at 46.8 nanograms per ml and an IGF-1 that was also elevated for his age and sex. He also had some central hypothyroidism, but the rest of his HP axes were normal. So his MRIs showed this Hardy C pituitary macroadenoma compressing the optic chiasm and also invading the cavernous sinus, encasing the ICA on the left side. So this patient also underwent an endoscopic transfemoral approach. And intraoperatively, we had planned a subtotal resection in this patient. So only the tumor that was in the cellar was actually dealt with. And we left behind residue in the cavernous sinus. This patient's growth hormone level on post-op day 1 was 7.4, and then he was otherwise discharged uneventfully. His 3-month follow-up MRI showed a fairly good excision of the cellar component of the tumor, but the paracellar component in the left cavernous sinus still persists. And his GH levels were modestly elevated, but definitely above. And his IGF-1 was also sort of on the higher side. Clinically, he was better. His acromegalic features were, he reported, he felt were regressing, and his diabetes and hypertension were also better controlled. So the question was now, how do we further manage this patient?
Your opinion, Dr. Anand.
Yeah, I would have loved to see the T2 images also, to see how much is the invasion, and then go back to the histology and see if they had any signs of invasion of the disease. If there is a lot of invasion, in the cavernous, whatever you leave behind, growth hormone secreting adenoma, again, the same caveat as in Cushing's, surgery offers the best chance of cure. All other modalities come next. But safety is most important. So if the cavernous invasion is still resectable, that is possible only in non-invasive cases without morbidity, I would still go in and try for removing the cavernous residue. But if I have any doubt of safety on that side, or if there is invasive disease, then best is directly send for radiation. They also have a reasonably good amount of control, but it takes years to control. That is when our medical people will have to help, because there are plenty of drugs they can start on.
Will you assess this as a failed surgery?
Yes, sir. It's probably, I don't say failed. In fact, like the surgery has helped us a lot, because at least I would have been able to debulk the load of both the tumor as well as the biochemical abnormalities. So at least I'm going to reduce the morbidity or mortality from maybe 100 to 10. So definitely it's a very successful surgery. The surgeon has done the best what they could do. Obviously, I can't expect that they will remove the cavernous part as well. So obviously, like this is an uncured or unremitted disease, we need to definitely act for further control. So since there is no further scope for surgery, we have to look for either a medical therapy or a medical therapy with radiotherapy as the second and third best line options. I would definitely would like to go back and look at what was the prolactin, because that will help me. In fact, if the prolactin was in 200,000s or 3,000s, even before surgery only, you could have considered cabergoline, because the coexisting and co-secreting tumors, especially when prolactin is more than 1,000, even if it's a GH co-secreting, they do well with the cabergoline. So, but it's very rare scenario. Most of the patients will have a normal prolactin or a slightly high prolactin, which is not co-secreting. In that case, whatever has been done is absolutely okay. So then what we come to medical therapy, is probably something we have like octreotide LAR is the best option we have in India now, though in abroad again, Teserotide and Pegosumat are the best options that are available. But for Indian scenario, octreotide LAR is the best scenario. So we have around 20 mg to start with, gradually escalate till 40 mg. 1 year remission rate, especially with this kind of a already well debulked disease, our remission rates can go up to 70 to 80%. Less debulked disease, we may achieve around 40 to 50%. However, on a long run, it's not a very cost-effective approach for patients. Some patients may even escape the control over time. So it's why it's very good idea that we do simultaneously plan a radiotherapy with medical therapy as an adjunct. So, but the point is that whenever giving a radiotherapy, we don't place the medical therapy around, because that may reduce the efficacy of radiotherapy. I think probably radiotherapy has a good role. I would ask her to take over.
This, I had a question to you. Now the central part of the tumor has been removed, and the chiasm is free. Do you think this gives an advantage from a radiotherapy point of view?
Basically, now if you see the pre-op imaging and the current imaging, the pre-op imaging, the chiasm was very close to the tumor bed. But now here you can see that the chiasm, we have a gap of at least maybe more than 2 to 3 millimeters from the tumor per se. So that would definitely help radiotherapy treatment planning, because when you go for a radiosurgery, the chiasm distance. If it is more than 3 millimeters, it helps to reduce the dose to the chiasm very much. So basically here, I think there is some residual disease even present on the contralateral side, on the right side as well. Maybe while doing the RT, maybe we need to include the whole of the both cavernous sinuses and give a margin entry. How we decide whether to go for a radiosurgery or go for a fractionated RT is like if the lesion is big and very close to the chiasm tumor distance is less than 3 millimeters, we'll go for a fractionated radiotherapy. Fractionated radiotherapy, there are two types. One is the conventional fractionation, where for a functional adenoma, you go for a dose of 50.4 grain, 20 fractions. Or there is a hypofractionated regimen where you give a dose of 25 grain, 5 fractions. Both of them have been equally good. If it is a single fraction you want to give, the distance between the chiasm and the tumor should be more than 3 millimeters. And for a functional adenoma, a dose of maybe 18 to 22 gray would be an ideal one.
How long will
effectiveness
it
takes
takes for the
as a
radiation not to work?
Yeah, basically cabergoline, when you give along with radiotherapy, it increases fibrosis and increases the response. So ideally we would like cabergoline to be stopped at least 3 months prior to giving the radiation. We can start after 3 weeks.
I had a question to Dr. Anand. Now there is the lesion is in the cavernous sinus. Would you like to go for a transcranial interdural approach to access the cavernous sinus?
Well, as
Patient
I
is
said,
not very keen on radiotherapy.
as I said again, if I am confident that going through transcranial will be able to resect the disease, then I would subject the patient to that trauma. Otherwise, I wouldn't. In this, transcranial will not help me cure the patient. Only I'll be able to clear what is lateral to carotid, what is medial to carotid I won't get.
I think an intracranial approach will be foolhardy. I think it should be condemned. You're not going to get this out of the transcranial thing. So even to give that opinion is probably foolish. I mean, I would just go with gamma knife on this. I think we'll get good control. But I do not, I mean, I don't want some young person here saying, we're going to go transcavernous and take this out, because you'll end up hurting the patient. You know.
We have done quite a few growth hormones with intraop MRI, and we found that for functioning adenomas, the intraop MR is very useful. And we have tried to go into the lateral aspect of carotid through the anterior, what is now described as the tan pterygod approaches. You can go to the lateral aspect of carotid and take out those also. But then the morbidity is quite high, especially if it is invasive.
I'll ask Prakash a question.
Yeah, Prakash
would you mobilize the carotid and try to take this out through the transphenoidal route?
Yes, I would. I would try to do it. Because in growth hormone secreting adenomas, I think the outcomes that we get after middle cavernous sinus wall resection are significant. Here, the lateral compartment is actually not very significantly involved. Most of the disease is in the anterior, inferior, and the superior compartment, just above the horizontal segment of the ICA, which is actually well accessed by the intranasal route. So I would try.
This is reasonable, favorable for from the medial wall. This is a favorable lesion from the medial wall, no?
Yes, sir. Not only the medial wall, but also the horizontal. So once we open the medial wall, we'll get access to this superior compartment of the cavernous sinus just above the horizontal segment of ICA. And that is also
this
good
part. This part is within the siphon. This easily comes out.
That part comes
This
out
is the
very nice.
difficult part.
The thing is that sometimes what happens is that when we take that part out, the amount of tumor left is very minimal. So I think another thing that radiation oncologists also agree that the Gauss total volume that we give them for RT, if it is smaller, the outcomes are also much better.
Definitely.
Suppose there is a very small residual and there is a biochemical, not full normalcy, there's some elevated IGF-1. How frequently will you keep following it up? The patient is in the maybe 50s.
Usually we start
there is symptomatic resolution, full symptomatic resolution.
Even asymptomatic patients, if there's an IGF-1 is elevated above the upper limit of normal for age and sex, we do consider medical therapy. So we usually start with 20 mg, and after 3 doses are over, before the 4th dose, we check the GH and IGF-1. If IGF-1 is in normal control, we continue the same dose. If it's still not come to the normal range, we may increase the dose. After that, once in a year, we'll miss 1 dose. And before the 2nd dose, we check the GH and IGF-1, because especially we would have given a radiotherapy. So we want to know when the radiotherapy is going to be effective. So in that case, we're going to check annually whether the radiotherapy has taken an effect.
Suppose you're having a large lesion, a macroadenoma with extensive cavernous sinus invasion. What is the type of field you will use? How will you shield the important structures?
Basically, when you go for a stereotactic radiotherapy, we are not going to shield any organs. Basically, we can do the critical structures. We call like post painting. So the most all good chiasm here. That is the only structure we will be seeing. And if you're able to identify the pituitary stalk, maybe you contour that and try to reduce the dose to that.
How
And,
sensitive are the other cranial nerves to radiation?
It all depends upon the dose what we give. If you're going to give a dose of, maybe you can say like a SRS dose, so then the cranial structures we need to be careful. If it is a fractionated dose, they will tolerate up to 54. We give a dose of maximum is 50.4. 55 to 50.4. Tolerate it well.
We are out of time for the discussion. Further discussions. Sir, I thank the panelists and the moderators for making this an interesting discussion. I request the moderators to give a token of our appreciation to Dr. Anand Balasubramaniam. Sir. Please, a round of applause, please. Dr. Vijay Sarthi, sir. And Dr. Rajesh Balakrishnan. I request the moderators to please be seated. We're now going to have a talk on DBS. We'll break for. Yes, sir. Okay, we're going to break for lunch, and we'll reassemble after this for continuation of the session on skull base and functional. So once again, sir, I request Dr. Sarita to kindly hand over the. So just 1 second, sir. And to Dr. Matthew as well, ma'am. Thank you. We'll reassemble after lunch.
Sanjay sir.
Session 6. Uh-huh. Okay. Fine, sure, sir.
Just at 20 minutes. We split it in half because one of the faculty, so that will just be, I think, a 15-20 minute talk by Dr. Prakash Nair. Yeah. So then your talk, and after that you can. Dr. Prakash Nair. Oh, that was good. Yeah. Oh. No. Prakash Nair. Then we're not. Lift is open on this thing also. Yeah, it's covered. So we can take the hardware over. Maybe look at close of everything and we do that. Yes, sir. Some PPT might be open. Last. Yes. This is here. Yes, it will be. Maybe someone is there. Maybe just see whether the videos are running or not. Sometimes what happens is you use another laptop. Yeah, the video. They lose their orientation. Please close the open dialog box. What that means. Right? Yes, sir. Click on it. And can I control the sound from here? No? I think so. By using or deleting the sound. Okay. You don't want audio, no? In some slides, yes. Okay. You can play that one. Oh. I have to click on it, is it? Yeah, on the this thing you have to click, then it will start. Can you click on it? It has paused. Yeah. It's playing on that thing. Yeah, but here it's not. Here it's little bit tough. Yeah, there it's playing nicely. But I have to click on the video. Yeah. I think better I'll maybe use my laptop only when we get this done. Okay. Here again. Was it starting on its own or not? Somehow I think there it's starting on its own. This is started on. I've not clicked. Yeah, it has started on its own. Here it's not moving. Yeah. That's fine, but as long as it's behind also you have to see. You can have a look at that thing, sir. It's the same copy of it's playing by itself. Here it's not playing on the laptop. On the laptop it's not playing, but there it's playing. Why this mismatch? This is an old system, so because of that problem, I think. So I think my laptop might be that because it's all. It's coming in. Yeah, it is. You can just have a look on the screen
front
in
one,
the
that will
front.
be mine, huh?
Yes, sir.
No need to look at the laptop. This laptop.
Yeah, that will be easier, I think. If you want to read, you can look at the laptop, like notes, something is there. For the
Most of
video.
it will be spontaneous.
Yes.
But if I'm using my laptop, this will not be needed.
Yes, sir.
Can we have a look at my laptop? Like connecting this to this?
Yes, sir. But it will be difficult for you to look under this, or else you can.
So it's charging. So one thing is solved.
Yes.
So that will solve a lot of problems back, you know.
Yes, sir.
Just take this out and put this in.
Yes, sir.
So this will be the one. This is the one.
You can use your laptop better, sir. No? Yes, sir.
Working both here.
Both here and there. You can use your laptop. It will be better.
No one is there. I'll just check it out. I can control it here. All videos only. Mainly.
Moment for us with video.
Yeah, man. I'm sorry about the videos are no, but there is no talking.
Yes, sir.
Yeah. So here what happens, if I do this in your, it would have
Yeah, would turn the
turned.
sound.
We are talking escape, do rotate and all that stuff. We hope it is playing normally there. But in these we will mainly sound. This is where I do the micro record.
Okay.
So there the sound is not coming from some sound issues there. This is connected to the sound now. This is a charger.
Yes, sir.
This is a charger. No?
Yeah, that is the charger. HDMI, it carries sound and video both, sir.
This is not the sound which is expected.
Okay.
There is some breaks which is coming. Yeah. Audio will be maybe this one. Maybe this one.
I think they have turned off.
Oh.
open. Right shoulder. No, this is the problem. Coming. These two are fine. ಅದು HDMI ಇಂದ ತಗೋತಾರೆ. So it has gone from there. So can increase the audio. It's now normal. This is how it should be. Well, I can do without the sound also. I can just put the sound on in this when I'm. Yeah, but it won't be audible to everyone.
Hi Ram. Hello, hello.
Your voice will be audible. Keep it there only.
Just come. ವಿಡಿಯೋ ಮಾಡೋಣ ಬಟ್ ಅಲ್ಲಿ ಸೌಂಡ್ ಇದು ಬರಲ್ಲ ಮೀನ್ಸ್ ಎರಡು ಬರುತ್ತೆ ಸೌಂಡ್
Yeah, but without the sound anyway.
last I think the first slide you
Yeah, I tried it. Yeah. And how do we get to the slideshow there? What is that? This is fine. 47, 48. Okay. I'll reduce the volume by myself. No, but others. Yeah, yeah. So I'll do it myself, right? We reduce every volume to get reduced. You don't reduce. You don't reduce. Put it on.
बताएंगे
No, that would have been ideal, but there is a presentation before me, so I'll keep the laptop here. Yeah, yeah. Done. So you can come and test, sir. I'll remove my laptop. Hi, sir. Nice meeting you. Good, sir. How are you, sir? Medanta. I'm removing the solar circuit test. Both the sound as well as this one? Sound I keep. No, this sound. Shall I keep it here or remove it also? Now the thing is sorted out there. Might have to rush.
అసలు అనుకోలేదు. నాకు నయ్యా పైసా కూడా లేకుండా నన్ను బాగు చేసి పంపించారు.
हर प्राणी में साई
ఆ రోజు నేను బతుకుతానని అసలు అనుకోలేదు. నేను డ్యూటీ నుంచి వచ్చేటప్పుడు బైక్ స్కిడ్ అయ్యి యాక్సిడెంట్ అయిపోయింది. కాన్స్టిట్యూన్స్ వచ్చిన తర్వాత 20 days కోమాలో ఉన్నానని తెలిసింది. నాకు 2 పెద్ద సర్జరీలు జరిగాయి. నాకు డబ్బు ఇవ్వడానికి కూడా లేదు.
Check, check. We're going to be starting with session 6, that is on functional surgery as well as DKRS. Our first topic will be an overview of DBS. I would like to invite the moderators, Dr. Shweta Kedia and Dr. Nishchit Hegde on stage, please. I request Dr. Anirban Deep Banerjee to please give us a talk.
Good evening. Good evening, respected chairpersons, seniors, colleagues. First of all, thanks to Dr. Sarita and a wonderful team for this opportunity. So this talk is mainly guided towards a younger audience who are keen on, are interested in picking up deep brain stimulation surgery. So what is deep brain stimulation surgery? The august audience need no introduction. Just to reiterate. Yeah. So in deep brain stimulation surgery, we implant 2 electrodes deep inside the brain on various targets depending on the disease we are treating, and then hook it up with a pacemaker and put it exactly where a cardiac pacemaker is put. So when we stimulate the target, neuromodulate those target, the symptoms of those individual diseases, they reduce and the quality of life improves. So we don't cure the disease, we try to bring those patients back to the mainstream. So scheme of today's presentation is that I will divide the talk in 2 parts, like which patients are amenable for this surgery, a bit on the surgical process, a brief elucidation, and what will be the after surgery management. Now, there are 5 indications for which deep brain stimulation is approved thus far. Parkinson's disease, dystonia, essential tremor, which come under the umbrella of movement disorders, which comprise worldwide around 95% of the indications for DBS, and then intractable epilepsy, adult partial onset, and advanced OCD. Now, coming to the movement disorders, we have a set protocol of assessing the candidature of each patient for the suitability for this surgery based on the decision of a group of doctors what constitutes a movement disorder clinic. So we usually see such patients. For example, these are patients with tremor predominant Parkinson's. The medical therapy is maxed out at the end of the road, or such patients who have not much of tremors, another type of Parkinson, but significant bradykinesia and rigidity, that is stiffness and slowness with lot of gait problems, especially freezing of gait. You can see this patient is having difficulty even getting out of the couch and taking a few steps. Going to the washroom is a big challenge. So there are various checks and balances which we tick or cross in the movement disorder clinic, but the thumb rule is when the medical therapy is maxed out or when medications cause something like this. So this is not the involuntary movement because of Parkinson's. This is because of overdose of anti-Parkinsonian medications, which leads to a specific involuntary movement known as dyskinesias, which is equally detrimental as the primary symptoms of Parkinson's, or something like this. This patient, an advanced Parkinson's patient, he has been oversaturated with levodopa, and this is what is happening. So such patients we evaluate, do proper UPDRS scaling and the neuropsychology assessment and whatnot. And most of all, we discuss the realistic expectation. We are not curing it. We are trying to control the symptoms. The second set is even more damaging movement disorder. This is dystonia, where you have abnormal sustained muscle contraction, either a focal part of the body or a segmental area or a generalized. This is the case of truncal dystonia. This person is suffering from a typical cervical dystonia known as lateral collis. So in my personal experience, I think dystonia is a surgical candidate, but most of them are medically refractory by the time they come to us. You can, especially in pediatric dystonias, you can run some genetic profiling to find some genes and for prognostication of DBS results in them. The third category is essential tremor. In Parkinson's, we saw that the tremor is in rest position. In essential tremor, when the person is trying to do some activity, he sets into an involuntary, uncontrolled shaking of his hands. It's usually bilateral. Again, when the activity, that involuntary movement is disabling the activity of daily living, and is intractable to medications and Botox therapy, he is a candidate for DBS. The fourth set, intractable adult onset partial epilepsy with or without secondary generation. There are a series of checks and balances which we evaluate. And the fifth, of course, the only psychiatric indication which is still approved is OCD. Again, there are checks and balances which we evaluate not in the movement disorder clinic, but in our neuropsychiatric clinic with our psychiatrists. And again, before doing this, you can't just do the surgery for DBS in OCD, but just by taking informed consent. According to the Mental Health Act 2017, you have to take a permission of your respective state mental health board. Now, these are the approved indications. Now, what are the evolving indications? Much work has been done in many of these indications like Alzheimer's disease, addiction, obesity, major depression, Tourette syndrome, minimally conscious state, post-stroke paralysis, chronic pain disorders, but none of them have so far got the approval. So maybe in another 5 years or so, some of them will get the approval so that we can do them without any medical legal hindrance. Now, if you want to do it, we have to do it as an off-label experimental procedure. So coming to the second part of the talk, the surgery is pretty straightforward. You put two spaghetti like electrodes in the brain, hook it up with the pacemaker. Coming to the main 95% of indication, what's the rationale? How do we select the target? So there have been various studies on basal ganglionic circuits, especially by Alexander and DeLong. And based on that, especially in the 80s, late 80s, they have found certain targets gray matter targets deep inside the brain. The first one is the subthalamic nucleus, which is usually a holistic target for Parkinson's because it's the only target that allows us to reduce the medications also, in addition to controlling the symptoms. But those patients of Parkinson's who have very early small dose levodopa dyskinesia or with psychiatric vulnerability or patient with static postural incoordination, we use the GPI for them as we do the posterolateral GPI for the dystonia patients. And for the essential tremor patients, we use the ventral intermediate nucleus, also known as the ventral lateral nucleus. So subthalamic nucleus, if I can have a pointer, that will help it out. Subthalamic nucleus, we define the motor ST in relation to the ipsilateral red nucleus. Now, in patients who have significant gait deformity, we also do tractography in those patients and delineate the hyperdirect pathway and stimulate the part of the subthalamic nucleus where the confluence of the hyperdirect pathway is there, and it leads to significant improvement in the freezing of gait. For dystonia, the globus pallidus interna, T1 inversion recovery images, but my favorite in this is the S phase image of the SWI sequencing because it gives a distinct bordering of the GPE and GPI. The internal medullary lamina becomes very prominent in the phase images. This is the image which I use for the posterolateral GPI targeting. And for VIM, the problem is that the thalamic nuclei, at least till 3 Tesla, they are more or less invisible. So for VIM, we have to utilize the homunculus, which is there in the thalamus. And during the surgery, during microelectrode recording, we have to determine the lateralization and move forward from ventral cordalis till the VIM-VOP border. And direct targeting in this case is practically very difficult with conventional MRI. In significant tremors where you have proximal as well as distal tremors like rubral tremors, we select the posterior subthalamic area because of its closeness to the dento-to-rubrothalamic tract, which we can even delineate with tractography. For anterior nucleus of thalamus is the target for partial onset adult epilepsy. To delineate that, we trace the mammillothalamic tract during direct targeting. And for OCD, the approved target is the ventral capsule ventral striatum, or what we see in a T2 stud image, which is not represented here, a nucleus accumbens, which is the nodal point of the reward circuit. So these are the targets for the approved indications. The soul of the surgery is accuracy. We can't even afford to be deviated by 0.5 millimeter, otherwise we'll lose the plot. To assure accuracy, there are certain checks and balances which we follow during the surgery. First of that is indirect targeting. So indirect targeting is a set of values which has already been prescribed in brain atlases in reference to two fixed structures deep inside the brain, the anterior commissure and the posterior commissure. But it's quite erroneous to just blindly follow the indirect targeting values because no two individual brains anatomy is identical, and we are talking about sub-millimetric accuracy. So here comes the value of direct targeting, especially in the day and age of high resolution MRI, where, for example, here we are directly targeting the subthalamic nucleus in relation to the red nucleus in a patient of Parkinson's disease. So once the targeting is finished, you have to find a safe trajectory, avoid any blood vessel, the ventricles, the caudate, and then you have a very good planning on the preoperative MRI, which we usually perform following the DBS protocol 1 day prior and do the planning 1 day prior to the surgery. But how do you translate all this planning in the stereotactic parlance? For this, you need a gadget which is very commonly used, what we call as a stereotactic frame. We usually do frame-based stereotaxy because it's still the gold standard in reaching that level of accuracy what we want. It acts like a GPS of the car. So on the morning of the surgery, we fix the frame, get a CT, and fuse it with the preoperative MRI planning the day prior, and we get the final Cartesian stereotactic coordinates, which we feed in the surgical suite on the stereotactic arc. And we reach the point where we need to reach so that from there, we can hit our target precisely. But that is not the end of a check and balance. We have something called a physiological target. When you are, traversing the brain, the layers of the brain, for example, again, I want to traverse from the surface to the subthalamic nucleus. First, I am in the thalamus. So each layer of brain will give you a specific verbal. Now we are in the thalamus. Now we have reached the zona. And then once we are out of it. So this is very essential to do during surgery so that you know that you have hit the right spot. Now there are various advanced MER systems which have come, which have with color coding. They make the process of microelectrode recording, that is physiological brain mapping, much more easier. Last but not the least, the final checkpoint is. So not only can we ensure that the symptoms are improved, we can also course correct. Suppose there are side effects because STN has notorious neighbors, for example. So suppose we are too close to the internal capsule, too medial to locomotor apparatus, too posterior to the medial lemniscus, we can course correct the final implantation of electrode based on the intraoperative clinical assessment. Now, some patient, this is a patient of SCA12 with intention tremor. She had the specific problem of writing. So during surgery only, while stimulating, you can ensure that there is improvement in that specific task what the patient has demanded for. I'll skip there some examples similar. So once those 4 checks and balances are done, you put the final electrode, hook it up with the skull, and that's it. That's the end of stage 1. But what we usually have been putting rather, was conventional electrodes. So you can see each electrode has got these 4 contacts each side. So these are all cylindrical contacts, that is, they are not segmented. The problem with this is that suppose your electrode is not at the right spot, you want to steer the current in the X and Y axis. With the conventional electrode, you can just go up and down in the Z axis. So with directional electrode, which we are quite frequently using, you see there are segmentations of the electrodes at each level, at the X and Y level. So for example, you see this pic. The current is going to the side effect area. I want to steer this current at the same X and Y plane to the beneficial area. What I do, I block this segment without changing the Z axis and direct the beneficial effect on the area of interest. Now someone will come and say, I'm not comfortable in putting the stereotactic frame. I'm claustrophobic. We got pediatric patients. So there is a string of frameless options also. For example, robotic, what we sometimes offer if the patient is not awake. It's not ideal, but then, or the conventional stereotactic frameless stereotactic, the next frame, or intraoperative MRI guided DBS. Problem with all these frameless asleep DBS is that this sentence, which many people who are proponents of asleep DBS, they tend to forget that the treatment related side effects is much greater in in asleep DBS as compared to awake DBS. Why? Because we can do the course correction during surgery, which the asleep disease doesn't give you the option. So if you are off the target, you don't have an intraoperative way to make sure that you can again come back to the area of interest. So especially in the medial lateral direction axis, it is seen that the asleep DBS tends to more error in stereotactic deep brain stimulation procedures. Sleep stereotactic procedures are very good for biopsies and all that, because the margin of error is much greater there. But we can't afford that little bit of error in DBS. So still the gold standard is frame-based stereotaxy for deep brain stimulation procedures. So these are experiences which we will share. So once the leads are put in, whatever which way, you get an intraoperative MRI, fuse it with the pre-op MRI, and you get these, we have these 3D models whereby they make sure that you have reached the target. And this green thing is what delineates the motor STN. So once you have reached the target, you go back with the stage 2, which is the last half an hour of the procedure, where you hook up these wires with the pacemaker and stitch up the bones. Now, IPGs have also become rechargeable, and with recent usage of lithium titanate in the recent the brain sensing IPGs, they're even lasting up to 25 years. And in the not so near future, we can even have cranial mounted IPGs, so that you don't have to do tunneling and make the pocket here like they are using in the responsive neurostimulation in epilepsy. But problem with these diseases, all of them are progressive. So one-time surgery is not enough. You should have a stringent after-surgery programming session or brain pacemaker fine-tuning, so that the patient who is well now comes back 3 months down the line with new symptoms. You can play with certain factors resident to the pacemaker and always try to stay one step ahead of the disease. Some patients might say they won't be able to come back again and again. For them, we have this option of satellite-controlled remote programming, whereby the clinician can control the pacemaker of the patient while he's sitting in his living room. He doesn't have to come back frequently to the clinician for this job. Now, with newer technology, there are biomarkers which the pacemaker reads, what we call as, for example, beta waves in Parkinson's, especially for the akinesia rigidity variety. It will read those biomarkers, send an impulse, anticipating the symptoms will come and abort the symptoms. Like you're saying, I'm trying to bring the, it's a bit hazy, this one, bring the beta wave within the upper and lower normal threshold of green and yellow. What will happen in the near future, I think the next month only they're launching, the clinician doesn't have to do this any longer. It will go into auto mode, the device itself will pick it up and do the auto programming, so that the intervention of the physician is reduced to a large extent. Other innovations in programming are multiple independent current control. So to give a simple example, a Parkinson's patient can have both tremors as well as rigidity in equal measure. We know that the lower you go down in the STN, you can control the rigidity better with lower frequency. The higher you go down towards the zona insider, go up, you can control the tremors better with higher frequency. So this variable frequency stimulation system gives us that option of doing this. Complications, no surgeries without complications. The most dreaded one is infection. However, it's relatively a safe surgery because the amount of anesthesia needed in most of the patients is practically nil. Now, we will just, to conclude, see what realistic expectation we can have after the surgery for some of these patients. Some of the slides, videos we showed before also. The tremor predominant Parkinson's, they do very well. The tremor almost practically stops. The challenge is the rigidity and bradycardia predominant Parkinson's, but in well-selected patients, they also have a significant improvement in their quality of life, as you can see in this patient which we showed before. And most of the patients are quite satisfied. Like this patient, significant freezing of gait, and this is 3 months down the line after surgery. You can see there is improvement in the cadence and the turning. And all these patients who have significant gait abnormalities, we do a before surgery and at latest follow-up objective gait assessment on pressure-sensitive treadmill, which has sensors attached to it, and we can make sure that the gait has significantly improved. Now, because the medications also improved by around 80%, these dyskinesia, side effects of the medicines disappear. So good results. But even better results happen with dystonia, although they take a bit more time than Parkinson's. You can see this truncal dystonia lady, which we saw at the beginning of the presentation, or this generalized dystonia person who had failed multiple Botox therapies and other such therapies. They get a real improvement in the quality of life. I personally feel that dystonia, well-selected patient is a surgical indication because most of them, they do well. This was the lateral occlusal patient, which we showed in the beginning of the presentation. Significant correction of the abnormality. And these are patients who were contemplating suicide before they opted for this therapy. Or another patient, another variety of cervical dystonia we call as torticollis. So I think we should be much liberal. Our threshold of offering DBS to dystonia patients would be much lower than what it is now, because the quality of life changes dramatically. Another such patient with torticollis. So the third variety of cervical dystonia, which again remarkably responds to DBS, is retrocollis. See this patient, she's walking with her face pointed to the roof. Failed multiple Botox therapies, life like miserable will be an understatement. And significant improvement after DBS is 3 months down the line. Now, this is a patient of segmental dystonia, cervicobrachial dystonia. You see, the smile will tell the story. Now, in pediatric dystonia, especially the DYT1 positive dystonia, like this child who has never had the use of his legs, never stepped on the ground from birth. After surgery, 2 months down the line, first time he started walking. Another very peculiar type of dystonia is the Tardive dystonia, which usually happens due to inappropriate use of prokinetic drugs like levosulpiride, which come in combination with proton pump inhibitors. And these patients also remarkably respond to deep brain stimulation surgery. Essential tremor, again, like the Parkinson tremor, easy to treat, so not a big deal. You can see good hand control after surgery. Epilepsy, thumb rule, over 50% reduction in seizure frequency by 1 to 2 years in about 50% of patients, but with chronic stimulation, the percentage keeps on increasing with years. And same as in OCD. The rule is 50-50. Significant lifestyle changes, patient goes back to their normal activity. 5 years back, there was a high myth that you can't swim if you have a brain pacemaker. Nothing like that. This patient personally made it a point to make a video and send it across to us. So numbers don't matter. It's around 15 years. I came back from Cleveland Clinic, and there are numbers, there are results, but the real purpose is to decentralize the therapy. We should not keep this therapy to a few centers. So in that quest, we keep on encouraging the younger generation to have centers with proper infrastructure and training, so that even tier 1, tier 2, tier 3 cities all across Indian subcontinent, neighboring countries, the Russian Commonwealth countries, Middle East, Africa, they have this facility. So it should be where the cardiac pacemaker is today here. 10 years down the line, brain pacemaker should reach that stage. That is our purpose. And also have national and international, national registry, which we definitely lack, in record keeping in India, and hook up with the international patient registries, which will help in, further increasing the efficaciousness of our artificial intelligence-based automated programming strategies, especially with our indigenous brain pacemakers coming up. Our friends are there from Sri Chitra, they will know in the audience. So in India is not any longer just an adopter of foreign technology. We are greatly evolving as innovators also. But the conclusion again boils down to the basic. If you have a proper patient selection before surgery, good placement of surgical electrodes during surgery, brain electrodes, and after surgery, stringent programming and follow-up of these patients, you will have a proper response or a successful outcome. The proportion depends on how much good you are in doing this. And this is nicely elucidated by this concluding slide, where I took an academic liberty to put the pacemaker off, and you will see immediately the symptoms, the shaking movements will reappear.
Thank you. Dr. Anirban, we'll
Yeah.
have to ask you to conclude.
So this is just the last slide. And immediately I put it on, and the symptoms come back under control. So the quest towards freedom from disability continues and ensuring happy smiles. Thank you.
Thank you, sir.
Thank you, Dr. Anirban. That was a very good overview for the audience. It is not easy to cover everything that you covered in such a short time. I'd just like to add a couple of comments. The gold standard, as you said, right now is still doing it awake with MER recordings, but there are a number of big centers in the world who are moving more and more towards the sleep because imaging is really good now, planning is better, and also with the advent of the directional leads, they're able to shape that stimulation. Agreed, if it's more than 1.5 or 2 millimeters off target, then directionality doesn't matter. But once you start doing the numbers and everything, the protocol and a pathway is established, these centers are doing really good cases within like 2-3 hours or 3-4 hours on the day off. So that's one. And adaptive, like you said, it's the next big thing. I think the Boston team is focusing more on image-guided programming, and the Medtronics team is more on adaptive therapies. They're all in stages of proving themselves. We don't have as much regulation here, but it's great that you're starting off next month as soon as the advent into the country is. But it should be compared because in all the early data, there are still developing specific use case indications for the adaptive versus conventional programming or versus image-guided programming.
In fact, they are already using it in Japan and Europe. So
Yes.
we are just waiting there here.
Yeah.
Next month, I think.
All right.
So just an observation on your first comment. So even if you do an awake surgery, it doesn't take more than 3.5 hours, skin to skin with intraoperative MRI, battery placement. So, and my point, which I wanted to put across, was for the younger generation who are starting up. They should start with an awake, the set protocol.
Agree.
But the point is well noted. Yeah.
Thank you, sir. I request the moderators to felicitate Dr. Anirban with a memento. I now invite Dr. Nishant Sadashiva, professor from NIMHANS, Bangalore, for the next presentation. As that is being, while that is being set up, we would like to announce the winners for the posters. I invite Dr. Sudarshan.
So for Group A, the poster winner was Dr. Sharansh Kumar. Can you come forward? Dr. Sharansh Kumar. So he'll be receiving a prize, a book from Dr. Anil Nanda. It's a signed copy of the books. One is on complications. Yes.
Transient cortical blindness following diagnostic cerebral angiogram. My topic, my title was transient cortical blindness following diagnostic cerebral angiogram.
Thank you. So in Group B, the winner was Dr. Deboria Paul. Are you around? Dr. Deboria Paul. Which institute?
Center in the Institute of Medical Sciences, Nagpur.
My topic was hemorrhagic neuroenteric cyst at CV junction.
First prize, Group A. And yes, sir. So there are two complimentary prizes. One, Jagdish Gangapatnam. He presented in Group A.
I'm from Narayana Hrudayala, Bangalore, sir. The topic was this extracranial metastasis of intracranial angioma.
Check, check. We will now resume with the presentation by Dr. Nishant Sadashiva. The topic is GKRS and cavernous sinus hemangiomas.
Thanks for the invite to the organizers and on this auspicious occasion to serve the title of my presentation. Serve the title of the day, the consensus and controversies. I think many of you might still think that there is some controversy regarding treatment of cavernous hemangioma through gamma knife. I think at the end of my presentation, if I convince you people that there is no controversy at all, and if there is consensus regarding treatment, I think that would serve my the purpose of my presentation. There are no conflicts. As we all know, cavernous sinus is considered to be anatomical jewel box. So it was earlier considered as a no man's land since surgeons dared very less to venture into that part. It was located in the deep location proximal to the ICA. Visual pathways were close, and pituitary gland was very close, and there was a sense of fear that it may cause exsanguination as well as cause damage. But cavernous sinus hemangiomas, they constitute around 33% of all cavernous sinus tumors. They are extraaxial. Microsurgical removal, if it is possible safely, it's curative. Today, most centers use gamma knife for this treatment. And why do we use gamma knife and why don't we operate cavernous sinus hemangiomas in the present day? So this is left cavernous sinus hemangioma, which was treated by gamma knife. Patient had presented with ptosis with the extraocular movement paralysis. So patient at the follow-up of 1 year, she had complete improvement of symptoms and the tumor was almost completely gone. So is it consistently reproducible? And what if there is an optic nerve compression or optic chasm compression? So some cavernous sinus hemangiomas compress optic nerve, and that has been told as it is an indication of surgery. So this is a patient who had compression of optic chasm. So during gamma knife radiosurgery, we undercovered the tumor. So we didn't completely cover the tumor. We undercovered the tumor so that part of the tumor near the optic nerve was not covered at all. But still, the patient had fantastic improvement. Our patients, all the symptoms were reversed, and patient was completely tumor-free in around 2 to 3 years. This is the follow-up scans of the same patient, which tumor almost disappeared at the end of 2 years and 2.5 years. So the same is reproducible in smaller tumors. This patient is a young female. At 5 years, there is almost complete disappearance of even the enhancement of the cavernous sinus itself is not seen. So this is another small tumor, a young female. At around 6 years, there is no enhancement at all. So it's not reproducible in all tumors. Some, they may have residual small enhancement, but at the end of 4 to 5 years, almost all tumors completely disappear. This is a large tumor. This is the end of 1 year follow-up. It's almost completely gone. This is another tumor, which is 7 months. There is gross disappearance of tumor. This is a medium-sized tumor. At the end of 2 years, it's almost reduced to 20%. This is the same with another tumor. So what about tumors which are larger? So even though tumors are larger, some people tend to venture to surgery, but we have several referrals where people have ventured to surgery and has caused major severe bleeding. The tumors decompression have been stopped and then referred for surgery, which have been effectively treated with gamma knife radiosurgery. What about larger tumors? There is in the present generation there is a option of fractionated radiosurgery. We can treat all these tumors with fractionated radiosurgery with safe dose limits of optic chasm. So this is another patient who received fractionated radiosurgery with gross decrease in tumor in around 3 years of follow-up. The same with another tumor, which there is gross decrease in tumor in 2 years follow-up. So it becomes important to find out what is cavernous sinus hemangioma, and we are not mistaking it for any other tumor. So usually it is very specific. The imaging findings, they are T1 hypo, T2 hyper. They have intense post-contrast enhancement. Sometimes they may not enhance. I will tell you about that later. But there are other imaging modalities which can help in that. See, in this case, there is no complete or gross enhancement. There are internal non-enhancing areas. It has good outcome. This is another patient who has internal non-enhancing area, but we knew that it is hemangioma. Patient had a good outcome. So many people might think that it's a trigeminal schwannoma also. So these are patients who don't have a complete or homogeneous enhancement is not there. So we have to do a delayed contrast study for such patients. So after we can repeat an imaging after 30 minutes to 1 hour. So the contrast uptake is much more compared to trigeminal schwannomas or any other tumors. This differential enhancement is very specific for cavernous sinus hemangioma. So we published our own treatment, and we have treated around 33 patients. In this graph, you can see almost all patients had a uniform response of decrease in tumor size over time. Most of the tumors had completely disappeared around 3 to 4 years. This is at our median follow-up was around 41 months, and median prescribed dose was around 13.5 gray. So if you see how much percentage reduction happens, in 6 months, 64% of the tumor would have been reduced. And at the end of 2 years, 82% reduction. At the end of more than 5 years, almost 100% of the patients had reduction in size of the tumors. So safety profile, 0% or no patient had radiation-induced damage because we have stuck to the dose limits of the optic chasm as well. So what about clinical response? Headache, 90% of the patient had complete disappearance of headache. Doses improved completely in 81%. This is what I'm talking about, complete improvement. So even if residual small ptosis is there, we have taken it as non-complete improvement. So visual acuity, almost every 3 patients had decline in visual acuity. That all 3 patients had improvement in visual acuity. So cranial recovery is also almost more than 80%. So this has been reproduced in almost all of the studies. They have shown that tumor reduction happens in almost 90% of the patients. And percentage response, like almost 97% of tumor reduction happens within 3 years of treatment. So recently there was a ISRS guidelines in which our study was also taken into account to do a consensus statement and come with guidelines. I don't know, even the strength of recommendation is conditional and overall quality of evidence is low. If this evidence of telling that a patient completely improves and tumor completely disappears is a strong level of evidence, I'm not sure whether a randomized controlled study is even indicated in such cases. So pooled analysis, if you compare with surgery, I have assisted surgeries of all sizes and shapes of cavernous sinus hemangioma. It's messy and bloody surgery. All of us know that. Even I have operated a few cases. To control bleeding, if you put a suction, we don't know we are sucking on the blood or on one of the nerves, especially if you are inside the cavernous sinus. So it's very important to know that there is almost 2/3 of the patients have cranial nerve morbidity when you operate on cavernous sinus hemangioma. So it's a pooled patient literature analysis, compared to which radiosurgery has 0.7% complication rate. That too, what are the complications? Headaches. Most common complication was headache. Transient dizziness is taken as a complication. That complication is 0.7%. compared to surgery alone, patient had like radiosurgery had 100% odds of decrease in developing complications. And if you control the patient's age, tumor volume, and length of follow-up, odds of improvement in symptoms was 5 times higher in radiosurgery compared to surgery. So there is no comparison in this case. So percentage of response, like it's almost 100% in majority of the literature reported. So what about very large cavernous sinus? So in the present day and age, like we have a thing called a fractionated gamma knife or staged gamma knife. You can give a lower dose. For example, you can give 8 gray within the limits of acceptable dosage, and then repeat gamma knife after 3 months or 2 months. And in this case, Dr. Manjul Tripathi has done 1 dose of gamma knife every month. At the end of 3 months, you can almost see that it is reduced to almost 10% of what it was. So this pathology is not a candidate for surgery at all, if you ask me. So it is clear and present danger that patient can have intraoperative exsanguination in such huge patients. And inaccurate preoperative diagnosis is very common. Like most of the inaccurate diagnosis is thinking that it's a trigeminal schwannoma or something else. So significant hemorrhages can happen in 15%, and deaths have been reported up to 2.3%. So it is very important to distinguish that from other pathologies like meningiomas in this case. As you can see, the response is not the same like cavernous sinus hemangioma. It is not reduced in size at all. Meningiomas as such, the treatment response to gamma knife is not so drastic like cavernous sinus hemangioma. This is another patient who had a follow-up of 2 years, 3 years. With the size, although reduced, it's not disappeared. So this is another example of patient with a schwannoma. Schwannoma, like initially they, for example, they have internal non-enhancement, and then there is a mild reduction in tumor, though tumors may not completely disappear, unlike cavernous sinus hemangiomas. So it is important to distinguish between hemangiomas, meningiomas, and trigeminal schwannomas while treating, or especially when patient, we are treating all this with the imaging evidence. So it has to be critically looked at before we diagnose a case. So cavernous sinus hemangiomas, as I already told you, they are T1 hypo, T2 hyper, and usually do not cause luminal narrowing of ICA. Luminal narrowing of ICA is very common in meningiomas as well as in schwannomas. So these are 3 different responses which we can expect. Hemangiomas completely disappear, meningiomas stay the same, schwannomas may decrease in size over time. So these, if you compare these 3 pathologies, so there is clear differentiation of how they respond to gamma knife. So in conclusion, though people may confuse between these pathologies, the outcomes are very different, especially when we do gamma knife. And we have to be very careful in assessing the diagnosis before considering for radiosurgery. So you can at least tell the patient that, okay, your symptoms may completely disappear or tumor may completely go if you effectively know that this is a cavernous sinus hemangioma. So I hope I have convinced all of you that there is hardly any confusion or controversy regarding the topic, and the consensus should be we should take up to radiosurgery if we find a cavernous sinus hemangioma. Thank you.
Excellent talk, Dr. Nishant, and I agree. I have also seen. So, as per you, is there any specific category of cavernous hemangioma where you would still go in for surgery?
If it fails, which I have never seen one.
Okay. Sir.
Nishant, excellent paper, because I've always been sort of intimidated by going into these. I've had a lot of bleeding. And I think All India Institute, one of your colleagues, has written a series of these. Suri or
Ashish Suri.
Yeah, Suri. Yeah. And I'm like, buddy, this is like not the same disease. You know what I mean? And I've had just a lot of bleeding. So I'm very intimidated by going into these. And I think you proved to me that the only treatment, the only viable treatment that I would do for my family is radiosurgery. I think it's just like jugular for, jugular tumor. Everybody was like, oh, you got to take out jugular tumor. Nobody takes out jugular tumor. They're now radiosurgery. But congratulations. Great.
Thank you.
Great results at NIMHANS. I'm just curious to know, so before gamma knife, when they were doing surgery, do you have a comparison where they were using either surgery alone or post-embolization surgery with your
We never embolized cavernous.
And in the NIMHANS experience, what have been the biggest factors to predict response to the gamma knife? Is it the pre-surgical size, pre-SRS size, or involvement and limitation of the amount of radiation?
So if there is a difference of non-responders and responders, you can actually compare it. Uniformly, everybody has it. So
irrespective of
the
size
most
and
important factor is your diagnosis, correct? If it is cavernous sinus hemangioma, it has responded. So like radiologically, like if you go through the record, like some cases have been written as cavernous sinus hemangioma.
Right.
We have gone back and discussed with radiologists. It was not cavernous sinus hemangioma. So those have not responded. So that's why I wanted to prove a point that like do a diagnosis. Diagnosing it before not only helps you decide what is the best option, but you can counsel the patient that this patient, like this tumor will completely go, or this patient may stay and you might need a longer follow-up. For example, schwannomas, you need a longer follow-up. Hemangiomas, once it disappears in 2.5 to 3 years, like you tell that you're cured, you can go back home.
Okay.
Though I had to take up one patient for surgery, which was scheduled for gamma knife, but on the day of gamma knife, we realized that the volume had grown significantly and there was significant edema and mass effect, which is unusual in cavernous hemangioma. When we operated, it did come out to be cavernous hemangioma. So that was only one patient where I found cavernous hemangioma associated with edema and midline shift. So I had to go in and operate.
So
But I
midline
agree.
shift, raised ICP. Anyway, any day it's a case for
Just
surgery.
one quick question. Sir, I saw very large lesions which you had shown, and you even choose 2 ISO centers to give gamma knife. Would you consider radiation therapy as an option for any of them, sir? Like
If
SRT?
it can be safely given, no radiosurgery modality should be differentiated. You should go ahead and give radiosurgery.
So in even such large lesions, gamma knife may be more effective than SRT. So that's
I don't have data, but it should not be different.
But gamma knife is not single session he's talking of. In large lesions, we are also fractionating like as you would do in
Hypofraction.
SRT. So he's talking
Staged
of 5
or
fractions.
hypofraction.
Yeah.
Staged or hypofractionated. You have to decide based on the patient symptoms.
the biggest problem there is when the radiation oncologists come and they may insist on typical findings of a cavernous hemangioma in the imaging.
So you have to convince them.
That's right.
It's your duty.
Thank you, sir.
Thank you.
Sir, just one second, sir. I request the moderators to hand a memento to Dr. Nishant Sathashiva for a very, very nice talk. One of the talks from the skull-based seminar, which had to be postponed because of lunch, is now going to be held. It's now my pleasure to invite Dr. Prakash Nair, professor from Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, to deliver this talk. A talk on future of skull-based tumor surgery, whether it is minimally invasive.
Very good afternoon to all of you. Thank you so much for inviting me to Satyasai for this program. Very nice set of talks so far, and been a great learning experience. So the question that Sanjay asked me to talk about, which is whether the future is entirely minimally invasive, seems to be a little unfair. But I will try to use the next 20 minutes to put this across like a story of how the transsphenoidal route has almost become the default route for management of pituitary adenomas, but is not the only option available, and where large tumors, especially ones with certain special characteristics, might need a transcranial approach. So it's all about how you wish to skin the cat. And I hope that I'll be able to cover a lot of that in the next 20 minutes. So the story starts about how this procedure developed and evolved and how it transformed to what we practice it to be like. What is the evidence that really supports what we do, and what it can and cannot achieve? And at the end, when can we opt for another approach or another modality to manage the same tumor? The history is very old and very distinguished. So it started in 1905 probably with a transcranial transfrontal approach. However, in 1907, Schofler first performed the transsphenoidal approach, which is not the conventional approach that we know of today, but in 3 separate stages, 2 of which were just to access the tumor. The diagrams probably show you why they were so inclined to approach it from the transsphenoidal route. It seemed so much more intuitive to come to it from the nasal cavity where there were no obstructing neural tissue, rather than come to it from the cranial cavity where there were multiple cranial substrates that could be damaged. However, the transsphenoidal route then developed through the efforts of many stalwarts. Finally, in 1914, Cushing probably brought the technique together when he brought about the anatomical basis for the rhinoseptal approach, made it much safer for access, and then continued to give it a great deal of popularity for the next 20 years. So when he, in 1929, had completed about 230 procedures, he had a very low mortality rate of about 5%. However, because he started to find that there were increasing number of infective morbidities and that he could not at that point of time distinguish Rathke's tumors or craniopharyngiomas from pituitary tumors, he then moved on to doing the transcranial approach. With Cushing kind of abandoning his own baby, in North America, pituitary tumors fell out of favor for the transphenoidal approach. However, Norman Dott, who was a student of Cushing's, probably kept it alive and passed it on to Gerard Guyot, who continued to keep the technique alive in Europe and passed it on to Jules Hardy, who then moved back to Montreal and also began using the microscope for operating on pituitary tumors. He was probably the first person to selectively perform adenomectomy resections for functioning pituitary tumors. And the modern era of microscopic pituitary surgery came to fore with all this. In the meantime, there was also this new kid on the block. This was the endoscope and the rod lens technology, which was able to transmit a lot of the light without causing significant amount of heat in the tube, had slowly come into fore. The endoscopic intranasal approach, however, was not popular instantaneously. This was because of extremely poor image quality and limited amount of HD technology that was available at that point of time. However, it was not without people having used it. And over a period of time, the endoscope slowly became more important for either the microscopic assisted approach, where the endoscope would be used to check the surgical cavity, or to initially do the nasal approach itself. But probably in 1998, when Joe and Karau first published their first 50 cases, this endoscopic approach started to slowly supplant the microscopic transphenoidal approach. So what is the evidence that we have to date to support the fact that the endoscopic approach is either equivalent or maybe even better than the microscopic approach? The first meta-analysis of the 8 published studies done so far in 2006 by Tubby et al. Analyzed very short-term outcomes of the endoscopic transphenoidal approach. And he concluded that in the short period of time that they had for analysis of literature, the efficacy of endoscopic skull-base surgery for pituitary tumors was definitely equivalent to the microscopic technique. So the endoscopic approach gives us certain definitive advantages. One being the fact that you have a very wide lateral corridor that is available when you complete the endoscopic approach. You get a very wide view of the lateral skull base also when we complete the endoscopic approach. However, the field is, you get a 2D approach to the field, and surgeons compensate for it by the to and fro motion of the endoscope itself. It has a learning curve, and many centers where endoscopic skull base surgery is popular has developed because of this marriage between an ENT and a neurosurgery team, which has come together. One of the many advantages of this wide view was that a new anatomical appreciation of the sphenoid sinus itself, with the carotid impressions and the middle opticocarotid recess and the lateral opticocarotid recess, came to view. But at that point of time, the question really was that, visualization is better, but how is this changing the clinical perspective, and how are the clinical results changing? Now, one of the things that we know about is that a transcranial approach transgresses a significant amount of pituitary tissue. So a transnasal approach gives us a very nice view of the pituitary tumor and also allows us to perform certain very niche approaches like the pseudocapsular resection. where the pseudocapsule can be slowly identified and the pituitary tumor itself can be shelled out while preserving the integrity of the pituitary gland as such. Now, when we look at the histopathology after surgical resection, we notice the presence of a pseudocapsule, which is a reticulin containing capsule composed of normal gland that prevents pituitary tumors from infiltrating into the pituitary gland itself. And when we achieve pseudocapsular resection of a pituitary adenoma, the remission rates for microadenomas tend to be in the range of 90 to 95%. So this is a case of a Cushing's disease, where one can appreciate how this plane can be gradually developed, the normal gland be normally separated away, and this small adenoma removed in toto. This is a perspective that was very difficult to approach if we had a transcranial approach. You can see that the entire gland has been preserved and the adenoma has been selectively shelled out from the tumor with good remission and a long follow-up period. So when we compare the more recent literature, comparing microscopic versus the endoscopic approach, we can see that for non-functioning pituitary tumors and for functioning tumors, the endoscopic technique had a higher incidence of postoperative gross total resection. This is both for large and for small tumors. For functioning pituitary tumors, there were higher rates of visual improvement and lower rates of postoperative meningitis. So these are probably results of a comparison where the endoscopic approach has now matured over a period of 20 years from 1998 to 2018. What are the factors that then contribute to subtotal resection in a patient who's undergoing surgery for a pituitary tumor? The transfer study was an attempt to look at the morphological features that might predispose a patient to having a subtotal resection. So the tumor diameter and the tumor volume, a tumor size of more than 4 centimeters, a large tumor volume, a Knopf's grade of 3 or 4, a tumor waist ratio where you have a very narrow waist at the level of the sella, clival invasion, and this nodular shape of the tumor with nodules extending either into the frontal lobe or the temporal lobe or into the ventricle were all considered to be factors that would predispose to a subtotal resection. This brings us to this very important classification made by Engelbert Knoss, looking at how much of the cavernous sinus is invaded by the pituitary tumor. And this modified cavernous sinus invasion that can be used to predict the extent of resection. Now, why is it important? Does it have any surgical implications? Surgically, when we look at it, as your grade goes on increasing, the percentage of gross total resection goes on decreasing. So for patients who have Knopf's 4 involvement of the cavernous sinus, we very rarely get a gross total resection of the tumor itself. So what is the role of endoscopic surgery in this whole game? So when we look at how tumors were observed endoscopically and invasiveness observed microscopically, we're able to notice that a much higher percentage of tumors could be visualized and could be appreciated to have cavernous sinus invasion when they were looked at from the endoscopic aspect. This brings us to certain new modalities that are now available to access the cavernous sinus itself. So in 2016, we had these publications from Pittsburgh where they looked at the medial cavernous sinus wall anatomy and the anatomy of the pituitary ligaments that anchor the cavernous sinus, the pituitary gland to the internal carotid artery. So this is an example of how the medial cavernous sinus wall might be invaded in a patient who has a functioning pituitary tumor here. The technique of resection involves very wide exposure of the cavernous sinus on the side of suspected involvement. The initial dural opening is done in pretty much the same way that you would do for any tumor, and the tumor is resected first, and then the anterior wall of the cavernous sinus is opened. When the anterior wall of the cavernous sinus is opened, we get some venous bleeding, which can be blocked using injectable flow matrices. And then we encounter these ligaments, which are paracellular ligaments. We go on to the space superior to the keratico-clinoidal ligament, which is called the dorsal clinoidal space. And then we start to slowly separate the attachment of the CCL from the ICA itself. And this can be removed till we reach the posterior clinoid. So when we do this, the entire medial cavernous sinus wall can be removed in one piece. Now, this is not just a technical exercise because, after resection, you see the entire cavernous sinus, the interclinoidal ligament, and the vertical segment of the ICA. But this is not just a technical exercise because when we look at the cavernous sinus histology after surgery, we start to see that the fibrocollagenous tissue of the cavernous sinus now contains tumor. And we all know that pituitary tumors have a definite incidence of recurrence, both functional and anatomical, at the end of 5 years. So it is probably likely that these are rests of tumor in the cavernous sinus that predispose to recurrence of tumor after surgical resection. So we looked at our outcomes of middle cavernous sinus wall resection, and for the first 25 patients that we did, we've seen that the overall remission rates are much higher. And they were definitely much better if you did the resection the first time over, when we compared them to reoperations where the remission rates are much lower. But one very interesting finding was that even in patients who had low-grade NOS involvement on MRI, we saw that the middle cavernous sinus wall was positive. So nearly 80% of patients had middle cavernous sinus wall positivity. And direct endoscopic inspection had a much higher sensitivity and specificity for detecting the involvement of the middle cavernous sinus. This brings us to how we can understand the anatomy of the cavernous sinus from the endoscopic perspective. So, as we were discussing earlier, the cavernous sinus can be divided into the middle and the lateral compartment based upon the internal carotid artery, especially the horizontal segment. And there are segments of the cavernous sinus, especially the anterior inferior segment, which do not contain any cranial nerve. So they are very safe to access. The superior compartment contains the third nerve and the posterior compartment contains the sixth nerve. And they all meet laterally. And the lateral compartment contains the third, the fourth, and the sixth nerve. So now we can tailor our resection to make it much more selective and decide how we want to approach the cavernous sinus. So for example, this is a very large pituitary tumor with extension into the lateral compartment of the cavernous sinus. And once we have exposed the cavernous sinus very laterally, done a transpterygoid approach, seen the foramen rotundum and seen V2, we get much more access into the lateral compartment of the cavernous sinus. So this gives us an opportunity to first resect the cavernous sinus, identify the internal carotid artery, and because we have a very soft tumor inside, we can slowly decompress this tumor. Now, when we come to this point where the sella has been decompressed, we can then turn our attention into the cavernous sinus lateral compartment. Here, using the help of neuromonitoring also, we can slowly identify the inferior hypophyseal artery and coagulate it. This lets us move from the anterior inferior compartment to the superior compartment of the cavernous sinus, where we have the third nerve. And while I do not do this for all tumors in the lateral compartment, we do approach the lateral compartment selectively, especially in functioning tumors. So this is the inferior lateral trunk, which is arising on the lateral wall of the ICA and going towards the lateral compartment. And here we come towards the superior compartment of the cavernous sinus, above the horizontal segment of the ICA, till we see a part of the tumor that extends from the oculomotor triangle into the suprasellar system. So there is a method to the madness. Using a very systematic approach where we access each compartment of the cavernous sinus separately, we can get a much wider resection than we could do with a classical microscopic approach. So this is the postoperative image with a small amount of tumor, the lateral compartment of the cavernous sinus. And you will all agree that if we did decide to treat this with radiosurgery, this would be a much better target compared to a much larger residue in the cavernous sinus. So when we look at the outcomes of cavernous sinus invasion with pituitary tumors, this is a study that Dandapani et al. Had done when Dr. Dandapani was in Cornell. It showed that there was a significantly higher rate of cavernous sinus resection for tumors that were tackled with the endoscopic endonasal route. And while you had rates of recurrent residual tumor following both microscopic and endoscopic resection, with higher grades, the extent of DTR was much better when you did the endoscopic approach. So what about tumors that extend into the ventricle? And what about tumors that are very large? So when we looked at our own data of using multiple corridors, the transtubercular, the transplanum, the transclival, or the transpterygoid corridor, we saw that by using multiple corridors, we were able to increase the extent of resection. And use of multiple corridors definitely helped us in getting a wider resection compared to a single transsphenoidal corridor, with better improvement of vision and a CSF leak rate, which was less than 2%. So cavernous sinus invasion was definitely one of the predictors of subtotal resection, with higher grades predisposing to lower limits of gross total resection. So in our own we were able to find that tumor volume of more than 10 centimeters, cavernous sinus resection, or adjacent involvement of structures like the brain parenchyma was a limiting factor. Now, giant tumors, like we all have seen now, seem to be one of those factors that require something else, something more than a transnasal approach. So Dr. Goel has this classification of the tumor going into the cavernous sinus and raising the superior wall of the roof, or our own work with tumor extension in the interventricular space. But importantly, there are compartments of tumor extending into suprasellar cistern like this into the oculomotor triangle that can also be accessed using the endonasal approach. So this is a work which Dr. Sanjay was also a part of, where tumor extending into the parapeduncular space next to the third nerve could be accessed using a transcavernous approach, extending along the roof of the cavernous sinus to tackle this component of tumor that was related to the third nerve as the third nerve was going into the cavernous sinus. So this is an example of how the endoscopic endonasal approach can be expanded to reach corridors that were probably difficult to reach earlier. Having said this, there are, or there might be, or there definitely are, boundaries that cannot be reached with suprasellar dissection. The optic nerve, tumor that extends lateral to the internal carotid artery, tumors that extend into the interpeduncular cistern and engulf the basilar artery, or tumor that extends into the sylvian fissure are beyond the reach of the endoscopic approach. Why does this happen? What are the technical difficulties that we encounter when we want to reach these points? The tumor is definitely beyond your endonasal corridor. So you are left with, extending your suction and trying to get those bits of tumor into the surgical field. It is very difficult to get hemostasis when you have a distant residual fragment. There is often bleeding from the brain parenchyma, and that is also very difficult to control when you have these lateral fragments. And of course, in cases of inadvertent venous or arterial injury, those bits of tumor and that part of bleeding is very far away from access. So there are options that we have, like the open approach or a staged approach that can be used to access this part. So when Buchfelder looked at his own rates of resection of large adenomas, he saw that less than 10% of large adenomas required transcranial resection. The majority of them had a very dominant extracellular component with a very small component in the cella, or these eccentric extensions into the middle and the posterior fossa, or a coexistent tumor involving an IC aneurysm or a MC aneurysm. So these are tumors that will require a transcranial resection, but there are limitations of how the transcranial resection can extend into the cella itself. So you might have to stage approaches by going for the transcranial corridor first and then taking the transnasal tumor out later. So how is this debate different? So coming back to the original part, the endoscopic and the transcranial approaches are not mutually interchangeable approaches. They have to be deployed differently for different indications. And while the extent and the indications have expanded over a period of time, the comparison between a tumor like this and a tumor like this is definitely not equal. So when we look at historical references, obviously, they may not be very easy to match. But when we look at contemporary data between 2017 and 2025, we see that when we look at visual recovery for a large set of pooled patients, the visual improvement following transcranial resection is better. And they're particularly effective in decompressing the inferior or the central part of the tumor, whereas the transcranial approach has a significant amount of advantage for tumors that have lateral extensions. And when we look at complications, the extended approach definitely has a much higher complication of CSF leaks. So if we were to encapsulate the indications of a transcranial approach, it would be a lateral extension or extension to the fissure or involvement of microsurgical microvasculature. And one important indication that I think is important from our side is when we do not have reconstructive options. So is the future minimally invasive? The endoscopic endonasal approach has a definitely better outcome compared to transcranial approach in terms of GTR and endoscopic remission, but this is only for well-selected cases. The transcranial approach will be needed for management of lateral extensions or when you have coexisting other pathologies there. And occasionally, when you have tumors that bleed and come to us in the ER, they're very difficult to manage by the endoscopic route. So we are probably still standing on this side of the sea with lots of people who have walked past and have left their footprints in the sands of history. But we still, I think, are looking forward into a sea that is still uncharted. And there are probably many more goals that we have to reach to make the overall outcomes of these complex tumors both successful and safe. Thank you.
Excellent talk, Dr. Prakash. I had one question. You've covered everything, and I completely agree with what you've said. I have one question is, if you have a patient with cellular and supracellular and lateral extension, and you want to do, and you think that you will not be able to excise it completely endonasally, and you know the patient will require transcranial, how do you plan it? You go in transcranial first? You want to go in endonasal and then go in transcranial
So if you
same
have
day?
a very large component in the sylvian cistern, which is lateral, and you feel that you will not be able to access it with a midline route, I would definitely do a transcranial first.
So you wouldn't attempt endonasal partial excision and then go in
No, because
transcranial?
for large components, so for small components, small bleed might still be easy to manage, but large bleeds like this can be very difficult to manage in the post-operative period because the brain swells. Sometimes,
No, I mean to say do both, but
So see, we've also tried doing simultaneous approaches. I personally don't think that simultaneous approaches are very useful because the managing the entire OR with two teams and managing both the nasal part and the cranial part has been a little cumbersome. So I would always stage the approach. For a large lateral component like the one that I'd shown earlier, I would prefer a transcranial approach first, and then depending upon the extent of the residue, a second approach. But sometimes, when you have a small cellular residue which is not symptomatic, you can even follow that up. But if you have a very small nubbin, say a nubbin that is just projecting into the parapeduncular space, you can do an nasal approach first. But if you have a very large chunk laterally, I think in most cases they will bleed, and you will have to come back for them at some point of time.
yeah, so what I was hinting at was this endonasal and then go electively and go in transcranial for the rest. You would go in for
Transcranial, and then endonasal only if
Fair
indicated.
Right. Dr. Nanda?
Great paper, Prakash. Really enjoyed it. I'm an old timer. We used to do transphenyl by ourselves with our ENT, and I think my fastest one was like 14 minutes. We just went in, cracked the vessel, got in out. The problem is ENT, when they do these mucosal flaps, they treat it like they're clipping a basilar tip aneurysm. Like every blood vessel, they're like, oh my God, you can't take this. So the length of the operation has increased. Sometimes that morbidity is not addressed. If you're 80 years old and I can do a procedure in 20 minutes versus 2 hours, it's a close thing. The second comment I had one of Nelson Ezekiel's fellows come as my fellow in Skull Base, and he helped me see how they did it in Emory. It was very interesting. They went the way you like to get the whole capsule out. And I was like, whether you eat this way or that way, you fragmented. I didn't think there was much advantage, but it looked technically much prettier. You're like, oh my God, you're getting this out and that. So I think there's a lot more nuances to it. I congratulate you for going into the cavernous sinus because that's a skill set that some of us will never have, especially from the older school. But I think this is great. You liked your picture where you removed it off the third nerve.
Completely agree with your first point, which is that so I do most of my procedures without an ENT surgeon, and in 90% of the pituitaries, you don't need a flap. So we manage the cellular approach with a simple fat repair, and we can do the entire procedure without removing the middle turbinate, and by doing a small posterior septectomy. So in those cases, the nasal outcomes are much better compared to patients who require transmaxillary approaches, which will be only about 10 to 15% of your case volume. Using the pseudocapsule is very useful for functioning tumors. Now, there are two aspects to the pseudocapsule. One is when you want to do all tumors using the pseudocapsule and want to shell it out completely. It gives a very nice video, but it may not be practical. But even if you cannot manage the pseudocapsule in toto, the idea of identifying the capsule is a great way of peeling this last bit of tumor out from the gland itself. So what happens is, even if I have not been able to take it out en bloc, I'll still spend some time peeling those small fragments away from the gland. And I personally feel that, it gives me a better chance of getting remission compared to leaving fragments there.
I also think the ENT surgeons have been very good at dropping the guilt bomb on neurosurgeons by saying, if you look at all the meta-analysis, it's all in the ENT journals. It's not in the neurosurgical journals. So they want you to think they're indispensable for this. And sometimes we beg to differ.
Thank you for that. Thank you, Dr. Nair. That was excellent. In the interest of time, we'll move on to the.
Request the moderators to hand a memento to Dr. Prakash Nair. Round of applause, please. I have a small announcement. Dr. Anand Akash has won the consolation prize for the posters, and we would request Dr. Anil Nanda to hand a small book to Dr. Anand Akash. Is Dr. Anand Akash around? Congratulations. We now move to the last talk of this session. It will be delivered by Dr. Vishwanathan K. Sir is an alumnus of Sri Sathya Sai Institute of Higher Medical Sciences and also the professor and HOD from Sri Ramchandra Medical College, Chennai. Sir will be talking about how to deal with spasticity.
Good afternoon, everybody. Om Sri Sai Ram, and it's always a pleasure to be back at my alma mater. Thanks to Dr. Sarita and Sumit for giving me this opportunity. Spasticity is an important subject as far as a functional neurosurgeon is concerned. In this talk, we'll deal with what is spasticity, why it should be treated, what are the treatment options, and discuss in greater detail about selective dorsal rhizotomy and intrathecal baclofen pump therapy rather than the other approaches. Spasticity is a word that's drawn from the Greek word spastikos, which means to draw or to tug. It's the velocity-dependent increase in the tonic stretch reflexes, which manifest as positive signs. That's the one that we notice as exaggerated deep tendon reflexes and the resistance to passive stretch, and negative signs like weakness and loss of dexterity. We've all learned from our first MBBS physiology that there is an imbalance between the descending inhibition and the sensory excitation, and the Golgi tendon organ and the muscle spindle and its role in modulating the alpha motor neuron activity is something that we understand. But what we don't understand is there is something called the spastic movement disorder. The clinical signs of spasticity that we as clinicians see are little related to this movement disorder, which hampers the patient and is the one that they are coming to you for treatment. No animal models exist for human spasticity, which is caused by multifactorial causes, and exaggerated DTRs are only a small factor of the patient's problem. Most studies focus on one sign, and the tone which we are interested in reducing may be the only one that's keeping the patient ambulant. And the human spasticity doesn't occur immediately, but follows a few weeks after the insult. We assess spasticity with the modified Ashworth grading from grade 0, which means no increase in tone, to 4, which means the affected part is in rigid flexion or extension. A much more holistic way is the GMFCS scale, 1 to 5, typically assessed in children with cerebral palsy. And the management approaches range from non-operative treatments like physical therapy, wheelchair positioning, occupational therapy, to oral medications that we commonly give like baclofen, tizanidine, etc., Botox injections, other interventional procedures like neurolysis using alcohol, and selective peripheral neurectomy, which is another neurosurgical option, which I am not dealing with in this talk. Orthopedic procedures also form a good part of the armamentarium, but they should usually follow the reduction in the tone and not before. Coming to the first major part of this talk, which is selective dorsal rhizotomy. It's a surgical procedure where the dorsal, that is the sensory rootlets, are severed to facilitate patient care and mobility. I do it with a limited laminotomy using neuromonitoring to aid, and muscle relaxants are not used. It's done in the prone position, ideally with the Trendelenburg position to minimize the CSF loss, needle electrodes in most major muscle groups in the legs. And care during positioning is important because the patients can have rigid flexion or extension, and improper positioning can cause fractures. This is the laminotomy. You generally, with the preoperative MRI, find out where the spinal cord terminates. and plan your limited laminotomy accordingly. The durotomy is standard. You identify the L2 roots, trace it back to the cord, and find the ventral and the dorsal rootlets and the space in between. And thereafter, after studying each dorsal root individually, we begin sectioning. How do we study? We see the response to the EMG, and the pathological response of grade 3 or 4 are the ones that are chosen to be cut. Sorry, there's some technical issue with the video. So this video also would have demonstrated the same, individually assessing each rootlet and going ahead and studying each one. And here you can see on the top, the normal response. So that selected rootlet is not cut, and the bottom one showing the pathological response, which identifies that rootlet to be cut. What is the evidence for whatever we are doing? For selective dorsal rhizotomy, there's evidence going for many decades, and it has been demonstrated to be effective in treating children with CP, and long-term evidence is also available. Both modified Ashworth and GMFCS reduction has been noted. However, there is also this paper that has come out that has looked at SDR versus other alternative availabilities. Yes, selective dorsal rhizotomy does reduce the muscle tone better than the alternative approaches, but in terms of assessing the gait, they found that in the other treatment options, the improvement in gait was slightly better. However, in the SDR group, it was just this intervention with continuing with physical therapy, occupational therapy, versus the other group had multiple other interventions, which could mean Botox, which could mean tendon lengthening, shortening procedures, so that the number of interventions increased. So the take-home message is that SDR is an important option, but it's not a one-size-fits-all. It depends on where you're working, what your milieu is, and it's guided by the patient's discussion that you have with the patient and the caregivers. Now, moving on to intrathecal baclofen therapy. What we see here is the pump that's implanted in the abdomen there, and a catheter that goes into the patient's thecal space. The baclofen gets in there and through capillary absorption goes directly into its intended area of work, that's in the spinal cord. Why intrathecal? We have oral baclofen. Why not give oral baclofen? By giving it intrathecally, the drug starts working at its site of action, whereas it needs to get through the blood-brain barrier when we give it orally. And so, because of that, some patients may experience unacceptable side effects. Now, the mathematics is extremely clear. Oral, when we give a 60 milligram dose, it translates into a 0.024 microgram per ml of intrathecal concentration. Whereas about a 100th lower dose translates into a 50 times more concentration in the lumbar space. It does, once you give it intrathecally in the lumbar system, it does go into the cervical space as well. When you give it bolus, it starts acting about 1 hour later, but continuous infusion is what the ITB pump gives. Effects are seen starting around 6 to 8 hours, and maximum effect is observed 24 to 48 hours later. The advantages are that it's reversible. Once we section the dorsal root, and we section thinking it's the dorsal root and we section something else, then the function is lost forever. Here it is reversible. Potentially, if you have side effects, it is programmable. We can increase or decrease the dose that goes in daily, and it is effective in reducing spasticity. And Croin et al. Was responsible in 1984 85 two landmark papers that identified that continuous intrathecal baclofen for spasticity is useful. The treatment process starts with identifying the right patient, doing the screening test, implant, and maintenance. It follows that there needs to be an interdisciplinary team assessment that considers the patient as a whole. And the goal, again, is to reduce the spasticity, facilitate rehabilitation therapy, improve the function and activities of daily living, and prevent spasticity-related complications. And an important factor is to reduce the caregiver burden. Even in a non-ambulant patient, where the child is in bed, it makes immense sense that the parents are able to move the child from the chair, from the bed to the chair easily, able to clean when the private parts easily by abducting the hips. These actually help in the day-to-day life of the parents. There is very few contraindications, and except if patients have allergies or an active infection. This is how I do the screening. The screening is also, typically screening is done as a bolus, but I prefer it as a infusion. Start off with your regular IV infusion set connected to the lumbar catheter and start it at 50 micrograms, and most patients show a response, after which you can stop. If they don't, you escalate it to 75 and then to 100, and if still there is no response, then you call it quits. As we have seen, the abdominal pocket is used. And we start with a low dose and thereafter increase gradually at each outpatient setting. The side effects could be related to the drug entering higher up. If it reaches the medulla, it can lead to hypotonia, somnolence, nausea, vomiting. Overdose is rare, but we should be aware of it. Catheter and procedure-related complications can occur. Why overdose happens? We entered medicine because we were very bad in mathematics. So if we can calculate the doses in micrograms wrong, the concentration at which the drug is coming, the concentration at which we should infuse it inside, we should be careful. The pump can malfunction. The programming error can happen. There is a catheter access port that is used to interrogate if the catheter's integrity is present or not. If inadvertently we inject through that, then a huge dose of medicine gets directly into the spinal cord. So, as you can see in this is the catheter access port, whereas the port right in the center would be the one that you'll be filling the medicine in. Maintenance is an important part. Every 6 to 8 months or so is the recommendation. I usually do it about 9 months, once in 9 months, injection of the baclofen. Basically, we do it in the outpatients, remove the medicine in the pump and refill it with fresh intrathecal baclofen. This is how we do it. Identify the center. There is a pre-fill, there's a refill kit that's available that comes with a sort of the impression of this, which tells us where the center is, but we can always have a jugaad technique that we can reduce the costs. Now, what's the evidence for ITB? Again, this is not recent papers. These are all from 90s, 80s. Efficacy of the screening test, 80% efficacious in cerebral onset, 97% in spinal cord. And outcomes in spasticity from cerebral origin, excellent results in children and adults. And again, in spinal, the evidence is pretty good. And a recent trial, the SISTERS trial on intrathecal baclofen therapy in post-stroke spasticity has also shown that there is a significant reduction in the spasticity. Whatever I say, if this video does play, can we try? So before and after, this is a gentleman from Oman who would come with a post-cervical compressive myelopathy ACDF surgery that was done well, but there was a large myelomyelitic area causing spasticity, and that's him 6 months later when he came for the initial therapy. So results can be gratifying if we choose the patients right. ITB therapy works if it is spasticity and not any other cause of hypotonia. Thank you for patient listening.
Thank you, Dr. Vishwanathan. That was a great presentation of both the two commonest modalities that we use as neurosurgeons. I think the one important thing is obviously to set up MDTs, having physiotherapy support along with your team. Apart from the surgical modalities, obviously titrate the drugs early on, and positioning also is important so that it stretches out those limbs before they go into a higher GMFCS grade, and then they need the surgery. Even after, I think as far as outcomes go, it's always a good multidisciplinary team approach. But for CP, I think it's universal evidence now about the STRs provided the indications, right? So
That's an excellent point, because we had a bad experience once. We explained everything to the parents. They've been suffering with CP-related spasticity in a child. Surgery went well. 2 weeks later, 1 month later, really reduced tone. But then they stopped all the therapies, despite all our counseling. And then they come back 6 months later with the rebound spasticity. It's not just one solution, it's part of a package. Typical, just like an LP, we put it around the L3-4, L4-5 space, and then we tunnel it up. If upper limb spasticity is something that you need to target, you can thread the catheter higher. Some people use fluoroscopy to ensure that the tip is somewhere in the mid-thoracic region, at least. But I typically don't. As far as you leave a good level amount of catheter inside, that's more than enough. We should ensure that we don't thread it too high, that it's the tip of the catheter is in the lower cervical space, in which case the drug can get into the medulla. The patient can stop breathing.
Thank you, sir. Sir, just 1 minute, sir. I request the moderators to hand memento to Dr. Vishwanath. Vishwanathan. Thank you, Dr. Vishwanathan. I request Dr. Sarita to hand over mementos to the moderators. Dr. Nishchit Hegde and Dr. Shweta Kedia. Coffee and snacks have been arranged. We will be continuing concurrently with the sessions.
Our penultimate session today will focus on pediatric neurosurgery. The session will be moderated by Dr. Suchanda Bhattacharya and Dr. Ganesh K. Murthy. Dr. Suchanda is faculty at Nizam's Institute of Medical Sciences in Hyderabad, and Dr. Ganesh Murthy, who spent several years as faculty at Satyasai, is currently affiliated to Medicover Hospitals in Whitefield. We will start this session with a debate on what constitutes optimum management of pediatric craniopharyngiomas, balancing disease control with the overall quality of life and treatment-related morbidity. The debates will follow a similar pattern to what we've been following for the earlier sessions. I now call upon our first speaker, Dr. Girish Menon, a senior consultant at SP Welfare Hospital and the current editor-in-chief of Neurology India, to speak in favor of aggressive surgery for these tumors.
Chairpersons, thank you, Sarita and team Satyasai. So, Ranjit, if you are ready, we'll put on our sparring gloves. So, thus spoke Harvey Cushing in 1930s, almost 100 century ago. And you all must admit that we are no wiser 100 years hence. A difficult disease to treat, but a favorite topic provides a lot of favorite topics for debate. So around the beginning of 2020, I used to take part in debates on the same topic gross total versus subtotal for craniopharyngiomas. Then it paved way for the debate on transcranial versus endoscopic approach for craniopharyngiomas. Then we now have debate between protons versus photons. And of course, with this new revelation that adult and pediatric craniopharyngiomas with all the BRAF mutations and the WNT and the CNTTs coming, we know that adult and pediatric craniopharyngiomas are probably two different entities and we need to be discussing them exclusively. So thanks to Sarita for bringing this again into focus, much needed debate, because the premise for this discussion is that gross total resection of craniopharyngiomas, of course, it provides less risk of recurrence, but is associated with severe morbidity, especially hypothalamic morbidity and a poor quality of life. It gives more life years, but at the expense of quality. Whereas subtotal resection followed with adjuvant radiotherapy has a higher risk of recurrence, but gives you less morbidity and a better quality of life, more life 2 years. It's a comparison between more life years and more life in your years. So obviously, when there is this choice, there is always quality of life, which gets importance, and that's how the debate had kind of concluded a few years back until this debate, the spark has been ignited again. And I would like to focus this by contending that what if, of course, as far as the recurrence part is concerned, there is no doubt about it that gross total favors less recurrence. But what if gross total recurrence offers an equivalent quality of life with a lesser risk of recurrence? And that's what I will try to prove in the next few minutes. It provides evidence to provide that acceptable morbidity is equivalent to that of subtotal resection with radiotherapy. Now, this I intend to do with evidence, with the help of a lot of literature, a lot of recent evidence. And as Sarita had given a fatwa that we should be using recent evidence and your own personal experience, and that's what exactly I will do. Only most of my references are of meta-analysis and systemic reviews in the last 5 years or so. And of course, our large series, which has been published thanks to the first author in all this, Dr. Saravanan, who was a resident in Sri Chitra and now faculty at PGI. He did a lot of analysis on craniopharyngiomas, and thankfully we have almost 5 to 6 publications exclusively detailing our experience at Sri Chitra on craniopharyngiomas. And we'll be discussing based on these parameters, outcome based on these parameters: vision, pituitary function, hypothalamic, diabetes insipidus, mortality, and recurrence. The ones in red are the major ones, which are non-compromisable, whereas the pituitary, hypopituitarism, and so forth, and diabetes insipidus, we all know can be somehow managed, but not obesity. And hypothalamic function is not only about obesity, but a lot of other issues, metabolic syndromes and cognitive as well, which can be really terrifying. So what is the visual outcome? How do you assess the outcome, compare between? Now, this study, I must confess again, is not totally pediatric, but includes pediatric as well. So this is how it fared. Gross total resection versus it compares all forms of this one, I'm sorry, this is exclusively pediatric one. It compares not only gross total with subtotal, but in fact, intracavitary bleomycin, interferon altogether. You would see that comparing gross total versus subtotal, it was a kind of equal. But yes, if you look at it, I'm sure, sorry, this is got misplaced, but higher risk of visual deterioration with the gross total resection. Now, the same findings were echoed in some other literature, which I'm just quoting here: single center with 41 patients, another center with 80 patients. But surprisingly, our results were in favor of gross total resection. The amount of worsening vision was more in subtotal resection compared to both in the early visual outcome as well as late. I don't know for what reason, but somehow subtotal resection had a poorer outcome in terms of visual deterioration in our series. So, but nevertheless, putting everything together in perspective, it has to be admitted the chances of improvement, visual improvement, is better with gross total resection, whereas the risk of visual deterioration is also more with gross total resection. But now we have enough evidence to say that this most important predictor of visual outcome is the preoperative visual function, and it is little more concerned about the surgical expertise, and which can help in preventing visual deterioration postoperatively. Coming to pituitary and hypothalamic function, I have clubbed them together, although those are two different entities altogether, because most of the literature, in fact, clubs endocrine and hypothalamic function together. As I said, pituitary malfunction can be corrected to some extent, but hypothalamic malfunction can be really difficult to manage. So now this is again a meta-analysis by Sharavanan, and this, in fact, it compares endoscopic versus transcranial, but majority it gives an idea about the post-op hypothalamic morbidity, which can happen with, this is a meta-analysis, not exclusively our series. This is around the figures that you can see. Post-op hypothalamic morbidity, hypopituitarism, and DI in the range of around 50%, both in the transcranial and the endoscopic review. And this another systematic review which compares visual outcome as well as endocrine and hypothalamic morbidity. Systematic review, it includes both pediatric as well as adult. And again, you would see, it will appear that I'm batting in favor of Ranjit, quoting that higher incidence of panhypopituitarism and permanent insipidus in the gross total resection. But lo and behold, this is what happens with radiation. This is the amount of hypothalamic and endocrine disturbance that you can get with radiation. And this is again a recent in 2022 publication meta-analysis. You can see the amount of hormonal deficiency which can happen following radiation, and this is around above 60 to 90% actually. This again corresponds to our series again, but what I like to point out is some of the new studies which have come out which show that gross total resection is associated with less hypopituitarism. This is a large series which includes 12,000 patients with 11 observational studies, 3 of them being exclusively pediatric. This one again is predominantly pediatric study. You can see here. So this is again, if you look at evidence, you have evidence for both ways, but now recent evidence suggests that gross total resection, you have increased incidence in hypothalamic dysfunction at 1 month, but at the end of 1 year, there isn't much difference between subtotal and gross total resection. Similarly with pituitary function as well. In fact, there are these studies which suggest, as you would say, that, obesity can happen despite preserving hypothalamus. So it is not all about preserving hypothalamus. And there's another study which I've quoted down which says that part of infiltrated hypothalamus can be resected without much deficits. So I guess the bell is rung. So I'll just run through the studies just to know how did, and the same about pituitary stalk preservation also. The stalk sacrifice definitely results in higher incidence of panhypopituitarism and weight gain. But there are enough evidence now, as I showed the literature which I quoted over here, they show that we can still manage to achieve a gross total resection. And even if you preserve the stalk, there is a risk of diabetes insipidus. So just preserving the stalk does not altogether imply that you're going to not to have hypopituitarism or diabetes insipidus. Now, how do they explain this recent turn of events? So what I understood from and what I could make out from the recent literature is it's all about the grade of preoperative hypothalamic involvement. So you have this classical teaching, the Pugo type O, type 1 and type 2. And what has been recommended now, and what I would like to emphasize here is the Pugo type 0 and type 1 gross total resection can be attempted and performed with outcomes comparable to subtotal resection with radiation. Morbidity related to hypothalamus can be reduced by performing hypothalamus sparing surgery and stalk sparing surgery. So this is something like a maximal safety. This is not an exactly gross total resection as you would define. It's a near total resection or a maximal safe resection, especially only in type 2, Pugo type 2, whereas types O and type 1, you can attempt a gross total resection. Now recurrence and progression-free survival, overall survival, and so forth, I think I would not emphasize in detail because it is done and dusted, enough evidence to show that long-term outcome and recurrence is directly related to the extent of resection, both in pediatric and adult as well. So apart from this, there are these add-on complications associated specifically with subtotal resection and radiation. We have our own case of a malignant astrocytoma, which we published in an Indian journal, malignant astrocytoma following radiotherapy. Added to this is the chance of recurrence, as you know, higher risk of recurrence and the complications associated with operating on a recurrent craniopharyngioma, which is far, far more difficult than in a first-time surgery. And of course, there are these vascular complications like the moya and so forth, which can happen following long-term radiation, long-term after radiation. So to conclude, I would like to emphasize that if you compare, recurrence, definitely gross total has an edge. And if you look at each parameter wise related to outcome, vision, I would say, is almost due, it's equal. Pituitary function is almost equal. Hypothalamic, diabetes insipidus, and mortality, I agree more with gross total resection, but only for Pugo type 3, type 2. If you go 0 and 1, we can attain great gross total resection with equal morbidity. I'm not saying zero morbidity, but equal morbidity compared to subtotal resection. Just to conclude, this is what I requested ChatGPT to provide. This totally ChatGPT generated. I just wanted a single slide to compare, and even ChatGPT says it has a smile when it talks about gross total resection and a frown when it talks about subtotal resection. To end, this is what I would like to conclude and the take-home message. I'm not saying that gross total resection is not associated with morbidity. You need to attain aim for a near total resection, but the point is the most important factor, as highlighted by Harold Hoffman, is the surgeon's attitude towards the tumor. If he or she regards the tumor as non-resectable, it will be treated as such and no attempt will be made to remove it. If on the other hand, the surgeon feels that the craniopharyngioma can be totally removed, its management is likely to be successful. So that should be the intent when you approach, and when you operate, leave behind parts which are inseparable from the hypothalamus and the stalk, and you'll have a better outcome. Thank you so much.
Thank you, Dr. Girish. It was a wonderful lecture, and he'll be given a chance for rebuttal as well. The next speaker, please, Dr. Ranjit. You will be on the conservative side, right? So while they're setting up, I would like to ask you a question. Like, usually you see types where there will be a lot of calcification in the hypothalamus with a large cystic component. So what will you do for those cases where the calcification chunk is sitting right over the over the hypothalamus, and rest of the things are cystic or something like that? I think after the nasal route has become popular, I think this gross total resection popularity is increasing in craniopharyngioma surgery.
That's why, as I was mentioning, there was this debate about gross total versus subtotal earlier part of 2000, the earlier part of this century, but then it totally subsided. The debate was between transcranial and endoscopic. Now it's almost endoscopic approach for craniopharyngiomas globally. And that debate is no longer there because a lot of publications suggest that the gross total resection is better with the transnasal.
Good evening. At the outset, I would like to thank Dr. Sarita, Dr. Sumit, and the organizing team from Satyasai for having given me this opportunity to present our views on the management of craniopharyngioma in children, focusing on conservative surgery and radiation therapy, which is what I follow and our unit follows. So what is the cost of management of craniopharyngioma? Craniopharyngioma is a benign disease. It usually occurs in children in the first decade, and all of them usually go on to live on to adulthood. So it's a lifelong disease like diabetes and other diseases. So there are four major morbidities that happens with following treatment for craniopharyngioma, which is either surgery with or without combination of radiation therapy. The ones marked in yellow are probably acceptable morbidities. Like, for example, visual disorders occur because of direct injury at the time of surgery. And so it has to be considered in the context of the preoperative vision. For example, if a child comes to us with preoperative PL positive 6/60 vision and all that, it may be acceptable to lose vision completely in that particular eye. But on the other hand, if a child comes with a vision of 6/6 or 6/18, then it is our duty to preserve that vision and not allow any visual deficit. Neurological deficits usually occur because of vascular injury to perforators, which usually is more common definitely when we try to attempt a gross total resection, and this should be avoided at all costs and unacceptable. Panhypopituitarism occurs either prior to surgery, at presentation, or after surgery in nearly 80% of these children, and is virtually unavoidable if you want to treat these tumors, either with gross total resection or with partial resection or biopsy followed by radiation, or subtotal resection and radiation. However, diabetes insipidus in the postoperative period again has been shown to be more with gross total resection and should be avoided, particularly if the adipsic form of diabetes insipidus, where the child cannot take water because they lose their thirst mechanism, and that can be really life-threatening. Similarly, hypothalamic obesity, the metabolic syndrome, and neurocognitive and behavioral abnormalities significantly affect their QOL. All are more with gross total resection, and because of trying to dissect the tumor of the hypothalamus, particularly in the Puget type 2, grade 2 tumors, and this again must be avoided. So this is again a meta-analysis of the treatment-related morbidity, which looks at the gross total resection versus the subtotal resection groups, where we can see both of them have got post-op anterior pituitary dysfunction and incidence of panhypopituitarism, slightly higher in the gross total resection compared to subtotal resection group. However, post-op permanent diabetes insipidus was much more commoner in the gross total resection group and not very significant in the subtotal resection group, and new neurological deficits pertaining to the hemiparesis occurred only in the gross total resection groups mainly. Similarly, if you look at the quality of life, quality adjusted life years, if you see biopsy and RT, they have the maximum number of quality adjusted life years, and with subtotal resection being next, and gross total resection seems to have the most poor quality of affected life years after surgery. All this resulted in a shift in the management paradigm in surgery towards more conservative approaches. And as Dr. Girish has already shown us, there is a significant incidence of hypopituitarism following treatment for craniopharyngioma with limited surgery and RT. So this is our data from our unit, where we follow a paradigm of subtotal resection or partial resection of tumors, followed by upfront radiation therapy. Between 2010 and 2019, we had 70 children less than 20 years of age. Often we have follow-up for 55 children, up to a median follow-up being around 36 months, ranging from 24 to 168 months. And 47 of them had primary surgery for the tumors, and 8 of them had secondary surgery. All of them were treated elsewhere. Sometimes it used to feel very sad. The resections that were done were so good with a very small residue left, and then they would have come back for recurrence only because they were not treated with upfront RT for the residue. And we had a recurrence after our surgeries on 12% of the patients during this period, and 90% of the patients either had improved or same vision at follow-up, with 4 patients having deterioration. And anterior pituitary disorders deteriorated in nearly 50% of the patients, and they remain the same as pre-op in 51 patients. 3 of them continue to have a normal pituitary function at post-op. This is another paradigm we followed, where we only placed an Ommaya reservoir into the cyst and then treated them with radiation therapy. We had 24 such patients, and 16 had follow-up for a mean period of 5.5 years. And again here, recurrences following partial excision done earlier without RT. Whenever RT was not given following partial excision, subtotal excision, these tend to recur. And in our data, we found that 12 out of 13 patients had either improved or stable vision, and there were no new endocrinopathies. So this is an example of one of the patients treated by us who had a large cystic craniopharyngioma. We just placed an Ommaya reservoir, decompressed the cyst, and subjected the child to radiation therapy. And at 100 months, we had progression-free survival when she came back to us with a new cyst, the left paracellular region, which third nerve paresis, which was excised, and re-radiation was given. And 18 months following radiation, she's doing well with a stable residue on hormone replacements. This is another example of a 17-year-old child who did a subtotal excision of this large cystic craniopharyngioma, leaving behind the solid component. She defaulted RT, came back to us 5 months later with recurrence of the cyst, for which an Ommaya reservoir was placed, and then she underwent radiation therapy, and she's doing well. 75 till around 14 years, she was doing well. She came back to us now recently with the recurrence of the cyst, for which we have done resurgery and re-RT. So going to the types of radiation therapy. So this is a recent paper from Tata Memorial, which clearly shows on a randomized trial between conventional RT and stereotactic RT, that both conventional RT and stereotactic RT have similar tumor control rates and overall survival at 10 years of more than 90%. However, there was freedom from cognitive decline was lower in the conventional RT group compared to the stereotactic RT or the conformal RT group, and the incidence of new neuroendocrine dysfunction was also higher in the conventional RT group compared to SRT group, which means focused RT does not really add on to the endocrine dysfunction in these patients, but conventional RT definitely does. Now, coming to the results between proton therapy and versus photon therapy, that is a conventional RT that we have in most of our centers. Again, the progression-free survival and overall survival are similar between both the groups. However, the proton therapy did result in a better cognitive outcomes in these children compared to the photon therapy, and visual outcomes are also similar in both the groups. So regardless of the type of radiation we choose, these patients seem to have good progression-free survival and overall survival of more than 90% at 10 years. It's not moving slides. So this is another data from our own institution by Saurdeep Sarkar, the first author in both these papers. And this is published by the group which was practiced maximal safe resection or attempted gross total resection in every case, but some of them, they had to limit themselves to a subtotal resection because of the poor plane with the hypothalamus. Here it's shown that the progression-free survival after subtotal resection plus RT is the highest, then followed by gross total resection alone, the last being subtotal resection without RT. So it is not that gross total resection is not without recurrences. 33% of patients did recur in the series after gross total resection, and they require a subsequent therapy, either surgery or surgery followed by radiation therapy. And subtotal resection and RT had a higher risk of postoperative obesity in this group, but it's possible that these patients underwent subtotal resection because of significant hypothalamic damage already being seen, and that may have contributed to the obesity. And it is stated here that the tumor and hypothalamic plane is the most important deciding factor in deciding surgical outcomes. There are some issues with RTs. What can happen is these cysts can recollect very early, as we observed in 20% of our, nearly 20% of patients. That is one indication why upfront RT should be given for any residual cyst after subtotal excision. And they also require surveillance imaging during the RT, so that in case the cyst increases, then we need to either treat them with replanning the RT or with Ommaya reservoir placement and decompression may be required. This is another paper from our institute which looked at upfront RT versus postoperative surveillance following residue, following residual tumor or after gross total resection. And here we found that upfront RT progression-free survival is 129 months, while for those who had surveillance alone, the progression-free survival is 27 months. So even after a gross total or near total resection, this disease does tend to recur. And childhood onset coronary pharyngioma is a lifelong family burden. Here is a study which looked at the burden of the caregiver, and it's shown here clearly that the more number of symptoms that these children have with respect to hypothalamic and pituitary dysfunction, as well as poor quality of life, obesity and hyperphagia, the quality of life of the caregiver also reduces. Similarly, as the pediatric QOL scores in these children decrease, the caregiver's burden also increases. So it not only affects the child, but it affects the entire family and the people around them. So this is why I would say that the philosophy of conservative approach in these patients is the best, better than gross total resection. The principles being to reduce mass effect on the optic apparatus and hypothalamus, excision of the cyst wall as much as possible makes maximal safe resection, preserve the hypothalamus and pituitary stalk, and follow up RT for the residual disease to prevent progression of residue. The rationale is most of these children have got very large multi-compartmental tumors. Often they require more than one stage to achieve a gross total or near total excision. Several of them have significant hypothalamic involvement, and gross total resection by itself does not provide lifelong cure. And focal RT has been shown to be safe and effective in the long term. Thank you.
Thank you, Dr. Rajneesh, for putting your points quite brilliantly. Do you have your 2 minutes of?
Ranjit is a close friend of mine, and so I don't want to go in for a rebuttal. We'll just arrive at a consensus, Ranjit, if you don't mind. And that's what the session also wants. So I do agree that gross total resection or the so-called maximal safe resection is not, that it's not without recurrence. It can recur. And I guess you also agree that so-called STR with radiotherapy is not without cognitive and other problems. Both of them have their own share of problems. My only argument is that as the quote by Harold Hoffman I mentioned, when we approach the surgery, go in with an intent to take out maximum as possible. And with your judgment and expertise, try to avoid damage to the hypothalamus, the pituitary stalk, and the optic apparatus. So that in case you are able to achieve a gross total or a maximum safe resection, there is a possibility that we might be able to give a good quality of life and the child may not require radiation. So the intent for maximal safe resection should be there rather than going, when you start the case itself, you go in with an idea that no, I'm just going to take a biopsy or just decompress the cyst and come out. So that's the only take home message or the consensus which I would like to share.
Dr. Ranjit, in case you've gone in for a tumor, case, and you have achieved a gross total resection, how do you follow it up?
Okay, honestly, I haven't had that experience, at least in the children, because all the tumors that come to us are fairly large and definitely they'll have these chunky calcifications stuck to these vessels and nerves. So those usually I don't even try to attempt to remove them very much. But in adults, we have had some patients who come with very small tumors. So those we have achieved gross total excision. So there usually we do an MRI after 3 to 6 months. See, and if there is any sign, very often we think that we have removed it and there will be some small bit left in the cell or something like that.
There are cases where I have managed without cranial also. And actually, small bits of calcification is actually considered as gross total. There is a classification. I didn't put it up for sake of time. There are small bits of residual calcification is actually considered as gross total resection. And adult cranial, definitely they do much better many times and we are able to achieve it. But adult is now totally different. Now there is chemotherapy available for adult cranial. So it's not only radiation and there's chemotherapy also.
And the other thing we also find very difficult, at least in Vellore, is that patients coming back for follow-up. So so anytime we see a residue, we would rather complete the entire treatment that we can provide the child at that particular time, which is upfront RT. Now, after that, if they don't come for follow-up, but also at least they've completed that RT, we know that from literature that at least the chance of recurrence is only after 6 to 7 years, once RT has been given. But if you leave them alone with a small residue without giving RT, they tend to recover much earlier. So the only patients whom we don't give RT upfront is the children who are less than 3 years, so which we try to get as much of the tumor out and then follow them up.
We used to have the same problem here of patients not coming back for follow-up.
Yes.
I don't know what the situation now is. It must be the same.
Yeah.
Yeah, because
sometimes
it's free therapy and there's no value for a patient is better, so they don't come back.
I think
They
large
only come back
centers-
only when there is a recurrence of the symptoms.
Yeah, because they know they can again get it sorted out.
Sir, adding to your part, I operated a small boy of 12 or 13 years, 2016. And then subtotal resection, RT given 2018, he was cured. Then suddenly there was COVID, they were lost. One day, maybe in 2021 or 22, they came to my OPD. So I also must be busy on that day or whatever, I don't know. But I've just seen him, did an MRI and it was absolutely disease-free. Now, this December, they came and they started fighting with me saying that our boy has become important and we are facing an issue of divorce. So they were ready to claim on me. So I also don't follow that at the age of 12 or 13, how do you ask him whether he's potent or not? That's the first thing. Then within 2 years, the disease after subtotal resection with radiotherapy was cured. So we didn't had a gamma knife in Ahmedabad at the time. We got gamma knife only before 2 years. So conventional radiotherapy was given. And at that time, I was also happy. They were also happy. The boy was also growing. So there was no...
Your point, Ravi.
The point is how to check at the age of 12 or 13 years in a kid and how to take it follow-up, means especially in a low socioeconomic family. How can you just check there, sir, that whether he's really potent or not?
I think we have to hurry up because all of us have flights to carry.
Yeah.
So the thing is that we need a regular follow-up. That's the idea of having a follow-up and surveillance. So that's what
from 2018 to 2026, he came only once in between.
I mean, that is so you have to tell on that point that if you had come on follow-up, we would have told you something. So that's how it is, I think. Yeah, I think both the speakers have put their points brilliantly, and there is a consensus that is customized to the child or the adult. And if you are very good at surgery, go for it. If you are not very good at surgery, it depends on your confidence, I think. And yeah, but only one thing is that you have done a gross total resection. Will you consider to give radiotherapy still?
For the first 2 years, maybe 3, 4 years, they remain symptom free, and we need to be on regular follow up. At the time of earliest recurrence, they have to
Yes.
undergo
Still
radiation.
we
Yeah,
have
to
that
be this.
consideration. Thank you, Dr. Girish.
No,
and
no radiation upfront.
Yeah.
No, small radiation. Yeah. No, what I wish to convey is, if you general policy is CT immediately, is MR at 3 months. The MR at 3 months does not show any residue, no upfront radiation, assuming that there is a residue. And then say, yeah, if it is a small one, sometimes I go in again, and then whenever I do a redo, I send them for RT. Sometimes the recurrence comes as a large cyst or a large tumor recurrence, then radiation. The small residue, then radiation.
Right. Thank you, Dr. Ranjit and Dr. Girish. We'll now move on to the next talk of this session. Our next speaker is Dr. Subodh Raju, Senior Consultant Neurosurgeon at AIG Hospitals in Hyderabad. He'll be speaking on the evidence-based management of pediatric hydrocephalus.
Good afternoon, good evening. Thank you, Dr. Sarita. Wonderful meeting. Very, very good topics, actually. This is slightly out of the box, hydrocephalus. But it becomes one of the common things which we face day in and day out. For the residents, everyone knows what is a communicating, non-communicating hydrocephalus and where we do endoscopic third ventriculostomy. And the hydrocephalus has been classified into various types depending on communicating and non-communicating. One small point is, when you talk of non-communicating hydrocephalus, it's not acute stenosis only. It can be fourth ventricle outlet obstruction also. That has to be kept in mind, because conventionally when we see the CT scan, if this thing is aqueduct is dilated, we tell it as communicating hydrocephalus, but that's not the thing. Similarly, it has been classified pathologically, different pathologies. The aim of any hydrocephalus treatment is to relieve the hydrocephalus. There is only one aim for treating hydrocephalus, that is relieving the hydrocephalus. Treat complications, manage psychomotor problems, and that is usually surgically. So what do you do surgically? Whether we give only acetazolamide spinal taps or do third ventriculostomy or shunts. Gold standard years together was shunt, and it still remains our fall thing if our ETV doesn't work. But shunt has its own set of problems. Lifetime failure rate of shunt is considered to be 100% actually, and people for who are shunt dependent. And sometimes outcomes are unpredictable, and we along our lifetime have seen all sorts of complications with shunt, from migration to these things. And this is one common thing which we see, the slit ventricle or the subdural hygroma we see. So taking these things into consideration, especially in pediatrics and infants, actually infants is a very separate subset. So inside we thought endoscopic third ventriculostomy was a good thing. There's a very big article in NEJM by Kulkarni, where they have seen that shunting in hydrocephalus Uganda. And in Ugandan, infants with post-infectious hydrocephalus shows no significant difference between endoscopic ETV CPC versus ventriculoperitoneal shunt with regards to cognitive outcome. So it's neurosurgeons feel that success of surgery is when there is not requirement of a second surgery. But actually, if you see success of surgery, we are looking at cognition and development also. That has to be considered. So ETV and shunt had an equal outcome. So endoscopy, intraventricular endoscopy has numerous indications actually. Primary acute stenosis of the third ventriculostomy is the most common indication which we do it actually. Then there is fourth ventricular outlet obstruction, posterior fossa tumors, posterior third ventricular tumors, septated hydrocephalus, arachnoid cyst, and these things. There are various indications where we find a high success rate and then the intermediate and the low success rate. One more important thing in a practice is subjective indication. A child comes to me with hydrocephalus, maybe 6 months old. I tell the success rate is 60%. So should we do a shunt or should we do an ETV? So if the parents understand that in these 60% of these children, the shunt may not be required, we go ahead with ETV and then tell them that shunt may be required. So this it's a relative indication of contract, especially for small children less than 6 months of age. And the rationale behind this thing is offering the patient a chance of a shunt-free life. Endoscopy equipments, everyone is familiar with the rod lens, the rigid endoscope and the flexible endoscope. This is a standard ETV which is done actually. Yeah. So the standard third ventriculostomy which is done, it's a mainstay of treatment of hydrocephalus nowadays. Always check for the second membrane whenever you are doing a third ventriculostomy. The end point of third ventriculostomy is visualization of the basilar artery for all practical purposes. Measurable outcomes, shunt independence, change in ventricular size, patency of stoma, and neurodevelopmental outcome has to be considered in these cases. So this is a very, very good practical tool which everyone should have in their OPD to talk about ETV success score made by Dr. Kulkarni and team. It's fairly good to predict whether the ETV is going to work in this children or not. So have this as a handy when you prognosticate the parents in the outpatients. And the best scenarios are adult acute stenosis. They score very good in these things. When we talk of outcomes, when we talk of pediatric outcomes, the literature quotes wide variety actually. And starting from 50% to 78% is outcomes. You can see different literatures. So if this is the thing, it's a review article in World Neurosurgery published in 2025, Rethinking Definitive Treatment of Hydrocephalus in Infancy. So they tell that definitive management with VP shunts in patients less than 6 months of age, the pooled etiology cohort have documented a failure rate of 38 to 59%. And ETV or ETV plus CPC is 47 to 80%. So early patients, especially children less than 6 months, should we jump in for a definitive treatment is the question here. So here, because for the time being, when the child comes in acute phase, you can do something temporizing solutions, like a ventricular subgaleal shunt or putting in a reservoir and doing tappings. This will, or there is a mild hemorrhage, mild infection, treat those things, and then go for a definitive procedure, then jumping for either a ETV or a VP shunt. It's a very, very important thing which they have pointed out. And this one, infants with hydrocephalus had a higher treatment failure rate when they had undergone ETV compared to a shunt placement. That is outcomes. When we talk of long-term outcomes, you see reliability of ETB after 1 year was stratified according to age. So as the age increases, your success of ETV increases. Patient comes to OPD with a large head, no pressures of raised ICP. How do you evaluate sometimes whether the shunt is functioning, ETV is functioning or not? Sorry. So we do a cinephase contrast MRI, which detects a flow across the third ventriculostomy. If there is a minor flow, it appears to an early sign of closure. So the volume has been, the stroke volume, which we calculate across the ventriculostomy, should be more than 75. And ventricular side, don't look at ventricular dimension. They are not a very great indicator for ventriculostomy patency. So the stroke volume has to be seen whenever you are in doubt and these things. ETV failures, commonest reasons are reclosure of the ventricular stoma, narrowing of the ventricular stoma, and formation of a new membrane, especially when you deal with post-infectious, post-hemorrhagic, where the signs of inflammation, bit of inflammation. So routinely, whenever you do send a CSF for analysis, so that you know, whenever you are doing an ETV, any signs of inflammation, because inflammation will lead to healing some way or the other. So these membranes and cicatrization forms in these cases. So re-endoscopic third ventriculostomy is an option in these cases. But overall, it was shown that most of the clinicians as such, because the patient will not agree for re-surgery, will prefer for a VP shunt than for a redo ETV. Coming to ETV classic, the most common indication is a primary accidental stenosis, different reasons. It could be a primary or a secondary accidental stenosis. We do a ETV. We get challenges when you are doing an ETV, like a small foramen of Monro. And when you try to pass your rigid scope, you can cause these fornicial contusions. We have to be careful on that. So measuring the foramen of Monro on the preoperative MRI is mandatory. It should be at least more than 7 mm. Or you are using, or instead of a standard Ascalap mini-op or a lotoscope, you should have a little lotoscope. In our centers, I use a flexible scope for doing all these small things. Next thing is most of the data on TBM with hydrocephalus. Should we do ETV or not? The simple guidelines tells that do an MRI, contrast MRI. If there are enhancing exudates, don't attempt an ETV. If there are no enhancing exudates, you can attempt an ETV or a healed ETV. You can. The success rate, Dr. Mazhar Hussain published this, and I think Dr. Yadav also published this. They had a success rate of more than 50% at 1 year, actually, in this case. I'll come later on to this again. Uncommon indications, other common for ETV is arachnoid cyst with hydrocephalus, very common. Large arachnoid cyst displacing the foramen of Monro and causing hydrocephalus. There are large arachnoid cyst where you can do a cystoventriculostomy along with these things, third ventriculostomy, or a suprasellar arachnoid cyst. Suprasellar arachnoid cyst, opening up the cyst cavity is not sufficient. You have to do an ETV with it. So once this is suprasellar arachnoid cyst, and once we have opened the cyst, this is a thulium laser which we use actually. So cystonostomy is also important. It's not cystoventriculostomy only. So once you have opened the cyst, we go into it. You can see the dipping third ventricle floor. This is the basilar artery, and you have to do a third ventriculostomy. So cystoventriculostomy with a cystocystonostomy it has a good outcome than compared to only doing a cystoventriculostomy in these cases. Or this is another case of arachnoid cyst. Same way, after laser fulguration of the cyst, go into the cyst and do a third ventriculostomy. So the membranes might be tough sometimes there. You can't open it with a scissor or anything. And these cases, we use the laser, thulium laser, to make opening into the floor. You have to be careful because we are doing it just near the basilar artery and opening it a cystoventriculostomy and cystocystonostomy. Uncommon indications, idiopathic stenosis of Magendie and Lashka, a fourth ventricular outlet obstruction with a large posterior cyst where it's displaced anteriorly. How do you do it? So for that, we require the flexible scope. That's another thing in your armamentarium. Like this, a dilated fourth ventricle with an hydrocephalus. So straight go to instead of these things. So after doing a third ventriculostomy, if it is not happy, the aqueduct is naturally dilated. It's nature's thing because fourth ventricle outlet obstruction. You can see the foramen of Magendie closed with the membrane here. So open this thing and do a Magendostomy. You can see here the tonsils and the choroid plexus inside the fourth ventricle. Or, sorry, this video is not there. Okay. Or there is a fourth ventricle arachnoid cyst. The fourth ventricle arachnoid cyst bulging into, this is again the case of a fourth ventricle outlet obstruction. So one procedure has to take care of both, one burr hole. So you take care of the posterior fossa arachnoid cyst through a transaqueductal procedure and do a third ventriculostomy. So you have taken care of both. Or in this case, there's a large retrocerebellar cyst. You can see a large retrocerebellar cyst causing obstruction and hydrocephalus. So once you do the third ventriculostomy, we do a transaqueductal, transmegendal. This is the arachnoid cyst, the retrocerebellar large arachnoid cyst. Open it up and do multiplication at number of places. You can see the pica vessels. This is a cyst wall, and open it up of number of places. So this one we published it. We had a series of 8 cases of posterior fossa arachnoid cyst which published it actually with a flexible scope. Trapped fourth ventricle is another indication, but we don't do a third ventriculostomy. The endoscope is required to open up the third ventricle. Posterior third ventricle tumor or a pineal region tumor with hydrocephalus, where you have to take care of both the things. They are also because it's an obstructive hydrocephalus, after doing an ETV, we take the flexible scope and do a biopsy from the posterior third ventricle tumor. The tumor sitting in the aqueduct, take a biopsy of it and solve. So this is one of the interesting indications for using a flexible scope along with a rigid scope. Prophylactic ETV in patients undergoing resection of fourth ventricular tumors. ETV prior to posterior fossa surgery significantly reduces the risk of postoperative hydrocephalus. Important thing here is because of the large posterior fossa tumor, the brainstem can be displaced quite anteriorly. So we have to be careful while dealing with these ETV cases. There are numerous publications where they have seen that the perioperative failure with shunt is more than with ETV. And post-traumatic hydrocephalus, ETV is not a contraindication, especially if there is an intraventricular hemorrhage and these things where there is a web or an obstruction at the aqueduct. Uncommon indications of doing endoscopy is trapped ventricles, as I told you before, where there is an asymmetrical ventricle, trapped ventricle, we do a foraminoplasty, septostomy, and take care of it. Multiseparate hydrocephalus, whoever has dealt with pediatrics infection will know that. It's one of the challenging cases because multiseparate hydrocephalus is a very, very dynamic disease and it keeps on changing the course. So these children may require multiple surgeries. Our aim is to manage these children with a single device, single shunt, not putting multiple shunts. So you may have to do repeated septostomies with endoscopy and then place in a shunt together. The previously shunted multiseparate hydrocephalus, you can see here the shunt is again displaced. So we have taken a trajectory from exactly opposite side and trying to locate that shunt. So one after the other, we open it and we identify the shunt and draw into that. So that one shunt still takes care of it actually. These all things come under the headings of the complex hydrocephalus where you have to take it on. Communicating hydrocephalus, should we do it or not? Especially Dandy Walker and these things are challenging scenarios. We have to decide on that based on these things. Coming to the main contraindications for ETV. If there is history of radiotherapy, significantly distorted anatomy, there is no heroism in doing a third ventriculostomy because you can have the worst of the complications and abnormally narrow prepontine space, ectatic basilar artery, vascular lesions on the floor, prematurity, IFH, and absolute infection on these things. When we talk of third ventriculostomy, conventionally we think about third ventricle floor. But there are scenarios where we cannot do a third ventriculostomy through the floor of the third ventricle. It could be post-meningitic, like I was talking about the post-TBM hydrocephalus. TBM hydrocephalus is basically a basal arachnoiditis. So the arachnoid above may be free. So in those cases, like you see here, or the vascularized, very, very prominent vascular, where you can't do a standard third ventriculostomy, we do something called as a trans lamina terminalis. Lamina terminalis, we have opened it number of times during anterior communicating artery aneurysm, these things, from outside. Now it is opening the lamina terminalis from inside. So we go here, this is the standard third ventricle floor. We open the laminar terminus from inside here. Show you the videos over here. This is with the old generation scope and this is with the new generation scope. So we tried doing a standard third ventriculostomy. You can see the scarring below when you do a third ventriculostomy here. So this is the optic chiasma. This is the lamina terminalis. We open it. Endpoint of standard third ventriculostomy is visualization of the basilar artery. Endpoint of laminar terminalis third ventriculostomy is visualization of any part of the anterior communicating artery complex. So this is the laminar terminalis. You can see here. We open it. Here you will just see the artery here. The artery can be seen here. That's the endpoint of this thing. So mostly the TBM hydrocephalus are highly vascular things we do. We publish this. ETV with CPC, enough article has been there depending on your requirement, especially in meningomyelocele or post-infectious. We do this. Or patient having choroid plexus hyperplasia with massive ascites. We do ETV with choroid plexus coagulation. The whole choroid plexus is fulgurated. And you can see the bulky choroid plexus here. This is a choroid plexus hyperplasia. So in these cases, we do ETV plus with CPC with a laser actually. We go up to the fourth ventricle. There's a fourth ventricle choroid plexus also. We don't leave it. Everything is taken care of. This is a post-op thing. The ascites has come down. The concluding, hydrocephalus is one of the major health burden. Neuroendoscopy has become the standard of care. Less invasive, promising result, less complications. The complication rate of ETV is not too high. Serious events should always be kept in mind. Understanding the potential surgical complications at each step is very important. And etiology of hydrocephalus rather than the age of the patient is more important in determining the efficacy of ETV, even in patients less than 2 years of old. The aim of treating any hydrocephalus is saving the brain. So ETV or shunt, save the brain, that's the most important thing. Thank you very much.
Thank you, Dr. Subodh. I think it was a very lucid talk covering everything about ETV. Yet, any questions? Yet, I think we are still quite not there before 6 months of age.
In some cases of the communicating hydrocephalus, again, what we think, conventional thinking of if there is no fourth ventricle outlet obstruction, communicating hydrocephalus means you talk of post-infectious, post-major, dandy walker. In some cases of dandy walker where we think it's a dandy walker variant, where there's a postifus arachnoid cyst, then actual dandy walker. We have done ETV.
But for that, you were using the flexible one, right? Any questions from the floor? You haven't?
No, nothing. Okay, thank you, Dr. Subodh. I'd now like kindly request the moderators to present Dr. Subodh with a small token of our appreciation. Following which, I'd like to request Dr. Sumit to kindly felicitate our moderators as well. We enter the last phase of our conference now, and for this session, we have a fairly eclectic and diverse mix of topics as we hope to draw a close to a fitting end of a full day of fitting scientific discourse. The moderators for this session will be Dr. Ranjit Murthy and Dr. Rakshit Srinivas. Dr. Ranjit Murthy is a senior professor of neurosurgery at CMC Vellore, and Dr. Rakshit is associate professor at the Department of Neurosurgery in MS Ramaiah Medical College. I now call upon our next speaker, Dr. Dinup, who is an additional professor of microbiology at Sri Chitra in Trivandrum, to walk us through the nuances of antibiotic prophylaxis as relevant to neurosurgery.
See, at the outset, we would like to congratulate Dr. Sarita and Dr. Sumit for having designed this beautiful scientific program. In one day, they've covered almost all the significant topics. And I think now the present topic that we are dealing with, the last session, is probably the nightmare of every neurosurgeon around the globe. And the next topic would be the nightmare of the future for all of us. So I'd like to invite Dr. Dinup for his talk.
Good evening, everyone. I thank the organizing team for giving this opportunity to speak on this topic on this day. The topic which was given to me was the antibiotic arsenal, guiding neurosurgical infection prevention with evidence. So the brief overview for the next 20 minutes would be on the various diverse neurosurgical infections which we see, the spectrum and its incidence, the risk factors linked with neurosurgical infections, the evidence-based risk mitigation strategies based on the modifiable risk factors which are identified in the literature. In parallel with the infection prevention strategies, addressing antimicrobial resistance is important in managing most of the neurosurgical infections. So sorry. So these are the spectrum of neurosurgical procedures which is undertaken on the current neurosurgery practice, which can be broadly classified as the cranial neurosurgery, the skull-based neurosurgery, the spinal neurosurgery, and there is device use or the device insertion neurosurgery, predominantly the shunt-based, the drain insertion, as well as the other implants like deep brain stimulators or the spinal cord stimulators. Most of the postoperative infections which we see could be classified broadly as the superficial, deep, as well as organ space involvement, which includes the ventriculitis or meningitis. Cranial neurosurgery is the most common practice where the procedures can be classified as the clean, in which there is no breach of the mucosa, that is the sinuses or the mastoid. There are clean contaminated procedures where there is a breach of the sinus cavity. And there are contaminated procedures where there is a penetrating injuries. So because the procedures are so diverse, the risk factors as well as the rates of surgical site infections and the meningitis are also different for many of these procedures. I think the PowerPoint is. I'm so sorry with the PowerPoint, it looks completely different here. Thank you. Thank you. So these are the various procedures which I just mentioned. So with regards to the cranial surgery, the infection incidence SSI risk rate can vary from 1 to 24% with regards to craniectomy procedures. And for craniotomy, it can range from 0.3 to 12%, depending on the setting. This is reported in the literature. For sinus surgery, the endoscopic transsphenoidal approach has a higher risk of SSI, which ranging 3 to 7%, whereas endoscopic endonasal surgery has much lesser SSI rates, ranging from 1 to 3%. With regards to spine surgery, in the literature, when there is a hardware being implanted, the infection rates can be as high as 7%, and when it's without hardware, it is less than 2%. With regards to device insertion in neurosurgery, for the ventricular shunts, adults around it can be as high as 17%, and for pediatric population, it is reported to be around 5%. Ventriculostomy with the use of drains has the highest risk of postoperative ventriculitis. With regards to the insertion of external ventricular drain, it ranges between 2 to 22%, and for the lumbar drain, approximately 5%. And for DBS, it is less than 1%, and for spinal cord stimulators and medical pumps, it is less than 5%. So the risk factors vary based on the surgical technique, and this is a recent meta-analysis systematic review data which was published in American Journal of Infection Control in June 2024. The strongest predictor which in this meta-analysis which was brought about was the CSF leak, which was linked with surgical site infection with an odds ratio of 8.9. The other significant risk factors which were identified was infratentorial surgical technique, surgery undertaken on an emergency basis, when there is a re-intervention which has occurred, and when there is a prolonged operative time. They didn't mention what is the operative time, but many of the studies do mention when the operative time crosses more than 4 hours, the risk of surgical site infection as well as organ space infection increases. Hospital length of stay, both preoperative as well as postoperative stay, increases the risk of surgical site infections as well as meningitis. Similarly, insertion of intracranial pressure monitor also increases surgical site infection risk. No statistical significance were observed for gender, nor the body BMI or obesity, diabetes, and more importantly, I would like to point out that antimicrobial prophylaxis was identified as a not having a statistical significance on which antibiotic is being used for prophylaxis. Patients on immunosuppressive drugs were not found to be at risk of surgical site infections, and also use of artificial implants. But there have been reports on suggesting these as risk factors too, but the meta-analysis suggests that none of these are statistically significant. With regards to spinal surgery, where the meta-analysis, this was a little while back, published in World Neurosurgery in 2019. This was based on 27 studies, and the strong association was found with diabetic patients. Similarly, obesity. None of these were actually observed as a risk factor in craniotomy, while for spinal surgery, these are risk factors for SSI. Similarly, hypertension, operative duration of more than 3 hours were linked with increased SSI rates, and perioperative transfusion was also found to be having a strong association with surgical site infections. For spinal surgery, there was no statistical significance reported in this meta-analysis for gender or elderly age group, or even smoking, or the use of autograft or allograft. Here also, no prophylactic antibiotic use choice did not affect the SSI rate, also steroid therapy. With regards to the endoscopic transnasal surgery, now this was based on exposing the intradural space. So the reported SSI rate was 2.3%, and all the SSI which was observed in this study was had occurred in the surgeries where the intradural exposure had occurred. And they had also classified it based on the Esposito's grade of intradural tear. And they found that grade 2 and 3 had a higher risk of approximately 5.6 to 5.8% of SSI and meningitis. meningitis, postoperative ventriculitis. The significant risk factors identified in this study was a higher ASA score, that is 3 or 4, had a higher odds, that is 20 times higher odds of developing meningitis. Postoperative CSF leak was also linked in this study as a high risk factor for postoperative ventriculitis. BMI was a significant risk factor, and malnutrition was also a significant risk factor for meningitis following endoscopic transnasal surgery. Coming to the risk factors for the external ventricular drain, which is one of the most common device insertion in neurosurgery. This meta-analysis again was published in the year 2023 in Neurology Clinical Practice. The significant risk factors which were identified was intraventricular hemorrhage or subarachnoid hemorrhage. There is an associated systemic infection in the patient who has undergone the surgery. If there is an indication for the catheter has been changed recently, there is 5 times higher odds of the patient developing infection. Bilateral EVDs had a higher incidence. Similarly, CSF leak in here also was linked with increased rate of postoperative ventriculitis. The EVD placement, when it crosses more than 7 days, was linked with 4 times higher odds of development of postoperative ventriculitis. There are various studies which show that use of antimicrobial impregnated catheters do reduce the incidence of postoperative ventriculitis. Some report that there is no such evidence, but the meta-analysis, they show that there is a slight reduction with the use of the silver-coated or antimicrobial impregnated catheters. No statistical significance was shown for diabetes or steroid use or even prophylactic antibiotics in this meta-analysis. This was one of the interesting article which was published recently in Surgical Neurology International, where they found that the length of preoperative stay was one of a predominating risk factor for surgical site infections in neurosurgery. This was a cohort study, and they found that when the threshold of a patient staying more than 5 days in a hospital preoperatively increases the odds by 2 to 3 times for getting a SSI or meningitis. So based on the risk factors which are reported in the meta-analysis, we can classify them as modifiable and non-modifiable ones. And the modifiable ones are the ones which can be addressed. The key prevention strategies would include, based on these risk factors which identified, are how to optimize the patient comorbidities preoperatively itself, because in some of them, obesity and diabetes can be a risk factor, and how well they are managed before admission. And reduce unnecessary preoperative stay. And as per the evidence, it is said that reducing it to 1 to 2 days before surgery is the best, and ideal is less than 5 days, so that the patient doesn't get colonized with multi-drug resistant organisms which are prevalent in the healthcare setting. Intraoperative technique, the most important one is the CSF leak. So the meticulous dural closure is something which is supposed to be aimed so that we can reduce the CSF leak in the postoperative period or during the intraoperative, and minimize the intraoperative duration also by efficient technique, learning by the residents using mannequins, etc. Monitoring of the postoperative wounds vigilantly, again, to early identify the CSF leaks in the postoperative period is also important to address and mitigate these risks. Now, infection prevention and control stewardship is one of the pillars in reducing the risk. But when an infection occurs, the mortality and the morbidity is high. There are studies reporting that the morbidity is like the ICU stay duration can increase by approximately 10 to 15 days, and the total hospital duration stay can increase by almost 20 to 30 days, which can increase the costs for the hospital as for the patient. And once this occurs, the next menace is the antimicrobial resistance, because in developing countries like India and Southeast Asian region, it's predominantly, or 70 to 80% of them are gram-negative bacteria, which causes these infections, unlike the reports which are observed in US and Europe, which are predominantly gram-positive organisms. So the question comes whether whatever antimicrobial resistance which we see is a one-way phenomenon, or can we reverse it or so? So this was a hypothesis which we had in mind, and we did a study introducing interventions on antimicrobial stewardship measures by introducing certain policy changes with the use of prophylactic antibiotics as well as the therapy also. So we did introduce a robust antimicrobial prophylaxis policy based on the available literature, and it was not a universal prophylactic antibiotic which can be given for all the procedures. It differs between the procedures. So we introduced a diverse antimicrobial prophylaxis policy in our for each of the categories of surgeries. And we did notice that when we compared the before intervention and after intervention effect on the antimicrobial resistance on all category of gram-negative organisms, which predominantly cause the surgical site infections and postoperative meningitis. You may notice that the dark blue are the before intervention ones and the light blue are the after intervention ones. Most of the beta-lactam antibiotic susceptibility had gone high once during the after intervention period. This was observed for almost all gram-negative bacteria. So this is for Klebsiella, and in our setting, Klebsiella pneumonia was the predominant pathogen causing the surgical site infection and postoperative ventriculitis. So we did observe statistically significant increase in the susceptibility rate to most of these antibiotics, so that we could change the antibiotic policy with regards to use of narrow spectrum antibiotics when an infection occurs. So this is for other Enterobacter and non-fermenting organisms like Acinetobacter. Again, there was statistically a significant increase in the susceptibility, helping use of these beta-lactam antibiotics, which were thought will be not useful in scenarios of postoperative ventriculitis. So we also had an ICMR collaborative study on CSF diversion-related catheter infections, that is on shunt and drain-based infections. It was a 2-year cohort study. So we did analyze the risk factors which occurs in this cohort of patients. And this is what we found. Increased infection risk for EVD infections were observed when the drain remains in situ for more than 7 days. There were 11 times higher odds. When there is a CSF leak, there were 17 times higher odds of a patient developing postoperative ventriculitis. And if the ASA score was 3 or above, similarly, when the patient had perioperative scalp infection, there was a 3 times higher odds. We also observed that posterior insertion points, when being used for drain insertion, etc., like the dandies, etc., there were 9 times higher odds of a surgical site infection and postoperative ventriculitis. Negative association, we did find that reduced CSF sampling frequency via the drains. So this was sometimes practiced to see whether the culture is sterile, etc., along with the biochemical analysis. So once we reduced the CSF sampling frequency, there was a reduction in the SSI and the meningitis rates. We also observed that when the policy changed from a use of broad spectrum antibiotic as a pre-surgical prophylaxis to narrow spectrum antibiotics, we did find that the infection rates were much less. But we find that there could be confounding factors for this because it was not reported in any of the literature. So we didn't stop there. So once we identified the risk factors at our setting, we wanted to know, or we want to design a care bundle for external ventricular drain and lumbar drain insertion based on the identified risk factors. So we use the comprehensive flowchart of the Institute of Healthcare Improvement, and based on the identified indigenous risk factors as well as the literature review, we chose the modifiable risk factors, and based on the consensus decision by the multidisciplinary team, we selected the most important steps for the insertion as well as the maintenance care bundle, choosing only the level 1 evidence. So this was the care bundle we proposed for both the insertion phase as well as the maintenance phase for the drain insertion. I'd like to end that one of the objectives in the study was also to use CSF biomarkers to early detect ventriculitis So we did study 5 biomarkers in this study. 2 of them are well known, used in sepsis, that is the procalcitonin and presepsin. We did study this in the CSF. We did study also 2 interleukins, that is interleukin 1 beta and 17A, as well as the CSF lactate. All of them were statistically significant to detect early postoperative ventriculitis. The cost benefit, when we just broadly checked the cost benefit analysis of all the 5 biomarkers, CSF lactate was the cheaper one, but you can see that the accuracy as well as the area under the curve based on the ROC curve analysis is much high compared to most of the other biomarkers. But again, we are yet to introduce this into the routine to see whether it does significantly reduce the time taken to diagnose the infection. Thank you for listening. I would love to address any questions if any.
Dinup, that is a very nice presentation and showed a lot of original data. It's very good. And I think he's shown the way that every department should conduct an audit on the infections and try to develop their own antibiotic protocol. Any questions or comments? Please keep it brief.
Yeah, I am.
No, but he's a microbiology specialist. That's why he's looked at it from a different point of view.
Whenever the CSF drainage is required, not for monitoring purpose, or if for any other purpose, put a EVD here in the frontal, remove the chamber, tunnel it down in the abdomen. 0 infection in the last 5 years.
Yeah,
not even a single case.
Yeah, that's well known. If you increase the length of the tunneling of the EVD.
And we keep it in the abdomen, we close it out. Now suppose you remove a EVD, the same way you just open it from here, pull, both the catheters will come out very easily. You hold a connector and pull it out, it comes out very easily.
Yeah.
And in case you require a shunt, you need not do a second procedure. That same tunnel works as a shunt also.
That's true.
Thank you, sir.
I think with the tunnel, I think tunneling distance, if it is more than 5 centimeter, then it reduces the propensity for a surgical site infection and postoperative meningitis.
Congratulations, your data was very good. I just have one question. In our series from our institute, led by one of the neurosurgeons themselves, in the first 3 days, we had markers were all inflammatory and non-infective. And the infection rate immediate post-op starts to increase from 4th day onwards. In your series, did you see anything of such that?
Yes. We do correlate that with we use the IDSA criteria to label whether the patient is developing ventriculitis or not. It is in the early stages, it is difficult to differentiate whether it's just a colonization or contamination. We do correlate with the biochemical parameters, that is sugar, glucose means protein, and the cell indexes. So they tend to give a early predictability whether the patient is progressing to infection or not, along with the culture report. So we classify them based on whether it is colonization, contamination, and further, if it is ventriculitis, whether it is definite, probable, or possible based on the culminating all of these together. So it does take time. So that was one of our objective, that can these biomarkers be used to predict? And we have obtained the ideal cutoff value to predict the diagnosis of ventriculitis, but it requires multicentric trials or multicentric studies to validate that.
So in one of the slides, you had mentioned that diabetes, post-craniotomy infections, diabetes wasn't a risk factor as per the meta-analysis.
Yes.
But generally, for all of us, uncontrolled diabetes, we do know predisposes people to infection. So I'd like you to elaborate on that.
Yeah. So in our cohort study, which was for 2 years also, we didn't find a statistical significance for diabetes at SET-IMST. But even in the meta, there are few reports which do find that diabetes could be a risk factor. But again, the meta-analysis concurred with what we also observed in the SET-IMST, that diabetes is not a risk factor. Whereas for spinal surgery, it has been observed that diabetes is. So I think based on these risk factors, I think the risk mitigation can be planned accordingly for the various category of surgeries.
Hi, I'm Gopalakrishnan. I wanted to know what is the prophylactic antibiotic that you use in your department?
Okay.
and what are the implications? Because what is the prophylactic antibiotic?
So so right now the agreed upon prophylactic antibiotic is a second generation cephalosporin, that is cefuroxime. So that is what we are currently using. And
Cefazolin that is supposed
yes.
to be used?
So in US, in American countries, the most preferred one is cefazolin. I think that is the first generation cephalosporin, and the reason for choosing that is probably because of the more of gram-positive nature which is observed in their scenario. Cefuroxime has a means action on both gram-positive and gram-negative, and is a little more relevant. So there are most settings do use cefuroxime. There could be a question whether can we go for more higher antibiotics like ceftriaxone or meropenem, etc. But again, using those broad spectrum antibiotics leads to colonization with multi-drug resistant organism in the patient.
Why I asked is the ideal antibiotic for a prophylactic setting is cefazolin because it protects against the skin contaminant which is supposed to come. But
Yes.
in vast majority of the hospitals in India, it is ceftriaxone which is used.
Yes.
Which could be causing the antibiotic resistance and
Yes. So in fact, in our cohort study also, there were time periods where there were third generation cephalosporins with or without other additional antibiotics were used also. So that's why we had to bring in a policy for use of narrow spectrum. And we did find statistical significance when there was a shift to narrow spectrum antibiotic from broad spectrum antibiotic use.
Thank you, Dr. Dinu.
It is available, sir.
It's not available.
We do use it for treatment of infective endocarditis and Staph aureus bacteremia, cefazolin. Yes, yes. Cefuroxime is still a good choice, not affecting the antimicrobial resistance pattern.
Also, I think
yes. So now, if at all postoperative ventriculitis does occur, we get a scenario that still we can use meropenem, etc. So confidently as an empirical regimen. So there are settings, yeah. So we did, yes, I did one. We did have a stage where we had to rely on intraventricular and means combination of IV and intraventricular colistin to treat means patients with postoperative ventriculitis. But as the antimicrobial prophylaxis was introduced and the susceptibility rates increased, we could actually change our empirical antibiotic policy to carbapenem use as an empirical regimen. So I think over time, as we tend to use it appropriately, we'll be able to bring in the third generation cephalosporins, etc., also for therapeutic purposes into the routine.
Last question.
Yeah, regarding the use of newer markers in CSF to detect ventriculitis or meningitis, we know that, for example, after neurosurgery, CSF lactate can,
yes.
One is how sensitive is it in post-operative setup? And second, is there a cutoff duration before which the sample has to be received in the lab so that the data is still valid? For example, glucose, we know that if you keep it for a long time, then glucose comes down.
The ideal is the immediate transport to the lab. So with regards to the culture, it does affect, the transport time does affect the culture viability as well as the retrieval. But with regards to the biochemical biomarker analysis, I'm not sure about how it affects. But at any point of time when we do this, means when it is clinically relevant, it means the biomarker, we have not studied whether in a normal patient, how does this lactate level fluctuates. Second.
Blood contaminating.
Yes. So what we did is, yes. So we had negative controls also, where patients who didn't have any bloody tap or presence of RBCs in the blood or other tumors, but didn't have meningitis, etc. So we had included that also in the analysis to arrive with this cutoff value. But again, we feel that multicentric studies will be required to really validate and bring into clinical use.
Thank you, Dr. Dinu. I invite the next speaker, Dr. Vikas. This is a debate, the rise of digital surgeon. Will AI replace neurosurgeon? This is a debate between Dr. Vikas, who will talk for, and Dr. M.S. Gopal Krishna, who will talk against. I request Dr. Dinoop to come on stage to receive the memento.
Respected chairpersons, Dr. Sarita, Dr. Sumit, thank you for inviting me here. It's an honor being here in this very special occasion. So the topic is difficult because I'm supposed to defeat, it's a self-defeating topic, rise of the digital surgeon when you yourself are a human. So I had to change the topic slightly. The tagline is changed. AI will change neurosurgery. I'm not saying the rise of the digital surgeon and all that because it may turn out to be counterproductive. And especially it's with a very esteemed colleague who's a master speaker and erudite scholar. This is a statement which I would need you to remember at the end of this talk. So that's the key. So the future ain't what it used to be, and it is changing so fast that we are not even able to grasp what is future, what is present. We distinctly know what is past. So I'll take this few minutes only to rush through. Yeah. So rush through where all things can change in neurosurgery and where all artificial intelligence robotics can make a difference. So if you look at this particular cycle, this is something which is common for all kinds of patients in all kinds of specialties, but we'll look at how things can change in each part of this cycle. So what are the issues if we look at today in terms of application of technology in the practice of neurosurgery, both at the clinical bedside and at the OR? So you can say that these are the technologies which can be available at these places. What are the issues in regulation? And when we speak about regulation, we are looking at the increased presence of robots which have increased levels of independence, increased levels of AI in the clinical decision-making process. So you have to distribute your decision-making between yourself and an entity which you do not even know how it works. And the last part of it is, of course, the acceptability. How are your own colleagues and yourself accepting these things, these changes? And how are patients expecting and anticipating and actually molding onto the whole scenario? So these things are dynamically changing. About 20 years back, if you would tell a patient that a robot is going to operate you, they would say, no, I want a good human surgeon. But that's not the case in majority of the surgeries, especially in this abdomen, where people distinctly look for robotic surgeons, though they don't figure out actually that the robot has very little things to do. So these are issues which are now in discussion. So technology is the last thing which I will handle. So you can have AI in various parts of this. So at patient contact, follow-up, investigations and surgery, and I would not bore you with details of how it can be done. I'll just show you examples of what is possible. And that is actually very interesting. So let's do a thought experiment. Can we evaluate the neurological function of a patient, clinical examination of a neurological patient remotely? Very simple thought experiment. You think through each part of this of the clinical process and try to figure out a sensor-based approach by which you actually evaluate the patient from a distant place. It can be from across a continent. You can extend the logic into patient being in space and you have to evaluate an astronaut. So I just ran through that myself and I found that taste might be the only thing in which I would actually have a lack of confidence in the person not being able to say. Because all other things you can think of something which can, including pupillary reflex, vision, directions, even temporalis wasting can be detected through very basic image software. If you look at the motor system, it becomes a bit interesting that I felt that tone, unless you have dedicated machines for it, is just about the only thing which you cannot find out. There are very basic gym equipment which can do a lot of the other things. Superficial reflexes are really difficult unless you have some very strong robotic device. Deep tendon reflexes are also in that. So that's the reason I put that in red. In the sensory system, I felt that apart from pain, most of the other things can be automated. So, it's just a thought experiment, but you can just think over it on your way back home after this session, and you would really find it that, you have stuff on this in the boundary of our everyday life. It becomes a little more complex when you think about remotely imaging. Just imagine a machine is there, patient is there, and you want to do it like that, and you can actually do MRI and CT. You have got a gantry, you can automate the entire workflow of getting into an MRI. Very easily doable. Ultrasound is a bit tricky because it's still operator dependent, and of course, our applications in neurosurgery are not all that. So what I've done is run through the entire clinical workflow. I don't know if you've seen this. There's a blood drawing robot, and it's a commercial robot. I'm not even saying about research robots, which are usually across the place. It looks wonderful. It's available for sale, and it's just about 2 weeks or so. But I've been aware of this technology for nearly 8 to 10 years. We've explored this possibility in our team also, but right now there's a commercial robot which can do phlebotomy and give you blood. So it becomes trickier with lumbar puncture. I can't figure out something, which can do lumbar puncture. Neuronal function EEG is done, pupillometry is done. So what's left behind for humans is just about a lumbar puncture. When I speak about regulation, it's an important topic because the technology for a lot of robotic procedures is already there. It has been there for at least past 10 years, easily. And simple things like, say, for example, DBS. DBS is already a very automated process. It's very objective, it is very automatic, and everybody does it exactly the same. But why don't we have fully autonomic DBS systems? Why don't we have fully autonomic spine implant systems? That's because of the regulation. You need to do a full clinical trial instead of a 10K for such a device. In most of the devices, the trend now is that you have a device, you put a little bit of AI to it and show it as an improvement instead of having a new device which is completely different from whatever exists in the market. So regulation is actually guiding the technology. It is not that technology is guiding regulation or adaptability use. So a lot of economics works into it because when a company decides to put up a new product, it is going to go through the 510K than doing a full clinical trial for a very autonomous system, which of course is again of dubious use. So that's the point. So incremental steps is what's the tradition. But interestingly, there are things with full autonomy. Apparently the R1 robot, if R1 is from Neuralink, it apparently does, I'm not sure of the skin incision, but the entire bunch of processes downstream is done autonomously, and they claim, I think, level 4 out of level 5 autonomy for this device. So of course, it's a very specialized device. That machine does only one single robotic procedure. So if you look at the entire textbook of neurosurgery, you would need about 10 to 15 robots to fulfill the entire bunch of stuff, bunch of procedures. Oh, I finished. So I'll speed up through the rest of it. So clinical evaluation, so competence is a point of question. Liability is a major discussion because there is always this to and fro who shares the responsibility of a problem, whether it is the machine or this one. So if you look at surgery, the R1 robot has very high autonomy. Spinal implants should already have been done, but it is because of other reasons. That is basically regulation, which is preventing these things from coming up. So a brief discussion on technology, and I promised you to show changes. So artificial neural networks, everybody knows, but transformers, how many people actually know what a transformer is? So the transformer is the technical term for ChatGPT, Gemini, Claude, and all the bunch of this. The technology is that, and world models and the next stuff. So I won't elaborate too much because of lack of time. So is it possible? So we can actually get sensor data. So this is the experiment of a robotic setup in which you track instruments. You get information from the instrument, look at parts. This is an overlay of an ETV. So you do tool recognition. That's the probability of it getting right tool. And this is tissue recognition, the floor of the third ventricle marked, and this is an overlay. And this is a video with the overlay of a machine actually documenting what parts of the anatomy are getting negotiated. And the interesting thing is this is 3 years old. So current work is going on two neural network architectures. One is, I call it as phaser, and the other one is the GSolve architecture, which is transformer. So let us look at what's going on. A transformer basically does a lot of things by itself, and it does it single shot, near single shot. Single shot is you do not have to train a large amount of data and get to work. So here is an example of very small size, vocabulary size of 82, in which it is able to do translation. Okay, in English to Kannada, English to Hindi, and interesting Kannada. Of course, the language is something. A transformer, you give a prompt, small, vocabulary size is 123, tokens is 17,000. Usual tokens are in the range of millions. Gemini is, I think, is about 10 million tokens. So it's a very small micro transformer model. It shows that the first presentation, the patient presented with, it generates text. Okay. How does that same model, see, I've shown you translation, I've shown you what's that, some text generation. This is an example of an MRI image with a tumor sitting over there, and it is supposed to just decide upon sight. And remember again, very small numbers of data and computing power. A more interesting, so higher level of this system. So this is, that was GSolve 1, this is at GSolve 4. For an interesting prompt, a meningioma is. It's basically trained on English and Yeoman's textbook of neurosurgery, nothing else. No other clinical information. But just look at meningioma and look at chordoid mitosis. The ability to recognize things internally without actually being trained to look for things is the power of a transformer. And we are just starting at it. And these are all home work projects. So what's happening is we are having incremental, slow, and sustained invasion of AI. We need to adapt to that. And it's a definite process. As I showed you, if I am doing this, there are bigger people in bigger companies with larger amounts of money who can do much, much more. Thank you.
Thank you, Dr. Vikas. We call the next speaker to talk against Dr. Gopal Krishnan.
For this strange talk, and it is the last talk, so you can all go home. So Vikas has made a compelling argument that AI is really invading, although he did not claim that it will replace us. So I am going to take a position that, can we go into the slide? Yeah, okay, then I'll have to scroll. It became a PDF file. Okay, I'm going to take this stage that it is never going to happen. Okay, ever going to happen. So the question of whether digital surgeons will replace neurosurgeons is not going to happen. But given infinite time, just about anything can happen. So we need to have definitions. What is the time span we are talking about? So is it 10 years, 40 years, or 100 years, or 1,000 years? So I would take 40 years, because if a young neurosurgeon who has taken up residency, he doesn't want to leave the course because it is going to take over, then we would take 40 years as the career span, during which time the AI or the digital surgeon should not push you out of your job. And then we define what a neurosurgeon is. So let's have a definition of who a neurosurgeon is. A neurosurgeon is a physician who assumes responsibility for performing structural modifications of the nervous system. So I am not sure, although I think he's a neurosurgeon. In trepanation, is he a neurosurgeon? He's not a physician. Hopefully the physician is an MBBS doctor. And then there is Cushing, then there is endovascular guys. And on the right, Dhirendra Prasad is sitting in front of a computer screen, sending photons to the brain. Is it really neurosurgery? Most of us will accept that it is neurosurgery, although there is no structural immediate modification of the brain. So the most important word here is responsibility. This is the first time I'm scrolling this one. So if neurosurgery is just a game, the question is, can machines solve it? Can we invent a powerful computer, powerful enough to solve any game? Brute force a solution. So there are 3 deterministic games here and 1 stochastic game. Deterministic games have rules and the outcome is clear. A stochastic game is where there is chance and luck. So we know that in tic-tac-toe, even a human being can solve it because there is only 10 raised to 3 positions. In the case of checkers, which was solved in around 1970s, there was 10 raised to 14 positions, that is different games. It is also solved. Now the question comes chess. It has got 10 raised to 47 positions. And interestingly, it cannot be solved. Now poker is a stochastic game. So neurosurgery is infinitely more complicated than chess. But even chess has got 10 to the power of 120 game positions. Even if you convert every atom of this universe into a computer, it still cannot solve all the positions. You cannot brute force chess. It cannot be solved. Then what is the question of solving neurosurgery, which is infinitely more complicated than chess? Now, complex systems can fall into 3 levels. Deterministic and small, that is solvable, tic-tac-toe. Deterministic and combinatorially explosive, which combinatorial processes become so huge that it is theoretically solvable, but practically never. And then there are stochastic chance games like neurosurgery, medicine. It cannot be solved. But then you will argue that don't machines play better than this man, Kasparov? He got defeated by Deep Blue somewhere in the 1980s, I think. But then as complexity increases from chess, humans continue to dominate. Neurosurgery is messy, it is complex, it is unpredictable. Brain shifts, bleeding occurs, pulsations occur. So it is an infinitely complex game compared to chess, and artificial intelligence cannot possibly take over. Now we have seen those dancing robots. You would have seen in WhatsApp, and there is Atlas that backflips. So you may think that, okay, robots could somehow, if it can assemble sub-micrometer computer chips, why can't it do micro-neurosurgery? Isn't it? A toddler bot should be able to do it. But then chips are not assembled. They are fabricated. They are photon lithography or ion manufacturing in a 2-dimensional plane. These are highly controlled atmosphere in which the robots function. Micro-neurosurgery is 4-dimensional. Bleeding, pulsations, brain shift, everything happens in that time. And there is an ever-changing biology, tumors change, there is innumerable variations, and it is messy anatomy. Then what about the human hands? Human tactile sensation and resolution is unparalleled. The human hands are the pinnacle of evolution on this planet. The tactile sensation is 17,000 mechanoreceptors on the fingertips, orders of magnitude greater than any robots. Robots may be able to repetitively do precise activity, but our hands adapt with our judgment. A possible counter-argument would be that there are modern reinforcement learning systems already able to adapt to a deformable environment. So there are soft robotics, and robots learn from simulation. So why can't they do neurosurgery? The argument against that is that in reinforcement learning, which is a form of artificial intelligence, reward function is clearly defined. The state space or the condition is always observable and estimatable. Exploration is permitted and trial and error is possible. And a large training data exists, although he mentioned about the one-shot training. Failures are acceptable. But in the case of neurosurgery, we do not know what is the reward function. Is it the 5-year survival rate? Is it the residual tumor that is left behind? Is it the quality of life? It keeps changing. So the reward function is neither scalar nor defined. Now, what about the hidden structures? There are so many structures behind the visual, the available visual field. Something is laying there. You yourself don't know what is happening there. and there is edema, shift, bleeding, and exploration and trial and error is not possible. Of course, you can argue that you can have thousands of goat brains in which the computer or the robo can do its practice and fail and then learn from it. But failures, again, will happen in a human brain. So there are no millions of surgeries and game which is available for the computer to learn. So it has been 26 years since the Da Vinci has come in 2000. Yet we still do not have a single autonomous robot that can even insert an IV line. So what about neurosurgery? So it is not going to happen in our career, hopefully. A human will always be in control. We see that there is always a human in the loop. Even in the most advanced fighter jets, there will always be humans under the chassis, under the cockpit. There's going to be a human in the loop. So even the most advanced fighter jets are not automated, although there are drones. So then we come to the most important point, human responsibility. The society is not going to give structural modification of the human nervous system onto a machine. So haven't professions disappeared? What is common about these professions? You would have seen this is a switchboard operators, then there is a coachman and elevator operators. If you see carefully, these are repetitive operations. They are very deterministic. If you push a button, it has to go to the 3rd floor. It cannot go to the 30th floor. So these are sometimes the switchboard operators. I'm not saying that the switchboard operators are doing a dumb job. They are actually quite a skilled job in which you have to listen to the conversation, quickly put the plug in. But then these are repetitive steps and can be algorithmized. But in the case of a coachman, there is a totally different thing has happened. The technological substrate itself has changed. The horse has disappeared, the engine has come. So I'm coming to 3 points why it will not happen. Irreducible complexity of the computational load, dexterity and tactile supremacy of the human hand, and then the fact that we have to take a responsibility. So we will constantly get augmented with technology, digital and robotic. We will perhaps have different ways of interacting with machines. Maybe we will have brain-computer interface. We will be operating with just thoughts. We'll be lying in some pool, getting our thoughts out. Or maybe we'll be sitting with a coffee cup or a teacup, whichever you prefer, and the machine will be doing, but we will be operating with a brain-computer interface. Thoughts become actions, but still we are in control. And the residency of the future might be over in a few seconds. You're uploading your entire neurosurgery skills onto the brain. That's also possible. So replacing neurosurgeons is not just about robotic dexterity. It would require systems that can reason under extreme uncertainty, integrate evolving biological information, and when there are catastrophic rare events, and these events do happen, you have to navigate those events. And we have to obtain meaningful consent from the patient and his relatives regarding these things. And finally, assume responsibility for irreversible outcomes. That requires a level of AI that is not seen anywhere. The current narrow AI systems can never do all of these things. So technology will not replace the neurosurgeon. It will only augment us. Thank you.
Thank you, Dr. Gopal Krishna. I think you reassured us. The
Yeah.
take-home message is 40 years, it's not going to replace us. So I think most of us will retire by then. Dr. Vikas, do you want to contradict him?
Meaning, GK has been my teacher at one point in time. I don't know if he remembers that. But both of us actually, ironically, we've not shared presentations. In fact, we wanted to share presentations, but we didn't share presentations. It sort of converts to the same philosophies at least, but the directions are completely different. And I think I would request Dr. GK to be enlightened with transformer technology, at which you would have a one of those under the banyan tree moments, because the technology is really unexplainable. The people who developed it don't know what's happening, but it does things like what I showed you. All of those things are real. They are not hallucinations. They have been done and in my own home. So the code is about just 500 lines. 500 lines of code doing translation, word generation, logic, association is unbelievable. It's just a matter of time.
Yeah. At all points in time, we have been blown away by technology. I think when calculators came, people would have been amazed how it can find the square root of a huge number. Similarly, things will surprise us. But if the question is that a machine is going to take over and do all your job, and then you have to leave this field and go and work somewhere else, that might not happen. At
I
least.
agree with that with a slight difference. So what's the point of doing all this stuff? Why am I still practice neurosurgery? So why am I doing it? Even in our day-to-day practice, there are scans which we don't understand. It's almost daily, it's not once in a while. After years, decades of experience, you still find it a daily phenomenon that you see some stuff in an MRI which you never able to understand. You have a lot of patients whom even now we say are inoperable. If you have multiple lesions, inoperable. If you have stuff in the brainstem, inoperable. They look nice on scan. If the same thing is in the frontal lobe, you would say operable. So there's a lot of stuff which is inoperable. What these things would do is to extend your boundary to those levels. It's not replace, it's extend. I think that's the place where I would like to.
I have no argument against extension. We will extend.
So he just meant augment.
Yeah,
So
we augment.
He's agreeing with you.
Yeah.
Basically.
But in ways which are way beyond. It's already crossed a lot of limits. I think anybody watching stock markets in the past 15 days will know what impact things have. And the irony is the technology is 2017. We are already 9 years down the technology and things are exploding now. Same stuff. There has been no change for the past 9 years, but things have changed in the past 2 to 3 months based on those things which were there 9 years back.
So the floor is open. If anyone wants to ask.
I think everyone is tired by the end of the. Thank you. Anyway, thank you, Dr. Vikas and Dr. GK, for that very nice and interesting talks that you gave. With that, we close this session.
Yeah, I'd like to request Dr. Sarita to kindly present a token of our appreciation to Dr. Vikas and Dr. Gopalakrishnan. And lastly, another memento for Dr. Rakshit. Okay, so that brings us to the end of today's scientific proceedings. I'd like to now ask my colleague, Dr. Sanjay, to deliver the vote of thanks on behalf of the organizing committee.
Good evening. Today was a very fruitful day with a lot of great discussions and presentations. My sincere thanks to all the speakers, panelists, and moderators who have made the conference a great success with their invaluable contributions. I would like to offer immense gratitude on behalf of the department to the director of Satya Sai Institute of Higher Medical Sciences, Dr. Sundaresh, for his encouragement and support. There are many within the department who have worked tirelessly for the past 6 months, be it the residents, be it the consultants, including the senior consultants, the department managers, and this particular week, it has been senior staff nurses who have coordinated the students and the junior nurses in order to make the whole process very smooth. I'd like to thank the AV team who have stayed back very late last night to make sure that all the presentations have been loaded and that the process can be smoothened to avoid as many glitches as possible. In the end, I thank the audience for staying till now and for being very encouraging, and we had a lot of interactive sessions. So I thank the audience and thank you all. Thank you very much for making this a success. Thank you. Yes, ma'am. The people from the alumni, we will contact you regarding the meeting. Thank you. It would be great if some of you, if all of you could join for a group photograph. Thank you. Yes, sir. Please, if you don't mind, please let's assemble at the dome area where we'll have a photo.